And our chairpersons, Dr. Rajiv Gupta, Professor Dr. Ratnesh is there, Sunil Kumar, Jai Siddiqui, Bharat Singh, Abid Akhtar, Vipul Kumar. Abid Akhtar is there. Kumar.
Yeah. Good morning.
So are we live? Should we start?
We are live, ma'am. We can start.
Okay. So good morning, all. Good morning. It's a pleasure and honor for Jharkhand Ophthalmological Society to welcome all the esteemed guest faculties across India of national and international fame. We have selected this time an array of top 21 stalwarts across India who are heading their subspecialty along with the eminent speakers from Jharkhand. We have kept very innovative sessions. This time, what's ideal, what's practical session is being organized in our midterm conference, first time across India. And what in cataract surgery, the brainchild of Srini, top mistakes in glaucoma, these are also very innovative sessions. Jhos is a small society, but its impact is always felt nationally. Recently, we got recognized at annual conference of AIOS with the Presidential Award for being Best State Society in the category of 100 to 500 members. This was given to us for the best CME activities, best PG training activities, and best public awareness campaigns, which we conduct throughout the year. In 2019, AIOS ARC Jhos se Jhos Jalao campaign for diabetic retinopathy screening, we provided the maximum data across country, and our society was felicitated by AIOS president in annual conference of AIOS at Gurugram. So now I request President Jhos, Dr. Rajmohan sir, to address all the viewers and inaugurate the 21st midterm conference of Jharkhand Ophthalmological Society.
Thank you very much, Chairman. Good morning. Namaste. Dohar. On behalf of the Jhos, and I extend a very warm welcome to all the members, the esteemed faculty members, and viewers to the 21st midterm virtual conference of this society. The CSC, the Chairman Scientific Committee, has meticulously planned a very innovative program. I'm sure it will be a fruitful learning experience. It is on the virtual platform, which can be accessed anytime you like. So, as already most of the good things that the chairman has already spoken, so I'll not take time. I'll just state that our Jharkhand Ophthalmological Society is a small society and is making presence felt at the national level. And all the achievements have already been stated. And now I inaugurate the 21st midterm conference of the Jharkhand Ophthalmological Society. Welcome, everybody.
Thank you, sir. Thank you so much. And now I request Professor Rajiv Gupta, sir, who has joined, and he is the Dean and Director of the most prestigious teaching institution of Jharkhand, that is Regional Institute of Ophthalmology, RIMS Ranchi. So, Professor Rajiv Gupta, address the viewers and all the guest faculties.
Hello, good morning, everyone.
Good morning,
Am I
sir.
audible?
Yes, sir. Yes, sir. Yes, sir.
Good morning to everyone. And I wish all the success for the 21st midterm conference organized by Jharkhand Ophthalmical Society, Dr. Bharti Kashyap and Dr. S.K. Mitra, under the guidance Dr. Raj Mohan, has done a very hard work for this conference. Hope everyone will get benefit from this CME. They'll get their knowledge enhanced by this CME.
Sir,
and I wish all the success for this CME. Thank you. Thank you, Dr. Bharti, Dr. Raj Mohan, and Dr. S.K. Mitra, sir.
Thank you. Thank you, sir. Thank you very much.
Sir, the session 1 of this midterm conference is what next situation in cataract surgery. We have our session coordinators, Dr. Srini Ekdalon, Dr. Vibhuti Bhushan, The chairpersons for this session are Professor Rajiv Gupta, Professor Rajiv Kumar, Dr. Ratnesh, they are all present, Dr. Sunil Kumar, Dr. Abid Akhtar, they are all present. And I can't see Dr. Jahiz Siddiqui and Dr. Bharat Singh and Vipul Kumar. Vipul Kumar is there. Vipul Kumar is there. Vipul Kumar is there.
Ma'am.
Yes, yes,
Right,
yes.
right.
Vipul Kumar is there. And okay, our chairpersons and session coordinators are there. So now I request Dr. Vibhuti Bhushan to carry forward this session, and please invite Dr. Srini Agdalon for the keynote address first and introduce him. Slide.
Am I audible?
Yes.
Can you see the screen?
No. Now, yes, we can see.
Make it full screen, please.
Yes. Yes. Now, can you see the screen?
Yes,
also?
yes, please.
Yes,
go
yes,
ahead.
It is my privilege to introduce Dr. Srini Agdalon, although he doesn't need any introduction. He was trained in RPC and he did his anterior segment fellowship from Shankara Eye Hospital, Coimbatore. He is the chief surgeon and medical director and chief cataract and glaucoma services or at Comtrust Charitable Trust Eye Hospital, Thalassery, and Mamtrust Eye Hospital, Kanjangarh. He does a whopping 750 to 850 phacoemulsifications every month in these hospitals. He's the chairman scientific committee of Kerala Society of Ophthalmic Surgeons, and he's the managing editor of Kerala Journal of Ophthalmology. He was a managing editor from 2021. And we just now have seen his organizational skill during recently concluded AIOC at Kochi 2023. So welcome, Dr. Srini Agdalon, and we are really privileged to have you here.
Thank you, Dr. Vibhuti.
Welcome, Dr. Srini.
Thank you, ma'am. Thank you.
We have decided that we will show the entire biodata which has been sent to us, but we will read just to save the time.
Should I introduce the other guest faculties also right now?
No, before they talk, you have to.
Right.
And the discussion will be in the last. The discussion will be in the last.
So I'll stop sharing my
yes.
screen.
So I'll just share my presentation. Hope you can see my presentation.
Yes.
It's full screen, right? Okay. Thank you, Bharati Keshwat ma'am. Thank you, Dr. Vibhuti, for that kind introduction. And it's a great privilege to be part of, to be the opening batsman for the midterm conference of Jharkhand Ophthalmic Society. I had the privilege of being a part of the conference this year, and it's really wonderful, well organized conference of Jhos at Kushalpalli, and everything was good. The scientific content was good. The hospitality was great, and I'm the scientific committee chairman of Kerala Society of Ophthalmic Surgeons, and so this is there have been many situations where I have actually faced uncooperative patients during cataract surgery, and see, it's what basically happens is that even if use enough amount of topical anesthetic, the patient sometimes perceives pain, and as you touch the eye, they keep moving, and the patient is not actually able to keep looking at the light, and so keeps moving. So you're not very comfortable with the surgery, and just during the surgery itself, as you proceed, I mean, as soon as you put the drape, the patient doesn't allow you to do the surgery. So, or midway through the surgery. Midway through the surgery, I faced it a few times. Like midway through the surgery, that the patient really becomes uncooperative. The patient starts coughing and all, and the patient is not really able to cooperate. So we'll just go through each situation one by one. And this is one patient. Like from the beginning, the patient was not really very cooperative, but it's not very uncooperative also, because you can see that the patient is not really squeezing, but the patient is not really able to keep the I steady, but still thought maybe I'll be able to proceed with the surgery. So the incision was put. So there was no much of struggle. Probably because I use two instruments. It stabilizes the globe. So entry made, side port made. So then again, the patient is not able to keep looking at the light, and so this is probably the most crucial part in a topical cataract surgery, the capsulorhexis. So if the patient is like this, it's a very good idea. If there is very good glow, it's a good idea to stay in the capsule, because you might keep losing the glow or whatever. And I use Oculan in all these cases. No financial interest there. But even after using Oculan and not able to really comfortably start the capsulorhexis, so I decided. See, there are two options: either go for peribubble anesthesia in this case, or go for subtenance anesthesia. And so that is what I decided to do in this case. A nick is made in the infranasal quadrant, and using that peribulbar cannula, give the peribulbar anesthesia. So the advantage with peribulbar anesthesia is that the analgesia sets in almost immediately, and see, once that sets in, even if the patient is not really able to really focus on the light, the level of cooperation improves quite a bit, and that's what you can see in this case. The patient is moving, but still with this degree of movement, it's doing capsulorhexis is not that difficult, and so I could complete the exercise properly. And once you start the phaco, that is easy. You have two instruments there. You can easily stabilize the globe and complete the surgery. So this subtenance anesthesia is given in that subtenance space, which is the potential space between sclera and the capsule. And the anesthesia, the nick, you make a nick in the conjunctiva tenons, something like that, give the anesthetic agent there. It's better to give it in the intranasal limbus. That's where I'm most comfortable with. That's it's mostly done, and go 5 to 10 millimeter from the limbus. And so there are a lot of cannulas, a lot of different designs of cannulas available. But the one that I've used all of them, and different gauges are there. So 19G cannula is there, 21G cannula is there, 23G cannula is there. See, all of them work, but that 23G cannula looks a bit more like a needle. But if that's what my nurse gives, I use it. But I prefer to go for that 90G cannula. And all these different types of cannulas are there in my OTs. There is an end opening one with opening on one side, and another cannula is opening on both sides. All of them work. What is most important is the shape of the cannula, which will actually hug the sclera and take that curvature of the sclera to reach that space where you want to actually inject it. So as I said, I prefer that infranasal area, and I don't go very much into the fornix. See, the reason I don't actually really go very much into the phonics is because I've tried. Because one of the problems, man, or probably the only problem in these subtenant anesthesia is that subconjunctival hemorrhage that is seen. So we feel that okay, you go more into the phonics that the hemorrhage won't be seen. I've tried that, but many times I end up in the subconjunctival space when I go more towards phonics. And this is my personal experience, and so I just go more closer to the limbus, but about 5 mm to the limbus. And in these situations, I'm mostly able to get into the subtenant space, and if you are in the subtenant space, the movement is very smooth, and you're able to hug the globe and go in and go to reach till the hub of it. But so the cannula tip actually crosses that equator, and you inject the anesthetic there. So even when you're injecting, if there is a block, you just draw it back and inject it. And if in the initial, after the initial nick, you find the resistance actually in the subconjunctival space, and you have to redo the nick and proceed with the anesthetic. And how much of anesthetic is used? I go for 2 ml only, because that gives me a good enough analgesia. And if you are actually really going in for you want a lot of echinacea, go for a 5 ml injection. And as I said, the only complication that you can have is the subconjunctival hemorrhage, which actually easily clears of most of the cases. You won't see it on the next day, but even if it is there on table itself, we can just say that there's a little bit of bleeding, and we'll see for a few days, and the patient won't really complain. So it's better to have this little bit of redness there than have a stormy surgery. So this actually really helps. The other choice would have been to give a peribulbar anesthesia, which is much more of complication inducing than the subtenant anesthesia. So this claustrophobia is a situation where I just don't proceed with the surgery at all. See, you realize that the patient is claustrophobic, and even the patient realizes on table when you put the drape. As soon as you put the drape, they say, no, take off the drape, take off the drape. You hear that, just take off the drape. You don't, I don't actually, because I burned my fingers at least 2-3 times. You don't actually keep counseling the patient. Okay, it takes only 4 minutes, 5 minutes. I'll finish it off in 5 minutes. You end up doing a 50-minute surgery after that, because you're going to land up in complications. I just take the patient, tell the nurses to take the patient into the preparation room. The anesthetist talks to them. Everything is explained. Most of the time, they would have never slept with the blanket on their face, so they've never realized. So even if the patient says, okay, I understand, I'll cooperate, I won't take that. I just postpone the patient and make them reflect on what happened, and let them come back. That time, I take the patient back to the theater, keep them in the preparation room, and do everything that is there. I plan to do in the OT, except for the surgery. Clean, drape, put the drape, and see if the patient can at least cooperate a little bit. If the patient can cooperate a little bit, then I would take up the patient for surgery, but the patient would be given an anesthetic preoperatively. So that is done, and a nurse will be always there, hand holding, so that actually reassures the patient. I keep talking to the patient in those cases, and see, obviously, the patient has some breathing difficulty. Actually, tent up the drape, but here, that tenting doesn't really help, but that sort of release a little bit of a problem for the patient. And one thing that I use a transparent drape so that he can actually open the other eye and see also. So all this, but in any case, the patient will have a cannula there. Anesthetist will be ready with the sedative load. So that is how I proceed with the surgery. But if the patient actually on assessment in the preparation room preoperatively, you realize that the patient can't cooperative at all, then I'll give the patient a choice of undergoing surgery under general anesthesia. And this again I've faced 4-5 times, and so this the patient is absolutely okay, absolutely cooperating. But midway through the surgery, the patient starts moving. Initially, it's just starts turning the head here and there, but there is no issue. Like even if the patient is under blocker, so the patient is not able to keep the head steady and then starts coughing. See, you should suspect pulmonary edema in these cases. So just stop the surgery then and there. Even if it is just a IOL implantation that is remaining, even if you have, it is midway through the nucleotomy, just stop the surgery, add other anesthetics, auscultate. I mean, mostly the crux will be there. Whatever anesthetics will take care, mostly Lasix and Epidiolex or something will be given. And don't just pad the patient, send it to an emergency medicine people, let them manage. And even if it takes a week to manage, you somehow manage, even if it is a partially opened nucleus, it doesn't matter. You give steroids and maintain it, and take care of the patient once and only if the patient is comfortable systemically. So basically, these are the situations that I've faced where the patient has turned uncooperative, and these are the ways in which I've actually managed these cases. Very basic presentation, but thanks a lot for this opportunity, Dr. Bharti, Jharkhand Ophthalmic Society. Thanks a lot.
Thank you so much, and I really truly acknowledge you for helping me in connecting all the speakers and from outside. So I will request, the talk was very good. I will request all the guest faculties and all the Jhos speakers to stick to the time, and the time is 6 minutes. And now we request the Dr. Vibhuti Bhushan, please introduce Dr. Madhu Uddaraju. The guest faculty talk is 8 minutes, the keynote address.
Yes, can you see the
Yes.
slides?
Yes. The keynote address is for 8 minutes. We will do some
now it's
later
my
on.
privilege to introduce Dr. Madhu Uddaraju. He is the chairman and managing director, Dr. Ramana Raju's Vision Tree, Visakhapatnam. He is the chairman and scientific committee of Andhra Pradesh Ophthalmological Society. And he's the advisor and Indian partner of Harvard Global Alliance for Medical Innovation. So we welcome you, Dr. Madhu. Please go ahead with your keynote talk, sir.
Thank you, sir. I'll start.
Many cornea surgeons are waiting for your talk.
Thank you.
They have especially joined for this.
Is my screen visible, sir? Full screen?
Yes, it is visible.
Yeah. Thank you, sir. Thank you for the kind introduction. And I thank Bharti ma'am and Jhos for this wonderful opportunity. The memories of Kushalpalli are still fresh, and we were so happy with the way we were there and the scientific content and everything. I congratulate Jhos for winning the Best State Society once again. And without much delay, this would be the scope of my talk. So the topic given to me was intraoperative DM detachment. What would be doing next? So first, in order to see this, we need to know which patients are at risk and what is the timing of DM detachment. Because if the DM detachment is before capsular opening, the management would be different, and if it's after capsular opening, it would be different. What are the intraoperative tips to manage this post-op care and follow-up? So if you see in our experience, though there is not much of literature available, patients with dense arcus, probably two factors. One is the visibility or sometimes even the junctions at the limbus may be looser, we tend to have more DM detachments in cases with the patients with dense arcus. So in these cases, we have to be very careful while doing the incisions. And Fuchs endothelial dystrophy is also known to have more DM detachments when compared to normal patients. Hyperopic patients, just because of the limited space you're operating in, also have a high risk of developing these detachments. And whenever you have an other eye with DM detachment perioperatively, you have to be very careful and note that down before the second eye surgery. So these are the 4 patients that could be at risk of developing a intraoperative DM detachment. So timing of detachment, as I've told you, it all depends upon the timing. So if the timing is before capsular opening, I usually don't continue with the surgery. I do a complete air fill, wait for at least 2 to 4 weeks for the DM to reattach, and then go ahead with the surgery after a month. But if it is after capsular opening, I usually don't take the risk of discontinuing the surgery, because we know that the nuclear is exposed and you can get this inflammatory response from these proteins that are there. So I usually modify my parameters and I do some modifications that I'll tell in detail in the coming slides. So coming to the intraoperative modifications, especially when the DM detachment is found post-capsular opening, is first you have to identify the extent and location. If you are having an access to intraoperative OCT, that's nothing like it. But we know that it's quite expensive and not available in all the places. So a simple trick is to have a trypan blue and an external light sourcing and have a high magnification in your microscope. And I usually reduce the brightness to 60 to 70% to have a better contrast. So once you stain this DM with trypan blue, it is easy for you to identify where it is, how the extent and location. So to reattach it, you can either use viscode or air. And if the DM detachment is quite big, it is advisable even to put an anchoring suture, because you don't want to have this DM flapping throughout your procedure. And the flow rate ideally should be below 30. The vacuum also should be below 300. And the phaco power is dependent on the grade of the cataract. So these are the things that you can modify when you are doing it. And also one important thing is try to avoid the area of DM detachment when you are maneuvering the phaco procedures. So I'll just show you a video where this was a case of abandoned cataract surgery because there was a complete DM detachment during an SICS and it was referred to us.
Financial disclosures. A 63-year-old elderly lady was referred to us after small incision cataract surgery, was abandoned, suspecting a complete Descemet's membrane detachment while entering into the anterior chamber. Due to poor visibility, the patient was referred for a combined procedure of cataract extraction and IOL implantation along with endothelial keratoplasty. This is the clinical picture showing diffuse corneal edema with evident Descemet membrane detachment on anterior segment OCT, which looks pretty bad. The case was taken up for surgery and we tried identifying the Descemet membrane with trypan blue staining and eventually identified an area of focal loss of Descemet membrane. The anterior capsule was also torn in that particular area with some lens material spilling into the anterior chamber. Illumination from external light source was also used to aid in better visualization. We created a capsular opening from that area and managed to complete a capsular excess. The cataractus lens was soggy and was further dissected and delineated with controlled hydro procedures. Phacoemulsification was then performed specifically in the area of focal Descemet membrane loss using a combination of chip and flip with flip and chop technique with optimal parameters of 380 vacuum and 35% power using Venturi phaco machine. The procedure was supported with external illumination by scrub nurse whenever needed. Care was taken not to engage the remnant Descemet membrane fracts into the phaco probe by holding them with a blunt dialer. The phacoemulsification was done with controlled pace, cracking the nucleus small piece at a time. Cortex aspiration was done using a Simcoe cannula. IOL was implanted into the bag. The Descemet membrane is visualized again with external illumination and with trypanlu staining. The decimate membrane was then reattached using air and a few venting incisions to aid better tamponade. Post-operatively, the decimate membrane attached well as evident on anterior segment OCT. After 6 weeks, the patient's vision improved to 20/40 with spectacles and with regular post-operative medications. Staining of decimate membrane with trypan blue and external illumination play a vital role in managing cases with compromised corneal clarity.
So I think that's the important thing that you need to know. And the tips regarding desmetopexy or air filler, always try to use pilocarpine intracamerally so that you can get a good air fill and the air bubble will not escape posteriorly. And try to put this air fill with a 5 cc or 10 cc syringe tangentially to the area of DM loss. And if you are seeing that the air is being escaping from any of the ports, you can direct with a direct needle, like 5 cc needle. You need not use a cannula. You can go with the needle directly and then inject the air bubble. This will stop any escape of air. And what I usually do is I do a full air fill for 20 minutes. That is when 70%, most of the DM reattaches. And after 20 minutes, I decompress the air bubble to 70 or 80%. And I do venting incisions only when I suspect there is a visco in the interface. So in post-op, if it is not clearing in 48 hours, you can debride the epithelium and see whether the DM has attached properly, repeat an ASOCT, and if required, do a repeat air fill. And hypertonic agents and steroids should be used prolonged in these cases for at least 6 to 8 weeks. Thank you. Thank you for your kind attention. I welcome you all to the second AOS midterm in Vizag, and I would like to see you there. You can take my contact number from Bharti ma'am. For any local help, you can call me directly. Thank you once again, Jhos, for this wonderful opportunity.
Thank you so much, Dr. Madhu. And I request all the speakers of this session to remain joined till the last, because if anybody has to ask question, they will.
Ma'am, can I ask Madhu? Madhu, have you really found that these real brown black cataracts, they have more of a loose distance membrane? Because when we were in Shankara, when we were doing a lot of SICS,
yes, sir.
So that was these brown nuclei. In addition to being brown, tends to have more of a loose distance membrane, and so that's have you actually noticed it?
Yes, sir. I think what you told is quite relevant, sir, especially when we were doing more of SACSs in brown. More DM detachments were there. Probably that was because of the bulky nucleus that was there, that we were prolapsing into the AC. That could be
actually during the entry itself, you'll see a small this thing there. See, that is one, and as you said, the bulky one, it gets stuck in the wound. You push it back. You're 100% in those cases, you're going to go, get a distance membrane detachment.
Yes,
and one more query, like when I manage a distance membrane detachment, that's postoperatively what I see. I actually, I mean, it's good that you say only 20 minutes it's needed. I actually keep it for about 2 hours, 3 hours. I inject air, send the patient out, and then call the patient back after 2-3 hours, and then actually release it. So you feel that 20 minutes is good enough?
Yes, sir. Actually, when we make the patient get up, you mean full air fill for 2 hours?
Full air fill, full.
Okay. But like for even DSEC, sir, what the Basak sir does is only 20 to 25 minutes. Most of them reattach, sir.
Okay.
I don't take the risk of making the patient stand up again. That's the only thing.
No, it's a full air fill. And one more comment regarding with directly going in with the needle and injecting air. So somehow I found that it's in my hands at least it works better with a cannula.
Exactly.
Because see, you have a distance membrane detachment,
and
you actually you have to actually take out the aqueous. I mean, not the surgery that you showed as it. You just have a descending membrane detachment and you want to inject air. See, the aqueous has to come out for you to have a full airfill. So using a 26G cannula or whatever, you are not able to achieve that. You enter, release it, and then inject air. So that was, I mean, it's just my personal experience that because I'm not really found using that needle alone very comfortable. But I mean, it's the personal choice. But for me, an entry and injecting air works.
Yes. Very valid, sir. Even for DSEC, sometimes when we don't get a full airfill, we don't use the side port. We go with the needle directly and we have a more controlled airfill because it's more like a closed globe thing. You're not going through any of the entries.
Okay, so should we proceed? Because we will have discussion. Nidhi, Dr. Nidhi, you have to ask the best student is here. So, Dr. Nidhi.
Good morning, sir.
Good morning. Good morning.
Sir, do you use gas directly instead of air in any case? I've had cases who have had a history of DM detachment in the other eye. And when we were operating the second eye, that time there was a total DM detachment. So in such cases, I feel that instead of using air, because we know how the morphology of the DM with the stroma is, so maybe direct gas fill can be done in such cases.
Yes. Gas always has a better tamponade. As you told, in these cases, definitely we can use gas instead of air.
So, and when you observe for maybe 48 hours, and if there is a redetachment, at that time, would you prefer to do an inferior PI and then go ahead with the gas fill so that it stays on for a longer time? Or in post-cataract cases, maybe we won't do a PI at the first one?
Yeah. That's very relevant point. We can do a PI, and also if the DM tear is large, we also put an anchoring suture also if it is in the second time.
Yes.
Okay, so let's proceed to the next talk. So Dr. Nitin Dhira, he's the local Jhos speaker. Are you there? Dr. Nitin Dhira is an LVPI alumni, and he's a cataract and glaucoma surgeon. Eye Hospital, Jamshedpur. So over to Dr. Nitin Dhira. His talk is cataract surgery under topical anesthesia turns stormy, the same topic. So what he experienced. If you take time, then can you invite Dr. Samaresh Srivastava, Dr. Vibhuti Bhushan? Dr. Vibhuti Bhushan?
Go to the first slide, please.
His slides are not coming. That's me.
It's coming, but the last slide.
Doctor, you are on the last slide. You need to go on the first slide.
Go on to the first slide. Use arrow key. Use arrow key.
Just go to the first slide and just be the full screen.
Sir, I think you should stop screen share and come to the first slide on PowerPoint and then again screen share.
Yeah. Yeah.
Is it okay now?
Yeah,
it's okay. Just make it full screen. Okay.
Okay. So, good morning, all. I am Dr. Nitin Dhira, and I'll be presenting on cataract surgery under topical anesthesia, and it's turning stormy. So, this topic has already been discussed, but still, from my perspective, what I feel is cataract surgery is turning stormy, then most of the time it is because of the intraoperative complication. You have started your surgery, and now in the midway, you are finding that complication is there. And based on your surgical skill, your resources, and the cooperation of patients, you try to solve that problem. So when you are working under topical anesthesia or surface anesthesia, what are the challenges that you can face? Is one is due to whatever reason the surgical time is prolonged and patient is becoming uncooperative. Your pre-operative workup, or for the ocular perspective, you have missed something, and some surprise thing is coming, like floppy iris. You forget the taking the history of BPH in male patients and taking medication like alpha antagonist, and the patient's iris is behaving rudely intraoperatively, and you are working on topical anesthesia, under topical anesthesia. This is the real challenging situation, wherein you require to have a good surgical skill, a cool mind, and probably you need to switch to some other mode of anesthesia, like regional anesthesia in the form of subtenon either, or peribulbar or retrobulbar anesthesia, to complete the surgery. So in high myop, again, the surface anesthesia most of the time is not sufficient because of the movement of lens iris diaphragm. You need to put either intracameral anesthesia in the form of preservative-free lignocaine, or again, you need to block the patient with the regional anesthesia mode. Sometimes the patient turns unexpectedly uncooperative. This is also a real situation where you need to, intervene, and you try to calm down your patient. You try to communicate thoroughly with the patient sometimes. And if the patient is still uncooperative, then again, the situation, again, the solution is none other than switching the topical anesthesia to regional anesthesia. So, we all know that in phacoemulsification, most common mode of anesthesia is around 90-95% of the times it is topical one, with or without intracameral lignocaine. Then again, any time when you are finding the complicated surgery or some additional things are there, patient is uncooperative, very much elderly, and you are finding that your skill are not sufficient to manage that particular grade or the complication of cataract surgery, then it's better to give regional block than proving yourself that you can do surgical, topical anesthesia, and landing up with the complication and getting an unsatisfied, unsuccessful surgery. So you need to weigh the risk and benefit anytime when you are performing the surgery. So this is the regional anesthesia, we all know, and the subtenon anesthesia is very well explained by Dr. Srini sir. It's a very good mode of anesthesia. The good point in subtenon is it does not have the complication, especially the serious complication like globe perforation and retinal hemorrhage, as much as which is there in retrobulbar and peribulbar anesthesia. So it's always the slide is the prevention is always better than cure. So we need to assess the patient carefully if we are planning for topical anesthesia. We need to impart our confidence in a way that patient is thoroughly convinced that you can do the surgery. You need to tell your patient that some amount of pain is possible, but not to that level that surgery cannot be done. Assess your eye to be operated thoroughly, that what is the condition of the eye, if the extreme hyperope, extreme myope, the challenging cases, the floppy iris. These are the cases based on your surgical competency. You should try to better block the eye than doing the topical. Last option is always give regional anesthesia. Goal is always the same, a happy post-op patient. Thank you.
Thank you, Dr. Nitin. Hello. So nice presentation. So now Dr. Vibhuti Bhushan to introduce our another guest faculty, Dr. Samaresh Srivastava. Yes, the slide
Okay.
is
Yeah.
visible.
Can you see my screen?
Yes, yes, yes.
Yeah, Dr. Samaresh. Yeah, after finishing his DMB from SN Chennai, Dr. Samaresh Srivastava did his FACO fellowship from Raghudeep Eye Hospital, Ahmedabad, and he has done his refractive fellowship from Narayan Netralaya, Bangalore. Presently, he is a consultant ophthalmologist at Raghudeep Eye Hospital, Jaipur and Ahmedabad, India. His special interest lies in the management of complicated cataracts and refractive surgery. He has a number of peer-reviewed publications.
Thank you, Dr. Vibhuti.
So welcome, Dr. Samaresh. Kindly go ahead with your presentation.
Thank you, sir. Thank you, Bharti Madam, for inviting me for this talk. And it's indeed a pleasure to be a part of this conclave. I hope my slides are visible.
Yes.
All right. So I think this whole what next series is an extremely relevant topic, because this is something that everybody faces. Nobody, no matter how good or how experienced the surgeon is, things can go wrong. Biometric surprise or post-operative refractive surprise is not uncommon. Despite the best of equipment, the best of lasers with swept source, OCT biometries, whatever you do, there can always be that unknown which can cause this problem. So it's very important for us that when it does happen, instead of showing panic with our body language or really getting worked up about it, to actually find out what is going on and to actually work up the patient to see where the problem lies. More often than not, in my clinic, I've realized that the problem is that I don't see certain problems in the patient's eye when I'm planning a surgery. Dry eye being the most important problem. So in many problems that the dry eye may cause, of the potential concerns of wound healing and all, the biggest concern is that it causes your biometry to become unreliable, particularly optical biometers and your K readings, because it's the first refracting surface of the eye. There are other problems that we know. Wounds won't heal. You may have a point of problem of infection, and the patients are generally unhappy with dry eyes. But like I said, just to show you the same patient, on the left side, you'll see the topography and the fact that you can't get a lot of data because the Myers are breaking apart because my staff had instilled a parakin. Versus on the right side, where you see the entire topography is stabilized after 15-20 minutes of installation of a simple CMC based lubricating eye drop. And how does this translate? This is how it translates. So when they did the first sets of investigations, they came up with an IQ power of 21 diopters. And I would have gone ahead and done the surgery since it's a monofocal lens. But when I put a lubricant eye drop in the patient's eye, the biometry went from 21 to 20 diopters. So to understand, it's a 1 diopter of difference that happened just because of surface not being proper. And this is typically the case that would happen in biometric surprises and something that one should look on for. The second thing, this is not going to play, but in many cases, posterior polar cataract, and this was a posterior polar cataract, there's nothing much to show in a video, but when a cataract like that goes on well, one is really happy that the surgery got over. But this particular patient landed up with a 6 diopter of hyperopia. Why would that happen? It's not sulcus placement. It's not a lens that's dislocating. Why would a hyperopia happen? What went wrong? So we went back and looked into the patient's file and reviewed all records. And this is when we were doing immersion biometries for these patients, because sometimes the opticals will not go through a polar. We repeated biometry and we found out that the immersion biometry for this patient was done in a contact mode by the optometrist. Just a simple flaw that instead of putting immersion, you put contact, it created a 6 diopter of hyperopic surprise. So it's very important that if you're still doing immersion biometries, please don't change the mode or ask your staff to be extremely finicky about choosing the mode, because that can cause the problem like this. Now, the only solution in a case like this would be to exchange an IOL, and best not to wait for too long. But the fear that a posterior polar has a weak posterior capsule will play out again when you're going to explant this lens. So it's not going to be an easy solution to do. We had to do that for the patient, but it would not have been the best thing to do in this patient. But it happened. Another case, where we implanted for a classical toric patient who has a toric lens, we implanted a T5 in the bag for this myopic patient. Everything went well. The patient surgery was flawless. The next day, patient comes up at 2 weeks follow-up with a biometry, with a refraction, literally double of what the patient's refraction was. From -2.5 even to -4 with a toric lens in the eye. What could have gone wrong? We saw that the IOL is well placed in the axis that the printout had given us. 64 degrees and 65 degrees. You can't get better than this in surgery. The problem was, this was the topography. The topography was 150 degrees. So when my fellow was entering data into a manual toric calculator, they flipped the axis. So 50 went to 160, 60 went to 150, 150 went to 60, and the IOL placed in the exact opposite direction, adding on to the previous astigmatism, making it double. And that was a data entry error. So for a long time, because our biometers now have toric calculators incorporated, it hasn't happened, but it doesn't mean it cannot happen. So it's very important that simple things like data entry and emotion mode errors can lead to significant surprises. And these things are doable. You can rotate these lenses. I'm not sure if the video is playing, it is playing. But when you have to rotate the lens or you have to explant the lens, there's no rush to do it on day one. But there's no point in delaying it beyond a certain level because the adhesions, the capsular adhesions should not be forming. You can use dispersive viscoelastics like you notice over here. We are using viscoat to cleave and then rotate the lens into place. The good thing about hydrophobic lenses is they can rotate. And you can use viscoelastics liberally to cause cleavage planes in these to be able to rotate the lenses better. And the outcomes are generally quite favorable. And post-rotation, this is what we wanted. We wanted no refractive surprise, and it did occur. The patient went back to its regular post-operative outcome that was expected. For many reasons of inaccuracy in biometry, data entry errors are the most common. So our marking errors are the most common. So it's very important to look out for these and make systems and processes to make sure these mistakes don't happen. Redialing can be done, like I said. But if you genuinely do have a residual error in the patient's eye, I would suggest you best wait and watch, because there is no point in being a little, bullish about it. And
but Doctor, 1 minute left.
Yes, absolutely. I'm on the last slide. It's important to explain sometimes that despite the best of diagnostics and the best of equipment, sometimes you can land up with a surprise because we don't know a lot of factors, like where the lens will play out in the eye, where the lens will settle down. And in some lenses, sometimes the lens biometric power, refractive power, is not actually the power of the lens, particularly if it's a subsidized lens, because the stringent policies and protocols for checking the power of the lens are sometimes flawed. If it does occur, my primary solution would be, like I said, to wait and watch. The second choice for me would be to do a LASIK if it's a straightforward refractive correction, and putting the refraction makes the patient to 6/6. I would not shy away from doing a LASIK, but probably at a 3-month or to 4-month gap minimum, so as to let the incision stabilize and the patient get comfortable with the final refraction. Lens exchange, although very reserved, I would do, particularly if I have a dioptric surprise that's going on more than one. And I would liberally use dispersive viscoelastics and any sort of exchange scissors or forceps to be able to take out the lens by not damaging the cornea and making sure the posterior capsule is away. So not only do I inject viscoat anteriorly over the lens, I also inject viscoat behind the lens so as to push the posterior capsule away, because I don't want it coming towards me. And finally, there's a potential of doing a sulcoflex implantation. I have not done any, but I value the guidance and teaching of some of the stalwarts in ophthalmology, including Dr. Ramamurthy and Dr. Sri Ganesh, who have always guided me that if something like this does happen, sulcoflex may be a good solution for these patients. Thank you so much.
Thank you, Dr. Samresh, for a wonderful presentation. So next we have Dr. Harish Kumar. Dr. Harish Kumar?
Yes, sir. Yes, sir.
Yeah.
Good morning,
please
sir.
Please share your screen. Dr. Harish will be talking about severe postoperative dysphotopsia and photic phenomena.
Is it visible, sir?
Yes.
Dr. Harish, actually there's something wrong had happened. I could not unmute myself. Dr. Harish is a consultant in Central Hospital, BCCL, Dhanbad. And he's the young speaker from Jhos. So please start your talk.
Thank you, ma'am. And good morning to all. My topic is severe post-operative dysphotopsia and photic phenomena. What next? Just imagine you have just performed successful, uncomplicated cataract surgery. Your patient has 6x vision and surgery looks good. You are ready to be congratulated. Instead, your patient say, I hate it. This unwanted image. The image make me crazy. You have to do something about this. Of course, you don't want to hear this. Dysphotopsia has become the #1 problem following uncomplicated, successful cataract surgery. And it does not go easily once a patient becomes focused on it. Unfortunately, many of these patients are incredibly unhappy. What is the nature of problem? Up to 66% of the patient may experience positive dysphotopsia immediately after surgery. Only 2.2% of cases have persistent symptoms up to a year post-operatively. Surgical intervention may be indicated in 0.07% of cases. The incidence of negative dysphotopsia is up to 26% of all patients. However, by 1 year post-operatively, the symptom usually persists in 0.13 to 3% of the patient. So what behind the current complaint? The first element is what the patient actually seeing. And the second element is how the patient react to symptom. The patient reaction can be the most significant factor in resolving or not resolving the problem. What the patient sees, patient says glare, light stick, starburst, light arc, ring, halos, flashes of light, arcs of shadow. In literature, terms such as photopsia, entoptic, and photic phenomena have been used to describe these images. Photic phenomena are PCIOL implantation was first reported by Arnold in 1994. In June 2000, Arnold coined the term dysphotopsia. Dysphotopsias are undesirable optic phenomena caused by external light source superimposing unwanted pattern over the two retinal images. Dysphotopsia are of two types, positive dysphotopsia and negative dysphotopsia. In positive dysphotopsia, glare, light stick, halos, and flashes of light are seen. In negative dysphotopsia, there is arcs and shadows. Understanding the problem. What is the problem? Positive dysphotopsia. Positive dysphotopsia after cataract surgery is described the patient as glare due to high refractive index and reflectance of the IOL, light stick and starburst due to backscatter from the IOL and microsecond exacerbated by higher refractive index of lens. Light arc seeing the edge of the IOL usually at night. Rings and halos more commonly seen with multifocal IOL, flashes of light, reflection of peripheral light rays of the edges of the IOL. The most commonly factor of occurrence of PD are IOL shape, sharp edge design, refractive index, pupil size, and IOL size. Negative dysphotopsia are arc sharp shadow or line is usually located in temporal visual field similar to temporal scotoma. Patients most commonly experience this phenomena in photopic condition when the pupil is narrow. Holliday and Simpson characterize the risk factor for ND development into three groups: anatomic characteristic, pupil size, hyperopia, and angle kappa, and IOL properties, IOL surface stiffness, edge design, dioptric power, and refractive index. Surgical technique for cataract removal, optic haptic junction orientation, and position of nasal anterior capsule to the IOL surface. Dysphotopsia is multifocal and toric IOL. Multifocal IOL are associated with higher incidence of PD symptom compared to monofocal IOL. Pei et al. So that diffractive multifocal IOL are more commonly associated with glare phenomena compared to refractive. Higher number of diffractive ring may cause more intense symptom. And after toric IOL implantation, 15 to 30% patients complain of moderate to severe PD symptom. What next after development of dysphotopsia symptom? Patient education, counseling, and reassurance are the first and most important. The patient should be advised to ignore the image as the symptom resolve spontaneously over a period of 1 to 2 months. The spontaneous ossification of the nasal capsule lead to spontaneous resolution of negative dysphotopsia. Capsular bag contraction can cause anterior axial movement of the IOL, reducing the axial space behind the iris. So patient assurance is the most important. And in positive dysphotopsia patient, pupillary constriction can be tried with pilocarpine or brimonidine, but it will not try on the negative dysphotopsia because it aggravates the problem. In negative dysphotopsia, pupillary dilatation can be tried. Thick frame spectacle can be helpful, especially in negative dysphotopsia, helping the brain to get ahead in the avoiding the shadow. Addressing other confounding issues is important, like refractive error, dry eye, etc. The eye should be evaluated to determine if there are any corneal abnormalities such as epithelial basement membrane disease or macrostriate due to previous LASIK. YAG capsulotomy of nasal anterior capsule can help resolve the symptom. When the patient's symptoms did not resolve by 6 months on conservative management, then surgical approach are tried. IOL exchange is the main in surgical management. Fabric et al. Advocate that IOL with a smaller optic and high refractive index with sharp edges should be replaced with IOL with at least 6-meter optic size of low refractive index and rounded edge. IOL exchange have been performed to change sharp acrylic to round edge silicon, shiny to frosted sharp edge optics and reverse shape optics. Reverse optic capture technique. Optic of the IOL is brought into the sulcus while the haptic remain in the bag, so that capsular axis does not overlap the haptic and be helpful. Bag in the lens technique introduced by Belgian ophthalmologist Mary Jhos. Bag in lens procedure feature a round edges IOL that has 5-meter optic surrounded by a peripheral group and electrical haptic to receive anterior and posterior capsular flake. Piggyback IOL in the sulcus reduce or eliminate the space behind the iris. However, it must be less than 0.6 mm. And this is the flow chart for management of dysphotopsia. Thank you. Thank you, sir.
Sharing your slide. So now I request Dr. Vibhuti Bhushan to introduce our next speaker. He has two very important talks, Dr. Gopal Pillai. Dr. Vibhuti Bhushan, please introduce Gopal Pillai. He has two talks, extremely disturbing post-operative floaters and suboptimal visual recovery in a clean post-operative case. So over to Dr. Vibhuti Bhushan.
Yeah, it's my privilege to introduce Dr. Gopal Pillai. He is the professor and head of the department, Amrita Institute of Medical Sciences. He has numerous publications and presentations at national and international level. He is a pioneer in the small gauge sutureless vitrectomy surgery in India. And he is the reviewer of the prestigious Ophthalmology, Journal of AAO, and Journal of Tropical Medicine. And recently we have seen his organizational skills, and he was the organizing secretary of the AIOC 2023 at Kochi. So welcome, Dr. Gopal Pillai, sir.
Thank you very much for the kind opportunity. And I thank you for the kind words of introduction. I'm indeed honored to be part of this platform. And under the able guidance of the Scientific Committee Chair, Dr. Bharati Kashyap, I think Jharkhand Ophthalmological Society has bagged the best state award. Congratulations for that once again.
Thank you. I know when it was the souvenir which handed over to Professor Lalit Verma, you were pleasantly surprised. I remember that day, and you only carried it to Kushalpalli.
Yeah, vivid memories about Kushalpalli also, ma'am.
Yes.
Yeah. So let me just go to the talk. I'll keep my time. I promise you that.
Yes,
so
thank you so much.
We would talk about troublesome filters. Right, cataract surgery is no longer a rehabilitative procedure. It's a refractive procedure where you need to give the best vision to the patient. So the patient expectations are also very, very high. So vitreous floaters are caused either by the degenerative or the pathological alterations in the vitreous ultrastructure, and they're perceived as shadows or fly-like obscurations in the front of vision. And some are self-limiting because we adapt to those, but some are perseverant as well. Symptomatic vitreous opacities do not alter the visual acuity. Basically, it acts as a menace, but it doesn't actually reduce the visual acuity a lot, but it is an important cause for patient dissatisfaction after cataract surgery. There's no well-defined consensus onto the management because some people will take floaters without a problem and some people are so much disturbed by floaters. And so let's look at the etiology of the preoperative, postoperative floaters. One is pre-existing floaters itself. They tend to become more visible because now after cataract surgery, everything is more visible. Everything is more clearer to the patient. So the pre-existing floaters will also become much more clearer to the patient. And then there's a secondary floaters, like intraoperative, if there is any leakage of the lens matter or OVD into the vitreous because there is a small PC rent or something like that, then troublesome floaters can come. Post-operative PVD. If pre-operatively there is no PVD, then post-operatively a PVD will occur in about 70 to 90% of patients, and that can be a reason of floaters. Degenerative vitreous syndromes and any retinal breaks or tears can also be there. Now, which are the patients who actually have a lot of problems with floaters? They're the type A, detail-oriented person who will always look for, he's a highly dissatisfied person who will always look for reasons to be unhappy and unsatisfied. Those are the type of patients who will get a lot of floaters. This finding that contrast sensitivity is diminished and glare increases because of scattering of light rays, and patient unhappiness with vision despite very, very well done cataract surgery and good visual acuity. And there's a strong positive correlation between quality of life and this quantitative ultrasonography, which shows the floaters. So how do you image floaters? Visibly, sometimes, in a clinical examination, you may not pick it up, but ultrasound A and B scan, quantitative analysis, and we can identify the PVD. OCT also shows floaters. There may be, if it is just a few, just in front of the macula or in the retina, you can see. Otherwise, if it is completely away from the retina, you cannot see. SLO, so you can see the umbra and the penumbra. Okay, these are some of the imaging mechanisms. So you can see the ultrasound as well as the SLO umbra, and umbra are the dark spots, and the penumbra the surrounding grayish halo. So how do you approach these patients? We have to take a family history also, retinal detachment. All those are very important, because if there's family history of retinal detachment, if you've got floaters post-cataract surgery, then you have to actively search for a tear, all right? And pre-existing floaters, we have to ask the patient. Complicated cataract surgery, we have to look for the operative nodes, etc. And fundoscopic examination should rule out any vitreous base problems, pars planitis, inflammation, tear, lattices, all those things, apart from obvious causes of floaters like asteroid hyalosis or vitreous hemorrhage or PVD, etc. Rule out peripheral breaks definitely in any case of floaters, because post-cataract surgery, now the cataract surgery age has also come down, and so many people do not have a PVD while going for cataracts, and please rule out any peripheral breaks. You have to spend time and effort to do that. So quality of life questionnaire throws light on disability. If there's a good visual acuity, explain about possible complications, and then possibly you can either observe or interventions. What are the interventions? Floterectomy or vitrectomy can be done. There can be Nd:YAG laser vitreolysis, and vitrectomy has a very good result, but it has its own complication rate like retinal detachment and off. Laser vitreolysis acts only on the collagen component and lysis of fibers aggregates, and complications can arise with laser when used very close to the retina, etc. So there are some studies which shows vitreolysis through pharmacological agents as well, but not approved currently, theoretically feasible and conservative approach. Right. So these are again other published articles on 476 patients. Overall satisfaction was seen in about 92% of patients post floaters study. All right. So to conclude, there is absolutely no consensus as of now for the floaters post cataract surgery, but we should rule out secondary causes like a tear or something like that. Case selection is important, and assess the amount of handicap despite good visual acuity. Identify the well-suited cases for laser analysis, laser vitreolysis, and in select cases, it may do well with vitrectomy. Always consider the risk-benefit ratio. Thank you very much for your patient hearing. So should we go to the next talk and then combine both the...
Yes, sir.
Yeah.
Please go ahead.
Yes.
Yeah, the next talk that I have is suboptimal visual recovery. Okay, suboptimal visual recovery after a clean case of cataract. All right. So post-operative surprises. The objectives of the talk is, first of all, find out the reason, and we should know what can be done and how to counsel the patient, and yes, to document it. Now, etiologies can be divided into preoperative, intraoperative, and postoperative. Preoperative evaluation is that we should know if the cataract is actually commensurate with the vision loss. All right, that's a very, very important thing. If the cataract is not commensurate with the vision loss and you do a cataract surgery, finally your visual acuity won't be as much as it should be. Was it a mature white cataract with poor vision? If it is a mature cataract, we would not know what is the retinal pathology or optic nerve pathology within it. So we would not know what is the visual prognosis post-operatively. Was the pupillary reflex good? If it is good, more chances that there would be a good visual recovery. Is the retina and optic nerve normal? That is something which we need to evaluate. Are there any floaters which are troublesome? Just like I told in the previous talk, any preoperative history of stroke. Stroke is another condition where you can have disabling visual acuity problems even after a good cataract surgery. Preoperative pathologies like high astigmatism, glaucoma, floaters, macular and retinal pathologies, optic nerve pathologies, and actually CNS ischemia, all these are preoperative pathologies which can actually lead to surprises post-operatively. Intraoperatively, sometimes block perforations can occur, and we would not know about that till the surgery is over. And we may have a bleed or a retinal detachment or something like that, which can actually cause a problem. Wrong powered IOL decentrations. A little decentration can sometimes cause major problems. Intraoperative AION, because the pressurization of the anterior chamber is too much, and that might, in a labile optic disc, it can cause an AION. Intraoperative vascular block like a central retinal vein occlusion, intraoperative choroidal detachment or suprachoroidal hemorrhage, and vitreous hemorrhage because of some reason, and or hyphema moving back or something like that. Postoperatively, postoperative choroidal detachment may occur in a wound leak, which can cause decrease of vision. Delayed suprachoroidal hemorrhage, which can occur if even after a clean case in an old patient. High IOP in a labile disc can actually cause decrease of vision. Some cases may go into malignant glaucoma. Early endophthalmitis. If it is a very late endophthalmitis, you will basically find out that it is there. But very early endophthalmitis, sometimes optic nerve and the vitreous haze itself may cause decrease of vision. Vascular block and AION. These are the postoperative reasons. Sometimes you can have very delayed postoperative, decentered or dislocated IOLs and corneal decompensations, which are slowly coming up. Only corneal edema is coming. Little bit of corneal edema can cause that. Significant corneal edema, we can pick up mild PCO or PCO holds, PVD and floaters, vitreous hemorrhage, worsening of retinal conditions like DME, AMD, the cystoid macular edema, any new pathologies like AION or the optic nerve. So what can be done about the preoperative problems? Astigmatism, we should manage intraoperatively. Toric IOLs or corneal keratotomies or whatever. Glaucoma, we should know how much is the preoperative pathology and then decide on that. Floaters, we can always explain to the patient. Retinal pathologies, there are retinal pathologies in which we can have reversibility, like for example, a vitreous hemorrhage, but a major TRD or ischemia or a tear in the center or macular hole, all that can actually cause. Yeah. What can be done about intraoperative problems? If there's a block perforation, you need to wrong powered IOLs, we need to find out. Yeah, intraoperative AION, probably we cannot do much about it, but basically you should keep your pressures a little lower. That would also help for intraoperative vascular block and choroidal detachment and suprachoroidal hemorrhage. So postoperative problems, post-op choroidal detachment, you can give steroids and hike up the pressures. Delayed suprachoroidal hemorrhage, you can drain. High IOP, you can easily manage. Malignant glaucoma, atropine, YAG hyaloidectomy or vitrectomy. Early endophthalmitis, yes, injections. Vascular block, you can give intravitreal anti-VEGF injections. Like that, you can manage these postoperative problems quite a lot. Delayed also, decentered or dislocated IOLs, you can manage it by changing it. Corneal decompensation may require more penetrating keratoplasty. PCO can be easily managed. PVD and floaters, I had a talk just now. Vitreous hemorrhage is simply manageable. Diabetic macular edema and AMD worsening, yes, we have to give more intravitreal injections. Cystoid macular edema, a lot of them would respond to subtenon steroids or intravitreal steroids. So counseling is a very, very important thing. You should never miss a preoperative pathology. And intraoperative complications should be recorded and counseled and management taken. Postoperative pathologies we can always diagnose. Endophthalmitis is something which we should never miss. We should basically take it as, in high index of suspicion for any patient with a hypopyon. Just don't think that it is a reaction or TAS. And you need to break news slowly over a period of time, firm, yet soft, yet empathetic. And financial transactions also has to be there. Documentations, right? The legal system would require high documentations. Each patient is a yeah. And document the explanation to the patient and all possible management options to reverse the causes. explain the prognosis to the patient. Thank you very much.
That was really wonderful presentation, Dr. Gopal. Excellent presentation, sir. Thank you very much.
Excellent. So, now we invite Dr. Archana Kumari. Dr. Archana Kumari is a young VR surgeon from Jharkhand, and the best part about her is she has a right balance of clinics and academics. So, welcome, Dr. Archana. Her talk is intraoperative rock hard eye. She's a VR surgeon. Over to Dr. Archana. Please share your slide.
Thank you, ma'am, for those kind words, and happy morning to all of you. Am I audible, ma'am?
Yes, very much.
Yeah, so intraoperative rocky hard eye. Rocky hard eye in phaco surgery.
हमको बड़ी टेंशन हो रहा है.
Yeah. What is it? It is an acute intraoperative of infusion fluid or fluid deviation into the posterior segment leading to marked posterior pressure, and literature calls it by good name of acute intraoperative rock hard eye syndrome or ARIS. So the key features are subcapsular infusion fluid, anterior displacement of iris lens diaphragm, which results in sudden rock hard eye. It occurs during uneventful phacoemulsification surgery, and retrobulbar hemorrhage as well as suprachoroidal hemorrhage or effusion must be excluded for the diagnosis. The risk factors are any kind of zonular dehiscence like traumatic or surgical, abnormal zonules like large eye in myopic patients, pseudoexfoliation, collapse. The only modifiable risk factor is high IOP or bottle height. So when can rocky hard eye syndrome occur? Complicated phacoemulsification surgery and even a large amount of viscoelastic injected into the sulcus for sulcus IOL placement can result in misdirection of viscoelastic into the posterior segment. So this is a very informative video, and I would like to acknowledge and thank Dr. Padvardhan for allowing me and sharing this with me. So during phaco surgery, the phaco probe infusion maintains the anterior segment for a safe and comfortable surgery without complications. However, if there is predisposing factors like zonular weakness or high bottle height, as we have discussed, there is seeping of these infusion fluids into the Berger space. That is this. So once this happens, the fluid misdirection keeps on happening. This is intraoperative fluid deviation, and because of fluid on either side of the posterior capsule, there is clinically we can see undulating posterior capsule and particulate material in the Berger space. So this is the point when the anterior segment surgeon, the phaco surgeon has to be quick in diagnosing, and once detected here, reduce the IOP and bottle height, reduce the phaco parameters, the vacuum and flow rate, and use protective viscoelastic to form the anterior chamber and perform a safe wake of phaco more clearly so that the posterior capsule, which is undulating, is not ruptured. However, if not detected at this stage, we are going to be at trouble. So the fluid misdirection goes on continuing in the Berger space, swells up, it pushes the iris lens diaphragm interiorly. And once the anterior displacement of the iris lens diaphragm occurs, there is acute intraoperative rocky hard eye, that is ARIS. So the management can be either needle aspiration from the Berger space or pars plana vitrectomy, 1 port or 3 port, or manage it conservatively. Let's go into the detail. For needle aspiration, Oliver et al. In 2014, they published an article in Journal of Cataract and Refractive Surgery, and they showed in a case series that it is very safe to do needle aspiration from the Berger space by the phaco surgeon itself in the same sitting immediately after the diagnosis is made. And even recently, in 2023, article was published in Jhos with very detailed that how it should be done, and they talk that how just like a vitreous tap with a 25 gauge or 26 gauge needle, which is more easily available, we go 3.5 millimeter from the limbus, and with the help of 5 cc syringe, we can pull out 0.5 to 1 cc of fluid from the Berger space. This is how it is, and once the fluid is pulled out, the iris lens diaphragm will fall down, and the surgeon surgery can be continued. But like every procedure, as nice it sounds and easy it sounds, there is pros and cons of it. The disadvantage is that needle aspiration is a blind procedure. Though it looks very tempting, there is chances of vitreous traction and it has inconsistent result. Like vitreous tap in any case, it may have dry tap. We may have to fiddle with the needle. But what the authors argue about the advantages is that it is the only procedure which can normalize the IOP urgently and save the optic nerve head. No additional setup is needed if you don't have will with it. And definitely they even argue that better than cutter. It is better than cutter to use needle because posterior capsule cutting or vitreous traction would be less. Now the option 2, which is the management, that cutting vitreous with vitrectomy probe through pars plana. Use it 1 port or 3 port. So what we do is that first debulking of the anterior vitreous is done. After anterior vitrectomy, the anterior hyaloid is cut, and then the fluid is aspirated from the Berger space. But as fancy as it sounds, it is not so, because we have to be aware as retina surgeon, because suprachoroidal hemorrhage is quite common, especially if the IOP is very high. So option 3, and the most pertinent, and I think the one I would like to advise, especially to the novice surgeons or the new surgeons, stop the procedure. Manage conservatively. Go for IV mannitol, oral Diamox. Once the IOP is under control, in the same day or the next sitting, we can go for the surgery. So the precautions that, something that we can be careful pre-op is the head positioning, especially in bulky patients. Try to keep it bit head up in inverted Z shape. Then exclude retrobulbar block. Minimize manipulations during the surgery. Elevate speculum. Inject viscoelastic before coming out of the eye. Be gentle with the inflations in the AC. And intra-op strategies, always avoid prolonged high IOP, and for that use mechanized pole or gravity-based machine. Watch for early signs of fluid deviation, because that time the IOP is not high and can be managed very well. Rule out the threatening complications like suprachoroidal hemorrhage or even floppy iris syndrome. Wait and come back, take a breath, take time out. Do indirect ophthalmoscope if you want to confirm suprachoroidal hemorrhages. See the red glow is going away or not. And if once diagnosed, go for the managements that we have discussed. And the take-home message would be that avoid prolonged high IOP, diagnose early. Always try to diagnose it early. Rule out other causes like suprachoroidal hemorrhage and manage it conservatively in the best results. Thank you so much for your attention.
So, very nice talk, Dr. Archana. And
thank you, ma'am.
Dr. Pritish Pranoy. So, Dr. Pritish Pranoy is a very high volume cataract surgeon. He works in the government sector. So, over to Dr. Pritish Pranoy. Dr. Pritish Pranoy.
Yes, ma'am.
So, please share your slide.
Good morning to everyone. Thank you, Bharti ma'am. I'll be talking on non-rotating nucleus. What next? I want to thank my colleague Madhu Sekar, Chief Cataract IL Arvind, for sharing the videos which have been presented here. No financial interest. It's a routine complication faced nowadays by a surgeon doing phacoemulsification. Knowing this, we should know the common causes behind this. According to the situations, we should know to identify the cause and treat it satisfactorily. According to me, I have categorized into 4 types: inadequate hydrodissection, dense corticonuclear adhesions, jonular dialysis, and posterior capsular ramp. Need to differentiate between all the cause. The first two in which the patients with inadequate hydrodissection and dense corticonuclear adhesions, after hydrodissection, the nucleus does not rotate from the very beginning. But in case in jonular dialysis and having PCR, the nucleus rotates freely in the beginning, but once encounter resistance in nucleus rotation after the above mentioned complication. Based on the causes, there are different management for each of the above causes. For the first 2 causes like inadequate dissection and inadequate hydrodissection and dense corticonucleus, we need to repeat the hydrodissection from the very beginning, following the particular proper steps like wash out the viscoelastics. Always use blunt cannula of 27 to 30 gauge with the bevel facing upward, and try to take the cannula below the anterior lens curve, right up to the equator, lifting the LC, and pass the BSS slowly and follow the wave from one quadrant to the other. Tap the nucleus. It helps to break the corticonuclear adhesions by passing the BSS to the nucleus on the capsule. And it also helps to burp out the extra BSS accumulated between the nucleus and the posterior capsule. Similarly, we need to do the hydrodissection all the quadrants. This is called multi-quadrant hydrodissection. It helps to break the dense particle nuclear adhesions. After that, we'll start again with the rotating of the nucleus and proceed further. In cases of zonular dialysis and in PCR, it's something different. First, we have to assess the weakness. The what clock hour the patients is. We need to see any shallowing of SC or not. Is there any ecodenosis or adenosis? If you notice that, we'll proceed according to the management of zonal dialysis. First, we put viscoelastic in the AC in the bag, and the best way to put devices like capsular hooks to anchor the anterior lens, capsule to give support to the bag. Again, we place a CTR to stabilize the bag. After that, we'll lower down the bottle height and reduce the phaco parameter. We'll start with the chopping, either the direct chop or horizontal chop. The next step is very important, the cortic aspiration, cortical aspiration, which will be done tangentially rather than pulling it centripetally, damaging the zonular. In PCR, again, in PCR, first we fill the chamber with dispersive viscoelastic before coming out of the AC to maintain the AC and also plugging the PC head. After doing so, we'll magnify the view to the computer, to the microscope. And after doing so, we'll prolapse the nucleus out in the AC and emulsify the nucleus, taking the consideration the density of the nucleus. If it is soft or in grade 2, we can take it out, taking in consideration the dispersive and cover of the endothelium with the viscodispersive, preventing the endothelial loss. If the nucleus is very hard, we'll convert it straight into PCR, into SICS. Have two cases. There is a case number 1. In which you say dense nucleus, the nucleus there is a nucleus rotation at once. But after doing the phaco, starting with the phaco, the direct chop, we'll encounter there is a loss of rotation. It's a very dense nucleus. You can see in dense nucleus there's always a zonular weakness. You can also see there's little piezo material in the pupillary margin. There's a difficulty in rotation in this case. What next we'll do, we'll take care of the capsular hook and hook the anterior lens capsule along with the iris. This will give a proper support to the bag. After that, we'll do a routine phaco. See the nucleus starts rotating because it has got a good support. The bag is well supported by the capsular hooks. The rest of the procedure as such, it will break the nucleus, take out the nucleus and do the rest of the procedure. Next case, another patient with a undilated pupil, mild hydrodenosis since a mature cataract with undilated pupil. Here you can see there is a piezo material. We will dilate the pupil with a manual sphygmatometer taking help of the Kublenz hook.
Yeah.
Access has been done. I will see there's a rotation initially. We'll start with the phaco. Again, in this case, we'll see during the carrying of the procedure, there will be difficulty in rotation of the nucleus. There's a proper chop, direct chop, and lateral separation. Now the nucleus is difficult. The bag is also rotating with the, if we start go on rotating, it will damage the bag. Again, we'll see that there's a sudden anterior chamber instability. Both the signs show that there's a zonal weakness. Again, we will go with the capsular segment, capsular hook, we will support it. In this case, since the vessel was more, we will inject a CTR with the help of the injector. This will give a proper support to the bag and the force will be distributed throughout the bag. Rest of the procedure is simple. We will do the phaco with direct chop.
Doctor, 1 minute left.
Yeah. See, it's a tangential removal of the cortex. Third case, it's a mature cataract, brown heart cataract. Start with the chopping. It will rotate initially, but again, you will see something going wrong. The rotation is good. Another part of the nucleus, semi-nucleus will start chop. It will separate with the lateral separation. For next, you'll hear it's become difficult to take out the nucleus. There's something wrong. If you think if the process is not going properly, there is something wrong. There's a poor rotation of the nucleus. The nucleus is taken out, and what we'll notice that there is a clear zone of PCR. You can see it's injecting the viscodispersive. You can see the PCR. If you go ahead, it will lead to a great disaster. It's better. It's a grade 5 cataract, more than 5. It needs to be taken out by SICL. The surgeon just convert this case into SICS. While doing so, we should always take care of the endothelium. We should properly cover the endothelium with viscodispersive. So the take-home message is always stop when you get something wrong, when the process is not going properly. Stop for a second, keep yourself calm, listen down your adrenaline, think about what to do next, rethink your procedure, what you have in your mind, magnify the view, identify the defect, and be ready with all the armory present in the OT, like what we have done here, CTR, iris soaks, and viscode, etc., and take out the carry on the process nicely, and have a very good night. You'll sleep at night. Thank you. Thank you.
Nice presentation, Pratish.
Thank you, sir.
A very nice presentation, Dr. Pritish. And he's a very, very high volume cataract surgeon. He's trained in Arvind Hospital, Madurai. And now I request Dr. Vibhuti to introduce Dr. Y. Umesh. Dr. Y. Umesh has 2 talks, repeated iris catch by phaco-tip and IOL implantation with mistakes. What next?
Yes, Dr. Umesh, after finishing his DO in 2000, he did his DNB in 2005, followed by a specialized training in cataract and refractive surgery from Sankara Eye Center, Coimbatore. And he also did a refractive surgery training. He also got a refractive surgery training at Germany. He's a chief medical officer at Sankara Eye Hospital, Bangalore since March 2008, has an experience of over 50,000 vision restoring surgeries, and regularly conducts short-term phaco training programs at Sankara Eye Hospital, Bangalore. He has trained more than 100 surgeons. So we welcome you, Dr. Umesh. You can start with your presentation, sir.
Thank you, Jhos and Dr. Bharti, and for the good introduction. And I have 2 talks. I'll try to keep up my time. My first talk is repeated iris touch during phaco. What next? I think this is the most common mistake that most of the beginners do. Are you seeing my presentation?
Yes,
okay.
Yes, we can see.
Okay. So this is the most. So that's the phaco touch that happens, iris touch that happens, and very common, especially beginners. And we see this very often. And what are the most common causes? The main cause is not respecting the central safe zone. I think this is one of the significant points that we always have to remember, not just for this, but any phaco surgery, any type, respecting the central safe zone is of utmost importance. The other causes obviously are small pupil, eye fish, high fluidics and dynamics. This is one thing that, especially when the transition surgeon from divide and conquer goes to a direct chop, there you usually encounters this problem, and of course search. And how do we reduce it? Obviously use reduced fluidics, respect the central safe zone, very important. The moment you are managing any small pupil, keep the central safe zone in mind. Essentially, central safe zone means doing all the apart from irrigation, aspiration, phaco, vacuum, whatever it is, has to be done in the central safe zone. And the other way is to keep the aspiration port away from the iris using second instruments. And finally, lastly, when you have no choice, you have to use the iris hook or iris ring. So this is one way of respecting, is just be in the central safe zone. See, once you hold this, you be away, you just come towards the side. Now, luckily for me, the iris has given some space here in the side port. So you just be in the central safe zone all the time. You can finish up the surgery without any problem. Just make sure that you are in the central safe zone. So sometimes when there is a repeated touch, especially during the IA also, even with a small port, you do have that. And you use the second. I'm here using the Sinsky, just holding the iris and slightly tuck away from the and try to do the irrigation aspiration. By this way, you can prevent the repeated iris incarceration into the port. And finally, other thing is to not use the aspiration port. Make sure the aspiration port away. If you're towards the side, it keeps on coming. Once it starts coming into the port, it keeps on and makes your life very miserable. So make sure that your port is away from the direction of the initial touch. And if you keep doing the way nearer to the iris, multiple areas of touch can happen. And in that happens, then you have no choice but to go for an iris hook. In this case, I had here, so I'm just going and doing only I just need some space where I can do the surgery and use one or two hooks wherever the iris in aspiration has occurred, and you can completely finish off the surgery without anything. So the take-home message I would suggest is be careful, especially when you're handling small people's hard cataracts, high fluidics and dynamics. And in case you have, don't just remember the central safe zone and using the side port, and where necessary, put the port away, the aspiration port away from the site of aspiration. Shall I go ahead with the other topics, sir?
Yes, yes. Yes, please go ahead.
Yeah, my other topic is IOL implantation mishaps. And I'm sure everybody, whoever has been putting my IOL, foldable IOLs have seen. We did see initially when the introduction of the Indian hydrophobics, a lot of IOL mishaps, especially because in improper loading and pushing too much, because most of the Indian cartridges have no enough lubrication within. So you end up in having broken haptics. So in this case, this is not Indian. This is a Johnson & Johnson Technics lens. Sometimes we do have, you can see here that the haptic has broken once you put it into the bag. So probably that is mainly because of not loading properly, and the pressure is on the haptic-optic junction where it has to be folded, not folded properly. So make sure that the folding is, loading is adequately good. Now, what happens if this happens? The other indications to remove the IOLs probably was spoken by our previous speakers, either high postoperative refractive error or extreme dysphotopsias, especially multifocals. I had done just one case for dysphotopsias and multifocals. And the available things are, you can do with small incisions only. One is the partial resection using hinge technique. This is most commonly used, or the full resection, transection. That is, you cut it into two pieces. There are many other techniques, but mostly we use the partial transection and the full transection. Most important is having micro instruments. These are very important. Many times in the initial part, when we had problems, we tried with our regular instrumentation. Maybe possible if you use Vanas, especially the new one, the fresh ones, but extremely difficult. So special instruments are now available with our Indian manufacturers only. So you need to have these cutting micro scissors for cutting. They are especially made with the saw type cutting edges and the micro forceps. Mostly we can borrow it from the VR friends also. It's very important to have these micro forceps and micro cutting scissors, because you have to protect the endothelium and the PC, and that will be even more disastrous if you don't have. So this is very important. The teeth in the microscopes helps to hold the microscope rigidly, and if the IOL is held perfectly stably, cutting will be as easy. So that is one important tip that all of you must remember when you have to cut. So this is one case where I do a full transaction. So holding the scissors, hold scissors, and you just need to go full cut. Make sure that the opening is quite big enough for you to go. Once the cut is full, Essentially, the eye optic is around 6 millimeter size. It cut into half, it will be 3 millimeters. So slightly increase the incision size to 3 millimeters, and then easily that can be dragged out. So that is one simple method. That is full transaction technique. Sometimes if it is difficult, you can just make mild adjustments. Since it's foldable, it definitely comes out easily. The same thing, if you have to do a partial dissection, this is a hinge technique. This is important to understand that you make the incision up to 3/4 and then just hold it and rotate it inside. You make the remaining uncut acts as a hinge, and you just have to rotate it and get it out. That is called the partial resection, transection and hinge technique. So that also serves as a good methodology of removing the IOL. Very simple, one or twice if you do, most of you can get this, and becomes very easy. Only thing is, make sure that you protect the PC and also the endothelium by using a good viscose. In this case, we made a partial dissection, transection. There is a small part that is available there. You just hold the optic hedge and then rotate it, optic head, get it out and rotate it slightly. The hinge acts as the remaining uncut port acts as a hinge, and then it can come out easily. This is the uncut portion. So holding the optic edge is very important. Just rotate it, and as you rotate it here, just have to rotate it. It comes out in one piece. Yeah, that's it. And for those of you who don't have the required instrumentation, our simple good old conversion into SACS works. This I did for an old case of high refractive surface -6 diopters, -6 diopters after 3 months, 4 months. Then we don't want to do, because we don't know how the adhesions are. But luckily for me, it was very easy. It just came out, and a good option for people who don't want to take risks to just go make a small SACS and just remove it out. So once it's in the bag, when it comes out in the bag, it's just easy, because you're just as you're putting through the SACS, it comes out. Several other techniques are there, essentially to remove through a 2.2, 2.4 millimeters. I have never used it, but it's there in the whole idea is, if you cut into a small triangle and use the remaining as a hinge and remove, you can remove through a 2.2. That is what the studies shows, and many people have done that. It is very easy to even remove through a 2.2 to 2.4 millimeter incision. So the idea is the 6 millimeters optic, if cut like this, just a small bit is cut like, looks very simple, but when doing, we feel that the partial transaction or complete transaction is more easier than this. And diagrammatically, this looks very simple. So to conclude, many techniques are available that allow explantation through the small clear. The simple techniques and effective ones are the complete transaction or the partial transactions, and obviously results are very good. And thank you once again, Jhos and Dr. Bharti, for giving me this opportunity.
Share. Please stop sharing. Thank you so much, Doctor.
Thank you.
You added a lot of significance to this session, and topics were very interesting. And please remain till the last, because in the last we will there will be few questions, and
definitely
we should maintain time. And the next speaker is Professor Dr. M. Vanathi from RPC AIIMS, and I request our treasurer. And before that, I would like to introduce to you our secretary and the treasurer. And the secretary and treasurer, they have really helped me a lot in conducting this. So our secretary, Dr. S.K. Mitra, is the anterior segment surgeon. He has served Tata Tin Plate Hospital for decades, 3 decades, chief eye specialist. He has his own setup and is the consultant eye specialist at Drishtidaan Peko Center. And our treasurer, Dr. Vibhuti Bhushan, as the secretary in the last term. He is SN Sankar Netralaya alumni. He's a trained VR there, and he runs his own center, Vishnu Netralaya. And above all, he's my dearest classmate. So now over to Dr. Vibhuti Bhushan for the introduction. Professor M. Vanathi.
Thank you, Dr. Bharti. Can you see the screen? Can you see my screen? Hello. Can you see my screen?
Yes.
Yeah. It's my honor and privilege to introduce Dr. M. Vanathi, who is the Professor of Ophthalmology, Cornea and Cataract and Refractive Services at the prestigious RP Center, AIIMS, New Delhi. And she is presently holding, she is the editor of Indian Journal of Ophthalmology for the session of 23 to 26. She is the reviewer of several indexed international journals. She has more than 150 international indexed publications. She has mentored more than 50 MD, PG thesis, PG guide, principal and co-investigator in intramural and extramural grants. She is the chief author of landmark review articles in Survey Ophthalmology, Surgical Techniques. She has been the invited faculty and speaker in more than 100 international and national conferences. She has been an invited speaker in more than 100 international and national conferences. She is a trainer in surgical training sessions of keratoplasty, and she was awarded the gold medal in IIRSI in 2013. She has also authored more than 50 chapters in national and international books. She has authored 2 popular textbooks in ophthalmology, the postgraduate ophthalmology and the undergraduate ophthalmology. She has a teaching experience of more than 18 years in RP Center, AIIMS, New Delhi. We are honored to have you, Dr. Vanathi. So please accept our regards and start with your presentation now. You are muted, ma'am.
Thank you, Dr. Vibhuti. Am I audible now?
Yes, ma'am.
I hope you can see my screen.
Yes, ma'am.
Yeah, okay. Thank you so much, Dr. Vibhuti and Dr. Bharti Kashyap and the entire executive of Jhos for having me for this wonderful session. I've been listening to all the talks since morning, and I think this is a very pertinent and a very useful session for all practitioners, especially as cataract is occupies the major space in our practices here. So I'm going to take you through for the next 8 minutes on hazy postoperative corneas, what next. I think there are multiple reasons, but I'm going to stick on to Descemet's membrane concerns here, much of which has been discussed in the previous by Dr. Madhu itself. I think tasks will be covered by my Dr. Murli, who's coming in after me. So I'm going to cover certain pertinent aspects which will be important for people who are looking at managing Descemet's membrane detachments postoperatively. So when you do see a cornea with undue corneal haziness, which is not in coherence with the intraoperative events here, and that's when you suspect an early Descemet's membrane detachment, a postoperative Descemet's membrane detachment. So I'm not touching on the intraoperative factors. So it is important to anticipate such an occurrence. So look at eyes which are at risk factors for development, particularly old patients, pre-existing endothelial disease like Fuchs endothelial dystrophy. The grade of cataracts, hard cataracts, pseudoexfoliation syndromes, you would probably find a higher incidence of postoperative Descemet's membrane detachments. Postoperative trauma cases here, and in cases where there are corneal morbidities here. So poor visual gain following surgeries, a translucent appearance of the cornea, and the slit lamp usually precludes a good evaluation of the Descemet's here. Sometimes if it's a bullous large detachment, you might find a double anterior chamber and undue corneal edema are going to be the salient features in when you're looking at postoperative hazy cornea. So these are some representative clinical pictures of how you could see a focal edema here. And if you go in and look at more closely, you would probably be able to find that the Descemet's detachment has started from the main site of the incision or from the stab incision where the surgery has occurred here. An ASOCT is recommended in these cases when you're not able to delineate it using your slit lamp. And that helps you to understand the configuration or the pattern of Descemet's membrane detachment, which helps you in the appropriate management of the Descemet's detachment here. I think I will skip largely most of the textbookish classifications, but just to be aware, you have the Samuel's classification, the McCool's and Jacob's classification, which is one of the latest, which is sort of akin to a retinal detachments. You can have regmatogenous, fractional detachments, bullous detachments, or complex detachments here. And testing whether it is planar or non-planar, depending upon whether it's less than 1 millimeter or more than 1 millimeter area, will help you to guide on the kind of management you need to adopt when you're looking at these postoperative detachments here. This is another excellent literature. These are two excellent literatures which are well quoted, and proud to say that they come from India here. The anterior segment OCT management algorithm and the help algorithm, which talk to you in detail. For those interested, I would refer you to go back and read up them to enhance your knowledge on these here. The help algorithm, based on the height of the detachment, the extent of the detachment, the length of the detachment, and the pupil and the relationship to the pupil, also helps you to guide on what would be the optimal modality for managing Descemet's membrane detachments. So what largely would help is to look at whether the placement of your detachment is superior or inferior, looking at whether it's planar or non-planar. Planar when it is less than 1 millimeter, non-planar when it's larger than 1 millimeter. Looking at the configuration of the detachments, whether they are simple detachments without any scrolling of the edges, and if they are more complex detachments with tears and scrolling of the edges. These are going to be primary factors which you would take into consideration when you are looking at managing the Descemet's membrane detachments here. Again, this is an excellent paper, again coming from India by Dr. Sinha and Dr. Dhruva et al. And this talks about the configuration or the pattern or imaging pattern of Descemet's, long-standing Descemet's detachments, especially in cases which have been, which need Descemet's endothelial keratoplasty for these here. And this really helps you to decide on the management required when you're planning DSEC and DMEX for these cases here. How do you go about managing this hazy corneas due to Descemet's detachments postoperatively? Conservative management for smaller detachments, which are more focal and localized, which are planar, do not have scrawled edges here. So manage the inflammation, give supportive therapy with antibiotics, hyperosmotic agents here, take care of the glaucoma, and that would largely help to settle small detachments. But when there are larger detachments and when that's one-eyed patients, you want a rapid visual recovery here. Detachments greater than 2 millimeters, detachments tending to involve the central part of the cornea here, and detachments are non-resolving to conservative medical management, you would want to approach by surgically here. Surgical options, what do you have available with you? Simple air injection into the anterior chamber, that's pneumatic descemetomexy. Mechanical tamponade can be aided with transcorneal suture fixations here. You can do descematotomies in when refractory cases and large detachments here. And again, stromal vent incisions for interface drainage would also be helpful. In long-standing chronic detachments, then you would need to consider endothelial keratoplasties here. I'll just quickly run you through two representative videos here. Here you have a Descemet's membrane detachment, postoperative hazy cornea, which you could see here. Go again 180 degrees diagonal to the region of Descemet's detachment here. And it's desirable to inject through a cannula here. And a single bubble injection is more desirable than causing multiple bubbles or fish egging, as you can see in this video here. So
Dr.
early
Minat,
yeah, I think I'm overshooting my time, so I'll just rush you through the second aspect of here, where you can partially do in place transcorneal suture fixation, especially if you have scrolled edges, and that will really help you to manage or help you the attachment to settle and without any postoperative concerns here. Can I stop here, or would you want me to continue to the next one as well?
Yes, yes.
Yeah. So
Let's
this is
continue with
why,
the next
yeah.
one.
This is one other scenario here. When you have this patient had come to us with a vision of 2/60 and multiple air injections done earlier here. So such refractory cases, and when you do find bullous detachments, that's when you would probably want to go in and use your stromal vent incisions for management of these cases. Here you see a large bullous detachment, limbus to limbus, and IOCT, if you do have it, really helps you to decide if you're going in the right plane here. So here you do have you can place stromal vent incisions, but be careful that you do not cause epithelial seeding and do not have infections in your stromal vent incisions. So this helps to drain the fluid collection between the detached desmids and the rest of the cornea here, and really helps the desmids to settle down here. I'll quickly take you through wound burns here with the next minute or so. I think most of us do not have wound burns right now because of the various evolutions of both technology and the surgical techniques as well. But if you're doing in hard cataracts, high phaco powers with higher frictional movements of your phaco needles, one other common cause is obstruction by ocular viscoelastic devices here. Tight kinking of your sleeve with a very tight wound. These are going to be common risk factors here. So look at the amount of ultrasonic energy you're using, and always tighter it to the severity or the density of the nucleus which is being dealt with. Choose the right phaco tip here. Effective fluidic cooling by the phaco tip mechanism you are using here, and always do remove the phaco. Do a little irrigation before you dig into your needle to remove off or take away any clogging ocular viscoelastic, which can lead to an increased wound heat generation of your cases. What do you do when you have them? And then if it causes a wound gape, you probably would need to suture here. You would probably need to suture your wound, or secure your wound with the glue application and bandage contact lenses. You would not need AMG in most of your cases here. Control IOP, give antibiotics and anti-glaucoma agents, and very extensive burns which lead on to MELS will need scleral patch grafts here. These are representative pictures which I did borrow from the net here. Delayed wound healing, fistula formations, iris prolapses, astigmatism when once healing occurs because of the scarring, wound infection are the complications which one need to look at. I think I would stop and not cover tasks which would be taken up by my next speaker. And I wish to thank the Jhos executive team and Dr. Bharati in particular for having me in this wonderful session. Thank you for your attention.
Thank you, ma'am.
Thank you, ma'am. So please remain because there is a discussion in the last, and the senior person, Dr. Kaushik Murli. So he will be talking on severe postoperative inflammation on first post-op day. And Dr. Vibhuti Bhushan, please introduce him. Dr. Vibhuti Bhushan, please introduce Dr. Kaushik Murli. He is the chief of Sankara Group of chain of eye hospitals. The Sankara Group is the largest group of eye hospitals.
Can you go ahead and introduce him? I have some technical issue here.
Please share, Dr. Kaushik. I have to introduce him. You have. Okay.
Can I start, ma'am?
No, I have to introduce you. So Dr. Vibhuti Bhushan had to introduce you. There is some problem. So I am connecting. Dr. Kaushik Murli. Can you see?
No. Yeah.
Can you see?
Yes.
Yes.
Yeah, we can see.
I cannot see the fully. Cannot see fully.
Make it full screen. Oh, it's make it full screen.
So I'm going to read a few lines. Dr. Kaushik Murli is the President, Medical Administration, Shankara Eye Foundation, India, and a pediatric ophthalmologist. The Shankara Group has 13 specialty eye hospitals across India and is one of the world's largest community eye care provider. And they have collaborated with institutions like the Harvard, the School of Public Health, University of Bonn, the London School of Hygiene and Tropical Health, and Microsoft Research on various public health research projects. He is currently Chair Scientific Committee of the Vision 2020 India, 25 publications in ophthalmology and various awards and national and international platforms. Part of the core committee organizing the G20 Young Entrepreneur Alliance meet in India. Wow. He was part of the Indian delegation at the G20 Young Entrepreneur Alliance in 2018 and lead the India delegation at the India Israel Forum. So welcome. Welcome, Dr. Kaushik Murli.
Welcome, Dr. Kaushik. Yeah.
Could I?
Yes, please share your screen, Dr. Kaushik.
Yes, ma'am. Just give me a minute. So thank you so much to the executive of Jhos for inviting me to be a part of this midterm conference. I'm going to be talking about severe postoperative inflammation in the first postoperative day. What next? I would like to acknowledge my colleagues, Dr. Simran and Dr. Minija, who helped me with some of the content and the videos that I would be sharing as a part of this presentation. So for most of us, just before we operate, our big dream is we want to be sure that we don't have any complications. We want to make sure that the IOL is in the bag. We probably don't want to have a wound burn like Dr. Vanati has just shared. We want a crystal clear cornea, and we are hoping that the patient manages to see an uncorrected 6/6 the next postoperative day. But that unfortunately is never the reality. The next morning you wake up, you go do your postoperative rounds, and you see a variety of these conditions that just scares you, right? From a little blood clot in the eye to fibrin membrane to maybe some retained cortex. And then you see a hypopyon where the cornea is hazy and you're completely confused as to how you're going to manage about it. So this is something that you cannot wish away. With the number of surgeries that you do, you will end up with inflammation, because inflammation management becomes a part of the eye surgeon's postoperative recovery plan. So we do, as a part of most of our regimens, include some kind of an anti-inflammatory medication, anticipating this to happen. And the mechanism has been shown to be a break in the blood-aqueous barrier, and typically inflammation does resolve within 2 to 4 weeks in a majority of cases. But it's not just enough for us to wait for those 4 weeks, but to see if we can do something a little more proactively on the first postoperative day itself. The various risk factors that are there for postoperative inflammation include a long operative time. Any patient who's had a prior surgery, if you've had an intraoperative complication, then definitely, yes, we will see complications. And then if you're going to be handling other structures within the eye as a part of your cataract, then again, there is a high risk of postoperative inflammation being seen. But first thing first, even before when you're seeing on the first postoperative day, sometimes in a busy practice, you may not have paid much attention to the history that the patient has. So here is one patient where we had seen that on history and even on the preoperative examination, it had recurrent attacks of uveitis, and he was shown to have been diagnosed with a complicated cataract with a peripheral anterior side decay. So these are quite common for all of us that we get to handle. And we need to again be sure that we're managing these quite appropriately. So you need to give adequate time control the inflammation preoperatively, not be in a hurry. You use perioperative steroids again to reduce the postoperative inflammation and the cystoid macular edema that you do anticipate in these patients. Most modern IOLs come with very good UVL compatibility, so you are quite good there. And where you've done this good perioperative kind of a planning, patients do get a very good visual outcome. So it is very important for us to look back as we look ahead to in some of these cases. So where you know that you're going to end up with inflammation, there is no real protocol per se, or there are no guidelines, but this is something that we have evolved across our organization over the last few years. In mild to moderate inflammation with grade 2, 3 cells, we use topical steroids, typically prednisolone acetate 6 to 8 times a day with a tapering regimen. In severe inflammation with the fibrin membrane formation and hypopyon, sometimes a subconjunctival mitricaine with dexamethasone could be given, along with maybe a loading of hourly topical steroids. Topical cycloplegics do relieve pain and reduce inflammation. Atropine eye drops, we limit it to very severe inflammation because, again, the photophobia lasts much longer than even after the inflammation has subsided. And wherever there is some persistence of this inflammation, oral steroids at a dose of 1 milligram per kg body weight could also be started. Now, when you talk of mitricaine, this becomes an armament that we quite often use. So again, typically, for those of you listening in, this is a mix of lignocaine, atropine, and adrenaline. So this is then reconstituted. So you use typically a 1 ml insulin syringe, and then in case you're using decadron, again, you can add about 4 milligrams to it. And you could inject it either in the inferior fornicial area or even in the superior bulbar conjunctiva. Inferior fornice is just easier because you ask the patient to look up and you have adequate space. So for the beginners, it becomes much easier. You're not worried about perforating any blood vessel inadvertently. So from that standpoint, this becomes the first tool that anybody can use. We've looked at the preoperative history. We've looked at some inflammation. The next most common reason is something that's happened in the surgery. So again, this is another patient who had inflammation from the first 5 that I showed, but the OT note showed that this was a 4 millimeter pupil that was not dilating further. And then the surgeon had in very small handwriting written minimal residual cortex left, post-operative, probably conservative management. So again, there are no rules in terms of when do you re-intervene and go in for an anterior chamber wash where you remove the cortex. But typically, anything that is beyond about 3 clock hours, it would be prudent for you to do an AC wash. Although if it is in the inferior quadrant, it is likely that it will get resolved over time. But in the interim period, the patient could have an increased intraocular pressure and other problems. What is most scariest for us is a picture like this, TAS, or the toxic anterior segment syndrome, which occurs when toxic substances enter the anterior chamber.
Doctor, 1 minute left.
This is a sterile, non-infectious postoperative inflammatory response, typically seen in 12 to 48 hours. You see decreased visual acuity, limbus to limbus edema, raised IOP, hypopyon, fibrin formation, irregular pupil, and there is mild pain and redness. 4 situations typically result in TAS: inadequate sterilization of instruments, enzymes and detergents that remain on these clean instruments, the endotoxins contamination that happens during this process, and some preservatives of products and medications that leak into the eye. So this is something that you need to be very aware about. First and foremost, do share it with your fellow colleagues. So if you're part of the JHOS, be sure to talk to other colleagues to find out whether any of them have been using it. If you're sharing operating facilities, again, you need to discuss with it. Look at any recent changes in the inventory. You may not be aware of it, but the stores or the inventory person may have changed one consumable because it was not available that day. Again, you need to be wary that you need to look for any regional outbreak if there is a larger cluster geographically or even within your institution. But it would be prudent if you have multiple cases to shut down your operating room, do some cultures, look at your cleaning protocol, recheck how your disposables are being used and ordered, and interview other surgical staff members to see whether any changes in the protocol have been done. You know, on the first post-operative day, if you see inflammation, it is honestly not very likely to be endophthalmitis. But however, as surgeons, it is prudent for us to assume it is an endof unless it's proven otherwise. You could do an AC tap or a vitreous biopsy, and typically you would continue on systemic steroids and you would suspend further surgery until you're clear about where the etiology is. So you don't want a cluster looming around you. If you have multiple cases, whether it's the TAS or an endof, the investigation remains pretty much the same. Look at patient common factors, You would want to look at any consumables that have been changed, whether they are outdated. You may want to even culture them to look for any contamination. You know that there is an interplay of patient factors, consumables, and the surgical environment. Be sure that your environment is okay. You may do cultures, look at your HEPA, look at your operation theater environment, and go ahead with it. As surgeons, yes, we think that we are very good, but we need to understand the outcomes are dependent not just on us to not have inflammation. We need good instruments, clean consumables, a good mentor and a trainer, somebody to hold us back so that every patient of ours can see that wonderful morning sunrise the next day post-surgery. So once again, thank you so much to the team at JHOS for inviting me to be a part of this talk.
Great. करो यही हो जाता है हमेशा.
Dr. Kaushik, can I ask you a very small question, quick one?
Yes, yes.
Yes, sir.
When did this term TAS was coined and recognized? Because this has been happening.
I'm not offhand able to recollect a particular date, sir. But I think it has become very fashionable for us to blame everything as TAS now. Because we don't want to sometimes take onus on what is happening. Because it's very easy for us to deflect blame on a consumable. So although TAS is something that we do see, I will need to go back probably when the question answer comes, I'll revert back with a more specific answer.
Probably 2013, 14, or even earlier. The term coined. Okay, thank you. Please go ahead.
Any question from Konya people? Any question from anyone?
Is it the question and answer session now?
No, actually Dr. Deepak Lakra is our local Jhos speaker. So that's why I was just asking if anyone has to ask question, because a lot of question answer has taken place after Madhu Raju's talk. So it has already been taken place. So, after one talk, again, I will invite people for discussion. So over to Dr. Deepak Lakra. He is the professor of ophthalmology in the largest medical college of Jharkhand, Regional Institute of Ophthalmology, RIMS Ranchi. And he's a cataract and glaucoma person. And recently he did a few keratoplasties also. So over to Dr. Deepak Lakra. Dr. Deepak, please share your screen.
Dr. Deepak, unmute yourself and share your screen.
Okay, sir.
Yeah.
It is visible?
Yes.
Visible, okay.
Make it full screen.
Okay, thanks, madam, for okay. My topic is extremely disturbing post-operative floaters. Already it is discussed by Dr. Pillai very nicely. So what is the floaters? Floaters are the tiny bit of protein or cells that float in the vitreous cavity. That may be APS, black, gray, white, yellowish, greenish spot, which is moving with the changes of gaze. Everyone got the floater at some times, and many people ignore them, and many may notice them when they look to the blind. American Society of Retina Specialists recommended that the person who noticed sudden symptom of floaters within a few months should check any sign of more serious disease. Cause of floaters, one is first is the age due to the posterior detachment, then bleeding due to the injury. There may be infection or inflammation, and there is a blood cells which is due to the retina tear or detachment, or there is a pigment which is also due to the retinal tear or detachment. Post-operative floaters most commonly are due to the pre-existing posterior vitreous detachment, or the posterior vitreous detachment occurs after the surgery. Then inflammation or infection and the retinal tear or detachment. So the posterior vitreous detachment, it is the floaters appears as a large cowl or multiple string type, and sometimes associated with the flashes of light. Translucent string or spider web-like images that are more prominent noticed during the hand or eye movement. These floaters usually disappear within the 6 months of the time. The problem occurs when the floater does not become translucent or doesn't settle down. The bleeding may be occur when the vitreous spills of the optic nerve or causing the retinal tear. These blood stain the translucent vitreous and make them more opaque. The PVD is due to the weakening of the posterior vitreous cortex and the inner limiting membrane of the retina. So detached vitreous move towards the center of the retina, and with the movement of the creating a moving shadow that is perceived by the patient as a floaters. Axial myopia and post-menopausal women are more predisposed to the PVD. Inflammation of the evil tissue or intraocular part of the eye. The inflammatory cells causing the floaters. We treat these with a steroid or NSAID to reduce the inflammation, and these floaters can be disappear. Retinal tear detachment. During the process of PVD, there is the chances of retinal tear or detachment which leads to the liberation of protein or the bloods. So during the clinical evaluation, thorough examination with indirect ophthalmoscopy with scleral indentation to rule out the peripheral degeneration, retinal tear or detachment. When we have to worry about the floaters, mild eye floaters are accepted after the cataract surgery, which are asymptomatic in 95% of cases. However, when the floater first appear, ophthalmic evaluation is required. If the floaters is appear suddenly, or there is multiple in number, or if they impair the vision, needs to see the eye specialist to rule out the PVD, which can be retinal tear or the tear of the blood vessel. If the floaters contain blood, in 85% of times it associated with the retinal tear. If the patient develop floaters or already have latex degeneration or the family history of retinal detachment, urgent consultation are needed. Where we have to treat or not. Mainly floaters are two groups: the posterior vitreous detachment and the myopic vitreopathy. Most of the time, patient can cope with them, and because the brain is neuroadept. Many of the patients are ignored by the medical profession because the complaint is not fit into the diagnostic box. But this doesn't mean that they don't have any problem. Floaters due to the dense vitreous cortex, the patient doesn't able to adapt these floaters, and this leads to the surgical intervention. How to document the floaters? First, the contrast sensitive testing. It is the best way to decide whether vitrectomy we go for vitrectomy or not. If the patient have decreased contrast sensitivity, cloudy floaters, especially when the posterior vitreous face is thickened or partially opacity, these are usually not resolved, and this requires the surgery. Ultrasound, if the bothersome symptoms or discrete floaters which describe the daily life, it is better to do ultrasound of the eye, which can be seen as a vitreous floaters, as you can see in the picture. And this is called the Weiss ring. Now, how to manage? The first is the observation. Most of the floaters are resolved within the 6 week to 6 months of time. If the vitreous floaters persist, they can be neuroadapt by the patient and ask the patient to ignore them. Even the floaters is persist and disturbing the daily life of the patient, then further evaluation is needed. The second is the vitreolysis with the ND-YAG laser. If the patient not willing for the vitrectomy, those cases we can do the vitreolysis with the ND-YAG laser. But there is side effect as a glaucoma, retinal detachment, retinal tear, hemorrhage. But the advantage is there is no risk of infection, low risk of raised intraocular pressure, low risk of worsening of the floaters. The efficacy of vitreolysis is controversy. The ND-YAG laser is ineffective and potentially unsafe for the treatment of posterior located vitreous opacity. Limitations are these vitreolysis with the ND-YAG laser is used only for ND-YAG laser or for PCO and iodotomy. The light is oblique, so you can't see behind the capsule, and the energy delivery system is not optimized. Then pars plana vitrectomy, for this, the preoperative contrast sensitivity function testing and ultrasound of the eye is needed for assessment. And the visual acuity, when decreased by two lines with the floaters, these patients can be taken for the vitrectomy. The complete ophthalmic examination should be done, including the indirect ophthalmoscopy with scleral indentation to rule out the retinal tear. The pars plana vitrectomy provides the definitive cure to the floaters, although the surgery is not without risks. There may be risk is endophthalmitis, retinal tear, retinal detachment, glaucoma, and vitreous hemorrhage. But the modern 25 gauge or 27 gauge vitrectomy and techniques helps in reducing the risk of the surgical complication. Pars plana vitrectomy can be both effective and safe management for the unresolving vitreous opacity. Number of study demonstrated that the successful pars plana vitrectomy improves the functional measure of the contrast sensitivity. Minimum invasive vitrectomy, that is core vitrectomy, in which the contrast sensitivity is normalized within the 1 week and it persists, remains stable for 3 to 9 months. So in summary, the impact of floaters on the patient after the post-operative period is period affect the quality of life, life and the vision. So however, they can be sign of more visually threatening complications such as the retinal tear or detachment. So it is incumbent upon the ophthalmic surgeon to offer the safe and effective management of the condition as either keep it observation or do the anti-YAG laser vitrectomy or lastly the pars plana vitrectomy. Thank you for listening.
Sir, will you allow me 2 points to say?
Yes.
A word of caution is number one. If the patient complains of floaters and if you examine the patient, okay, go ahead, do the endoscopy and thoroughly and after doing indentation and all that. But if the patient is not satisfied and comes to you again, you should be examining again. You do the endoscopy again. This is very, very important. Point number one. Point number two, if the patient has floaters and if you examine and you found that they're horseshoe tear, right? So you seal the hole, you barrage the hole, and you're happy that you have saved the eye. But you must explain the patient that the floaters are going to remain because the patient does not know what have you done. Because the patient didn't develop detachment. So the patient had the same problem. And after you charged him and did the laser barraging, the patient has the floaters again. So you have to be very, very careful and explain the patient that the floaters are going to remain. There are 2 points I wanted to make. Thank you very much.
Definitely, sir. Okay. Thank you, sir.
Yes, very practical approach. So we have to explain the patients that many times it persists after the treatment. And any question to the cornea people? Dr. Pooja, Dr. Nidhi?
Excuse me, ma'am, I'm having one question.
Yes.
With Dr. Vanati, ma'am.
Yes.
So what timeline for the decision of in DM detachment we should go for, or any other clinical sign pertaining to whether the DM detachment management can be done with the just air tamponade or endothelial keratoplasty is needed? I mean, is there any timeline or clinical guideline wherein we can decide that whether we should send directly the patient for endothelial keratoplasty, or we should try for the conservative management in the form of air tamponade?
Yeah. Hi, Dr. Nitin, can you hear me?
Yeah.
Yes, I think these are the pertinent points and concerns when one is looking at a Descemet's membrane detachment here. Several times, I think in corneas at risk, you would be able to see that subtle detachments or descetotomies at the site of your side ports or your main incisions here. And if you find that these are unduly loose, then I do go ahead and put in a suture then and there itself sometimes, so that this does not worsen postoperatively, especially in high-risk cases. That said, it's not required in most, but those in which you want to avoid a postoperative intervention and those in which you feel it's going to increase, or in those where you have had a higher manipulation. I think the simplest way of managing is preventing. The way you go in and out with your equipments, the orientation of your needles, and the frequency of entry and exit to be kept to as minimal as possible. That works a lot in preventing, and the sharpness of the instruments which you're using. That also helps. When you're looking at interventions, if they are small ones, shallow detachments, focal, then most of them settle with just medical management over a week or two. But if they're going to stay on for beyond about a week to 10 days, they are threatening involvement of the central cornea. they are one-eyed patients and their eyes at risk, then I would go in for an earlier management in these patients. Whether you want to just put in a air filling of the anterior chamber, whether you want to aid it with a transscleral fixation will depend upon the configuration of the Descemet's department you're dealing with here. If you're having more complex detachments, meaning they are involving superior cornea, they are larger tears here, they are folded, they are scrawled, that's when you probably conventional management is not going to help and you would go in for an earlier management. Again, I have handled detachments which have lasted for more than 2 to 4 weeks with multiple detachments. That particular one which I showed you was on for 3 weeks here, where I had used interstromal vent incisions. But that's when looking at the configuration with an ASOCT, and that one particularly had a large fluid collection between the detached descemet's and the stroma, and that's why every time the bubbling was done, it was not helping. So the fluid had to be let out by stromal vent incisions, and that is what helped in its settling. And the patient gained 618 post-op in about 3 to 4 days here. So again, it depends largely by your clinical findings here, by the configuration of your Descemet's detachments. But by and large, if you've had it for more than 4 weeks, complex detachments, multiple bubblings, they are rolled configurations and with tears, these are not very successful in getting managed by simple air injections or by adjuvant procedures. And these are cases which better you would send over to your corneal colleague. A simple guide is look at the ASOCT, look at the corneal edema, and if the edema is not resolving, if it is worsening, if your haze is increasing, then an early endothelial keratoplasty gives you fantastic outcomes as it prevents haziness, subepithelial scarring, bullae formation, which all will give you a better prognosis, and you will land up with a 6-9 post-op when you take them for an early DMEC and a DSEC.
Thank you very much, ma'am. One last question, ma'am. When you are giving air tamponade, you find that next day that DM detachment is there and manageable with air tamponade. Is there any particular timeline that you follow, that 1 hour, 2 hour, 3 hour, any?
I largely avoid giving a limbus to limbus air fill in these patients here, and especially avoid in eyes which are, have compromised optic nerves, as you have glaucomatous optic atrophies or you have anterior ischemic optic neuropathies, operated VR patients, and pre-existing posterior segment pathologies here. So here, a full fill is usually not possible in these cases, and that's where you would probably want to add on a suture as well, especially if it's an operated VR. You've done a scleral fixated eye, or there have been multiple manipulations. These are eyes which are going to be at risk over here. And if you're looking at the duration of pathology for a small tear, then I would leave a suboptimal fill, meaning 2/3 or less than 2/3, or I would leave a small part of the pupil which is free of air. That would prevent a pupillary block glaucoma here. But if you're anticipating a pupillary block glaucoma, if it is a large bullous detachment, if you feel you need to give a full limbus to limbus air fill, in such patients, dilate the patients on your table itself. So that helps you. And I do give them, I review them, say 6 hours later. And if you want to give a postoperative mannitol, then that's something which you can resort to here. That said and done, I do not adopt it. And again, as it was pointed out earlier by Dr. Madhu as well, when we do DSECs and we are doing DMECs here, DSECs, especially if you're attaching a larger tissue here, the airflow which we keep is only not more than 8 minutes, and a supine posture. So these two are more imperative. So I do emphasize on the patient that they do not lie down onto their sides, and they avoid getting up and stay supine except for the time they have to go to the restroom, at least for 24 hours. This works well in most of the cases.
Thank you so much,
ma'am. One question, ma'am. Hello?
Yes, Dr. Pinky, I can hear you.
Yeah, ma'am. Good morning, ma'am.
Morning.
One question from my part, ma'am. After the post of corneal edema, what is the dose of hypertonic solution, and Dimoxystazolamide, what is the duration? It is very beneficial for those patients. And if we give any hypertonic solution to the patient, so how much we can decide the duration, ma'am? Because the patient is very much, we can judge that, we can move for the long time, the corneal edema is subsided or not, and we can throw out the medicine and all these things. But what is the guideline for the medical part, ma'am, please?
I think you're trying to ask me how long a vial can be kept. Is that your question, or what is the duration of the medication?
Ma'am, how much
To be
what is
used?
the
Okay.
duration?
See, if you find the patient is reliable and the patient can tolerate drops, or it's not going to squeeze it out, Hyposol 5% eye drops. It's a very severe edemas. I add on Hyposol 6 eye ointments for these patients here. Okay. And again, I would titrate it to the severity or the ocular surface pathologies like pre-existing dry eyes, which they have here. And when you're dealing with compromised corneas, please do remember a dosage of 5 days of antibiotics and surface potent steroids or low potency steroids will help in the rapid clearing of the edema. Watch the edema in terms of the corneal thickness, and you can have a clinical impression on your slit lamp, or you can do an ASOCT to document the progress. And this will help you to decide if your treatment is actually bringing out an outcome or not. I also add on anti-glaucoma medications, but when the surface is more inflamed, you are using a lot of topical drops. I give an oral acetazolamide for these patients here. But if your surface is reasonably good here and the patient is compliant and can tolerate the number of medications you're giving, then you can decide on adding on 1 or 2 anti-glaucoma medications here. I would roughly keep the duration as much as is required and as much can be tolerated by the patient. So that's going to be your duration. And if you know the pathology is bad, then it is not going to help for a long period of time. So you cannot give acetazolamide indefinitely for a patient. You will have to look at the systemic side effects before you take on. For some patients, systemic side effects come within 2 to 3 days. For some patients, they tolerate more even for 2 to 3 weeks. So that's going to be a patient-to-patient approach for these things, for these scenarios.
Ma'am, what is the pro-kinase inhibitor like Ripatech in the market? How they helpful for the
use of netarsudil and its type in the scenario of an edematous cornea and raised pressures will lead on to the very classical reticular epithelial cell edema, which is reticular pattern of edema. So these are the two scenarios. If you want to give these Rho kinase inhibitors in a scenario of corneal edema and raised pressures, you will get reticular epithelial pattern of edema, which will only resolve on stopping these medications. So ideally, I don't use them when they are going to be used on. But again, if the pressure is so high, your glaucoma colleague usually does step in these here. So I don't use so much of Rho kinase in a scenario of edematous cornea with very high pressures.
Okay, ma'am.
So now let us move to Dr. Nidhi.
Yeah. Good afternoon, ma'am.
Hi, Nidhi. Hi.
Hello, ma'am. Ma'am, I wanted to ask what would be the difference in approach in treating a taut DMD versus one with rolled edges? Because as you said, even in rolled edges, after 3-4 weeks, there might not be a good outcome post-operative.
Yes.
But in few cases, I have done them even at 6 weeks and they have responded well. While in taut DM detachments, I don't know what is the cutoff when we would maybe attempt a decimatotomy and do a tamponade or directly move on to an EK.
Okay. See, in a taut Descemet's membrane, there are 2 factors. So one is that it is probably limbus to limbus sometimes. And 2 is there is a fluid collection between the detached Descemet's and you have the stroma here. So simple air fills will not allow your Descemet's to settle back because there is no way of the fluid to get drained. That's when you're probably going to go in and do a descematotomy here. So your positioning of descematotomy should be such that it's not going to cross a scrolling here. So that's when your good visualization and your planning of how and where you're going to enter from is going to be important in these cases. Otherwise, you might land up, you might feel you would have bubbled, but you would have actually crossed a scroll or tear, and it would have complicated. And such cases generally come to you when they are bad cases. They are hard cataracts or pseudo exfoliation, multiple bubblings done by the surgeons themselves. And when they come to you, you will find this scenario here. And I will agree that the success rate in managing these is not good, and you would probably have to plan on an early DMEC or a DSEC. When you're already seeing a significant amount of stromal haze which is setting in, when your desmoids has remained detached for more than 3 to 4 weeks, that's when I am going to consider alternatives here. I don't prefer to do a desmototomy from inside. I would prefer stromal vent incisions. You can move them away from the paracentral cornea, but again, be careful if you have an IOCT guided, or if you're able to assess on table, and don't go too much and just nudge the corneal thickness and see and stop when the fluid flows out. That itself helps in a lot of settling.
Yes, thank you.
Thank you so much for having me on. And
we are getting delayed. We are half an hour delayed. Thank you so much, madam, because there is a lot of discussion went on your topic. So we are moving to the next, the prestigious R.P. Tandon extramural oration. And this time the oration recipient is Dr. Somashila Murthy from LVPI. So the session coordinators are Dr. Dolly Tandon, Dr. Vibhuti Bhushan, chairperson, our president, Dr. Rajmohan, our past president, Dr. Surendra Singh. They all have joined. Our past president, Dr. Lalit Jain, our past president and current managing committee member, Dr. BP Kashyap, our immediate past president, Dr. Anand Thakur, our president-elect, Dr. Rajnikant Sinha, our secretary, Dr. S.K. Mitra, and myself, and Dr. Dolly Tandon, who is going to introduce our oration awardee. Dr. Dolly Tandon is the worthy daughter of worthy father, Dr. R.P. Tandon, and she has done, she is an SN alumni, and she is a prolific cataract and glaucoma surgeon. So over to Dr. Dolly Tandon for introduction of Dr. Somashila Murthy, our prestigious R.P. Tandon oration recipient. Dr. Dolly Tandon, madam, please unmute yourself and share this. Yes.
Good afternoon, everyone. I'm happy to introduce Dr. Somashila Murthy for the Dr. R.P. Tandon Oration Award 2023. Dr. Somashila Murthy has an extensive experience in conducting clinical trials. Dr. Somashila Murthy is an alumna of PYL Nair Charitable Hospital in Mumbai and has done a specialization in ophthalmology at Lokmanya Tilak Municipal Medical College, Mumbai. She completed her clinical fellowship in cornea and anterior segment disease from L.V. Prasad Eye Institute and uveitis and ocular pathology from Doheny Eye Institute at the University of Southern California, Keck School of Medicine, Los Angeles. She then joined LVP Eye Institute as a faculty. After completing a successful 22 years, of which she served as the head of cornea for the last 10 years, she currently is on deputation and works as medical director of Shantilal Sanghvi Eye Institute. Her areas of clinical and research expertise include diseases of the cornea and anterior segment, uveitis, and ocular inflammation. And surgical expertise includes corneal transplant surgery, corneal trauma, refractive surgery, and cataract surgery, especially complicated and uveitic cataract. She has extensive experience in conducting clinical trials as principal and co-investigator and has participated in over 20 clinical trials. She has to her credit over 150 publications in peer-reviewed international ophthalmology journals. She is an acclaimed speaker and has 200 talks at various national forums and regularly presents scientific papers at international ophthalmology meetings. As an acknowledgement of her achievement, she was awarded the Achievement Award from the American Academy of Ophthalmology in 2015. She has also won several national awards, such as the Best Free Paper Award in Cataract and Uveitis session at the All India Ophthalmology Society Congress, apart from Best Paper and Best Poster awards at the national and international meetings. Apart from her work at LBP, she is passionate about mentoring women entrepreneurs and participating in team building activities. She is currently part of the All India Ophthalmology Society governing body as a member of the scientific committee for the second term. Her motto is, "Be the difference that you want to see." Thank you so much, Dr. Somashila Murthy. Over to you now.
A very good morning to everyone, and thank you so much, Dr. Bharti, and for having me here, and thank you, Dr. Tandon, for a very nice introduction. I just like to say that my name is Somashila Murthy, and I like cornea and uvea. It is a great honor indeed to be bestowed the oration. And before I start my talk, I would like to introduce Professor, of course, at this forum, there is no need to introduce him. But honestly, I did not know much about Professor R.P. Tandon till I read about him, and I'm so impressed and I'm so honored to be giving this oration. So he was one of the most prominent members of the fraternity, especially Jhos, and those who had the privilege of knowing him would fondly remember him as a distinguished ophthalmologist and a wonderful human being. He was very knowledgeable and he had immense wisdom. If there was one trait that defined him, it was his quest for knowledge, is what all his contemporaries and his juniors would say. He was a voracious reader and he imbibed everything that he read, and he could talk on any subject from ophthalmology to oceanology, from philosophy to politics, from to economics, and from history to the latest gossip. He was a great communicator, and once he got onto a topic, you could not but be charmed by his clarity of vision and oratory skill, and he had a natural gleam in his eyes and a mesmerizing smile, as you could see in the photograph. Coming to his education, he did his early education in a prestigious school, St. Michael's School in Patna. He did his MBBS from the prestigious Prince of Wales Medical College in Patna in 1954, and his MS Ophthalmology in 1957 from the same college. He first started his career as joining the Bihar Health Services, where he was first posted at the historic Bodh Gaya. He then went overseas for training. He did his DO, he did his FRCS in 1959, and in 1964 he completed his FRCS. And then he came back to India and he joined the Rajendra Medical College in Ranchi, and he was there for the next 10 years. Ultimately, he left government service in 1975, and then he went on to full-time private practice at Ranchi. At the same time, there was liberalization of the economy, and he was a first mover. He was able to grab the opportunity and upgraded his clinic with the latest equipment and technology. And he was very popular amongst his colleagues. To them, he was just Tandon. Coming to his clinical and surgical skills, he was a clinician par excellence. Surgically, he was gifted. His clinical knowledge and wisdom was immense. And most of the who's who of Ranchi really went to him for advice and treatment. And he had patients coming in all over from the areas in and around Ranchi. Coming to his professional activities, he was a founding member of the Academic Medical Forum. With being its founding secretary, he wrote the constitution of the forum and later on became its president as well. He was president of the Bihar Ophthalmological Society, and he also received the Lifetime Achievement Award in 2006 from the Jhos Society. His other achievements included receiving the Most Outstanding Ophthalmology Award of Ranchi in 2000 for his leadership and above all for his being a fine model of a cultured human being. And as I mentioned, his culmination was a Lifetime Achievement Award from the Jharkhand Ophthalmological Society. that was not all that he had to his personality. He had so many facets. He was a voracious reader as well as a writer, book author, and he wrote several books during his lifetime. And apart from just the academic fora and societies, he was also a member of the Sri Satya Sai Seva Trust and the Sri Satya organization. So with that, he left behind a legacy, a great legacy, and I'm sure that the vacuum that he has created cannot be filled. He's left behind his wife and his 4 daughters, of which Dr. Dolly Tandon, we just heard from her, is an active member of the Jharkhand Ophthalmological Society. So I'm extremely humble reading about him and seeing about his life, and I'm deeply honored to be presenting the deemed oration in his name for the Jharkhand Ophthalmological Society meeting. So when I was thinking of what topic to choose, I thought that I should choose a topic which is relevant to everyone, which is what we commonly see in practice. And I thought I would take you through infectious keratitis, 10 tips to guide your practice. Dr. Bharti, am I audible?
You are audible.
All right. And the slides the slides are visible, right?
The slides we can't
Not
see.
yet, not yet.
Not yet. Okay. Can you see the slides now?
No.
Okay.
Now it's visible.
Okay. So yeah. So now you can see that.
Yes.
All right. Is that yes or a no?
Yes, yes.
Okay, great. So we all know that infectious keratitis is somewhat common problem that almost all of us, whether we are general ophthalmologists or cornea specialists, end up seeing at least, if not frequently, at least occasionally in our practice. Unfortunately, it is more common in developing countries because of the incidence of trauma and agricultural background. Overall, it accounts for a fairly large population of corneal blind in India. And amongst all the corneal blind, 50% of these are either due to childhood keratitis or adult keratitis. So therefore, if we have early treatment of microbial keratitis, obviously we can limit these numbers. So the etiology, if you read various studies, will show that most of the time it's bacteria that are frequently noted. Whereas when you look at the hospital-based, it's fungal and bacterial are almost equal. But when you talk about community-based, then bacterial is higher. So that was my first tip, in that the community-based practice, bacterial will be higher. The next thing I had is that the clinical evaluation. So not just the onset, progress, treatment, response, or history of trauma, but when you see the patient, for example, this picture here is of a patient with contact lens wear, and the patient comes with infection, but you really have to ask that, what the patient sometimes may not give the history. This is another patient who has a corneal transplant, and this infection is because there was a loose suture, which was noted even at the previous visit, but perhaps was overlooked to be removed. This is a patient who has a cataract surgical wound, and there were loose sutures in there. They were not removed after the cataract surgery, and look how the infection has advanced. Sometimes the patient doesn't come to us right away. So contact lens wear, past surgery, associated ocular disease, and sometimes even systemic illnesses like uncontrolled diabetes or certain other infections, say leprosy, with corneal anesthesia. So these are some of the conditions we should look for, and that is tip number 2. This is a patient with past RK in the past, and so these patients have deposits within the RK scars and are also prone to infection. So in addition to our history taking, we should check for corneal sensations. Sometimes neurotrophic corneas are more prone to infection. We should check for dry eye, check for the nasolacrimal duct if there's any obstruction, check if lids and lashes are malpositioned, or if the patient has a missed foreign body. So coming to what we must know. So we must, of course, know about the commonly encountered infections. It's good to know about the uncommonly encountered infections. And then it's also good to know about non-infectious keratitis, because sometimes they look like infection. So bacterial keratitis due to gram-positive cocci is one of the commonest. You can have a rounded infiltrate like this, not too severe infection, or you can have multiple such infections somewhere here, almost like a staphylococcal marginal keratitis, but this has ulceration and it also grew gram-positive cocci, and there's a main focus over here. And you can have suture related, so loose suture for the patient with ECCE, you can have suture related keratitis, or sometimes you can have very severe looking, even these corneas will rapidly melt. So this was a patient who had a nasolacrimal duct obstruction and presented in this, it's quite rather late stage because the patient was being treated as fungal keratitis based on the severity that the ophthalmologist must have noted. So bacterial keratitis, so in other words, can range from mild to very severe, as you're seeing here. On the other hand, you know that gram-negative bacilli is notorious for being very rapid to become severe. So here is a patient with gram-negative bacilli, not so severe looking, and this can be rapidly controlled. Here is another patient in the central lesion. Again, this turned out to be gram-negative bacilli. And then these patients are some people that you might unfortunately see who present to us with very extensive, almost near total corneal melt. Here there is corneal melt and pseudocornea formation going into anterior staphnoma. So these patients can have gram-negative bacilli such as Pseudomonas. Sometimes these drugs are multi-drug, these bacteria multi-drug resistant, and that's why you can have these devastating infections. So even in bacterial infection, it can range from mild or it can be devastating for what you see typically in Pseudomonas. So how should we treat these patients? There's always a sort of a debate. Should we use empirical therapy versus protocol-driven therapy? So we have commercially available 4th generation fluoroquinolones. So should we use them as monotherapy? Or is it better to use as fortified antibiotics, combine two therapies? So the tip 3 is that if you have a smaller, less severe infection, and it is not really in the center, maybe off center, and it looks typical like this, it appears clinically bacterial. So we can start the patient on every 1 hour intensive topical therapy of 4th generation fluoroquinolones, but don't wait beyond 24 to 48 hours. So if it is bacterial, you're on the right track. Most of the bacteria will respond, especially gram-positive cocci, should respond to this therapy. And in 24 to 48 hours, you'll start to see a dramatic response. So beyond 24, 48 hours, don't wait. If we have isolated it and if we have microbiology and this has shown to us that this is gram-positive cocci or you know that it is bacteria, or if the patient presents to us initially itself like this is very severe. So you have to do microbiological evaluation and you have to start fortified antibiotics. Don't treat this patient empirically because in the next 24, 48 hours, it will start melting very soon. So a good combination is fortified vancomycin eye drops. We used to use cefazolin fortified, but it's poorly available nowadays. And then we combine it either with tobramycin or ciprofloxacin eye drops because these are available. Initial therapy is every 1 hour, and then these are severe conditions, so use atropine eye drops and evaluate within 12, 24 hours, you should have improvement for these patients if you're on the right track. So which means, in other words, the management strategies can be divided for non-site-threatening ulcers and for site-threatening ulcers. For non-site-threatening ulcers, you examine them, can start on broad spectrum, don't start on multiple drugs, only on antibiotics, don't start antifungals as well, only one course that you need to follow, re-evaluate, and if they are not doing well in some way, then go ahead for microbiological evaluation, and then change to fortified antibiotics. In the second strategies, if they're site-threatening, straight away go do microbiology or refer to your cornea specialist, and then based on the smears, we can start the appropriate treatment for the patient, and then change the treatment based on the response. And in case it is melting, it may need surgical intervention such as tissue adhesive or something like that. So that is what we learned about bacterial infection. Another commonly encountered infection is fungal keratitis. It also accounts for nearly 40 to 50% in hospital-based. They come with large ulcers, very bad, almost to the limbus. This is what we see in tertiary care. They're feathery edges with hyphae extension, and can have satellite lesions like this, which is slightly connected to the main lesion. And they can have a very dry-looking appearance like this particular patient. So the typically following injury, for example, this patient had injury with a leaf, and this is superficial anterior variant, but very severe. So this one, when we took smears, it showed septate hyaline fungal filaments like this. And also you can see very broad and thick hyaline fungal filaments for this patient. So we started, this is another patient who had, again, injury with cement fall, and also has a dry elevated plaque-like lesion. So all of these are very typical for fungal keratitis. So what we must know is that though we say fungal keratitis, there's another uncommon infection which closely resembles fungal. What is that? So if you look at it on a cursory glance, you can see that this is feathery looking, not so yellow looking infiltrate, and it has edges. So I don't know why. All right. So this has spread like this, and you might think that this is fungal, but there are some differences for this patient. This patient turned out to be Pythium keratitis because of the corneal scraping. So we also initially diagnosed as fungal, but when we took scrapings from the ulcer, what we could see is a slight difference. They were broad and aseptate. So the microbiologist should be able to tell us that. Pythium keratitis is a newer variant. It's not a fungus. It responds to antibiotics, and it looks very similar to fungus, but it doesn't respond to antifungals. It goes on spreading if you're using only antifungals. So it has these typical tentacle-like spread, closely resembling fungal keratitis. But nowadays, when we see this typical spread around the main lesion, so we are more likely to consider that this is Pythium keratitis. This is a tip 4. So when you manage fungal keratitis, you can use natamycin eye drops, or you can use, which is the drug of choice, or you can use voriconazole eye drops. And then you can use oral itraconazole when the ulcers are large. But then when you see Pythium keratitis, what you need to use is linezolid, which is an antibiotic eye drops, and combined with topical azithromycin as well as with oral azithromycin. And it takes a long time, but these patients will resolve medically. So we talked about commonly encountered infections, and we looked at Pythium, which is an uncommonly encountered infection, but can resemble fungus. Another uncommonly encountered infection is acanthamoeba keratitis. In the Indian population, we don't have a history of typical contact lens wear and then keratitis. In fact, many of the contact lens wearers, they actually come to us with bacterial infection. Only very few of them do have acanthamoeba keratitis. Most of the time, patients who are having history of trauma or agricultural background, or some soil or mud going to the eye, this is the history you have for acanthamoeba keratitis. You have a typical ring-like ulcer in these patients, like for example here. And look at the infiltrate. It looks as if it doesn't look like infiltrate infection. It looks like it's scarring, but there's a central plaque. Typically, history would be for several weeks. And this is very classical for acanthamoeba keratitis. How will you diagnose it? Really, you can't diagnose based on only clinical. You will have to do microbiology, or if you have confocal, you can do that as well. And the treatment, so this is the active part. From here, you're likely to get the acanthamoeba cysts, but from the rest of it, you may or may not get that. But mind you, all of this is active infection. So these are what the cysts look like under the fluorescein microscope, the typical hexagonal, and these are what some of the cysts look like with the gram staining. So the treatment for acanthamoeba is to use chlorhexidine eye drops as well as PHMB eye drops. That is a definite treatment. And if you are not able to get that, you can procure it from various places, for example, from the LV Prasad centers or from Arvind and so on. And if you're actively seeing these infections in your area, then it is worthwhile to keep the medicines in your pharmacy and prepare them for patients when they come to you, because these are the only drugs to which the patient will respond. Coming to another uncommon organism, which is very interesting, is microsporidial keratoconjunctivitis. Typically, it occurs, it looks very similar to adenoviral, but the only difference is that you will see these multiple small pinpoint elevated lesions on the corneal surface, and either you have to suspect them or you can gently scrape them and send them for microbiology. That will show you the microsporidial cysts. The good news about this is that these cysts are sort of, this infection is not a very devastating infection. It'll resolve with or without treatment, and only it's because the patients are very symptomatic. So when they're symptomatic, what we tend to do is just take off all these lesions very carefully, even with a sort of a dry surgical sponge, and maybe put a BCL for a few days and just routine antibiotics and lubricants, and the condition will resolve. When you stain, you can see all these multiple staining spots, which are nothing but colonies of microsporidial spores. The same bug can also cause stromal keratitis. Now, that is when it becomes difficult, it becomes sight-threatening, and there is really no medical treatment. Although various medications have been tried, most of the time you don't have success. So when it becomes stromal microsporidiosis, again, this is a diagnosis that you have to make by exclusion. So you'll have a patient with very long history, even sometimes going into months or even years of recurrent infection like this, most of the time it's missed or misdiagnosed as viral. And these patients can only resolve with a penetrating keratoplasty. Luckily, the results of penetrating keratoplasty are extremely good in these patients. Some more unusual organisms are nocardia keratitis, atypical mycobacteria, and don't forget HSV keratitis. This is a case of HSV stromal necrotizing keratitis coming in from the periphery. So you can call it a marginal keratitis. Viral is sort of a very, very common and frequently encountered entity. And when it's typical, when you have the epithelial form, the dendritic, it's very easy to make the diagnosis. But when you have, as I showed in the previous picture, when you have something like this picture, then it's very difficult to figure out what's happening here. Sometimes even the viral keratitis can have hypopyon. They can look like a bacterial or fungal infection. And to make it even more confusing is that you can have underlying viral infection and then the patient has a secondary infection. So viral can fool us into many kind of presentations. And only thing is that we'll come to know a little later that the patient is not responding to whatever therapy. Then we revise our diagnosis, think about viral and start the patient on antivirals. And that's how the patient will improve. So we learned about commonly encountered infections. I discussed many of the uncommon infections. Let us look a little bit about the non-infectious keratitis. So what is this? So this is a patient who had undergone a therapeutic keratoplasty a while ago and developed a central corneal lesion which looked like an infection. So the referring doctor started the patient on quite a few, 1, 2, 3, 4, 5, 6, 7, 8 medications. So antibiotics, antifungal, I guess, and then even lubricating eye drops and anti-glaucoma medications which are already going on. So with the result, what happened is that all this congestion persisted. The central epithelial defect just never healed. So what is this? This is a case of drug toxicity or drug induced. So tip 9 or tip none. None is because there's no infection here. And this is because of all the multiple medications. What is the treatment? Stop everything except for the lubricant and wait for this condition to resolve. So that's what we did for this patient, and the epithelial defect beautifully resolved. But of course, the graft was already edematous and failing, and subsequently the patient needed visual rehabilitation for that. So even when we use antimicrobial therapy, I mentioned earlier, even the fortified medications can after a while start causing worsening, or you'll see that initially patient did well and now the epithelium is not healing and the patient still has a very congested eye. So the history to take is that, is there severe burning or stinging on putting the drop? And the patient invariably will say yes. So we have to sort of have a strong heart and stop all the antibiotics or antifungals. And we have to believe that this is now drug toxicity. And most of the time it is. So if the patient doesn't improve just by stopping the medications, then we have to do an amniotic membrane or a tarsography to facilitate the healing of the surface. So coming to the very last tip, which most of us may not make this confusion, but if you see these very rarely, sometimes we had this patient referred to us as an infection, in fact, as acanthamoeba. But the patient actually has an advanced Morin's ulcer. So when I tell you the diagnosis, you wonder, how could this be confused with acanthamoeba? But in a little earlier stages, it was. So sometimes you have this peripheral infiltration. So this is a patient with rheumatoid arthritis and having this peripheral non-infectious etiologies, inflammatory. And this is in a patch graft, whether the patient has, actually it was a severe rejection of the patch graft, but it was confused to be an infection. So this was assumed to be a perforated keratitis, but actually it was also another case of probably Morin's ulcer. So you can have PUK as well as you can also have certain other diseases which are not inflammatory, which are not infectious but inflammatory. For example, this patient I mentioned here, which will mimic infections. So that was the last tip for today. There are many other tips, but maybe for another day. Thank you very much, and I acknowledge all my colleagues whose contribution for this presentation. And I have so many mentors and role models who have helped me in all my years. And of course, my deep gratitude to Dr. Bharti Kashyap and the Jharkhand Ophthalmic Society for help, for inviting me and giving me this great honor. Thank you once again.
Thank you, Dr. Somashila. And the topic you selected is of immense benefit to all of us, and especially to those who are doing solo practice.
Thank you.
Here, Dr. Jahid Siddiqui is here smiling. Please acknowledge him.
Hi, Zahid.
Thank you. Hi. Nice
So,
presentation.
he very rarely makes his appearances. Very special
No, I'm all
person.
here.
Yeah, but then you are so much delightful to see, madam. So now all the madams are here. Kasturi madam is here. तुम्हारे सब favorite लोग हैं. Anagha Harur madam is here. So
Now I'll mute
सब
myself.
madam लोग हैं. तो अब this is we have actually bound Dr. Somashila to, it is a must for her now to participate in our forthcoming annual conference, which will be March, because now she has to receive the plaque of appreciation of the of this oration.
It will be my honor.
And as annual conference dates are coinciding with our annual conference, so maybe it is we have our dates are declared in the month March, 15th of March, but I am hearing that the annual conference is also happening on the same date. If it is so, then our conference will be rescheduled from 15th March. So please block your date 15th March. If AIOS conference happens at that time, then our conference will be rescheduled to the last week of the March. So thank you, Dr. Somashila, once again. You are my all-time favorite, and my another two favorites are here. So now we are starting. We are starting the third session, Top Mistakes in Glaucoma Management. This is the very interesting and innovative session. And our session coordinator is Dr. Rashi Shyam and Dr. Tanisha. Rashi Shyam and Dr. Tanisha. Dr. Anga I have replaced because she has to join somewhere else. Our chairpersons are ex-past president, Dr. B.N. Gupta. Sir, are you here, Dr. B.N. Gupta, sir? Dr. Vinay Gupta, sir, is here. He's a glaucoma person, very senior person, practicing in Giridih. Dr. Lalit Jain, our ex-president, past president, he has also joined. Dr. Sujaya Samanta, our past secretary, very active, and the prolific cataract glaucoma surgeon from Hazaribagh. He has joined. Dr. Atma Prakash, the diamond from Dhanbad. He is the Dhanbad Ophthalmic Society. He has joined. Dr. S.P. Chakanwal, he is the boss. He is the chairperson of Jamshedpur Eye Hospital. Dr. Ajay Gupta, he is another prolific cataract surgeon from and glaucoma surgeon from Jamshedpur. Dr. Anuj Pathak, he is from Ranchi. He is the prolific cataract surgeon. So all high-profile people have joined for this top mistake glaucoma management. So now I request Dr. Rashi Shyam to take forward this session and please introduce our guest faculties, Dr. Kasturi Bhattacharya first, and then Dr. Anagha Harur. The first will be there, then you introduce Dr. Anagha, and then she will deliver her keynote address. Keynote address is 8 minutes. Audio visual is monitoring time.
So I am trying to share my screen. Can you see it now?
Yes, you are audible and you are visible.
Okay. So I welcome all our guest speakers to this session 3 and welcome Dr. Kasturi. Dr. Kasturi is director of Sri Shankara Deva Netralaya Guwahati and chairman scientific committee of the Oculoplasty Association of India. She is also the president of APSOPRS. She is winner of multiple awards and 109 publications and more in peer-reviewed journals, and more than 500 orations and presentations in national and international journals all over. We were very happy to have her at Kushalpalli, and she is an extremely good speaker with very interesting presentations. So welcome, Dr. Kasturi, and over to you.
Thank you very much. Can you hear me? Actually, I am in some different venue now. Am I audible?
Yes.
Okay. So I'll just put my video mode off because the network here is not good. But can you, I'll be sharing my screen. So at the outset, I would like to thank Dr. Bharti Kashyap, Dr. BP Kashyap, and all my friends here in Jharkhand. Like I feel that I'm back to my family. Thank you so much for having me here. And so I'll be speaking on 8 minutes about the 8 steady procedures which are being done in Indian scenario. And can you see my slides?
Yes, we can see.
Yeah, very much.
And everybody is attentively listening you.
Thank you so much.
So don't worry. All the stalwarts of Jharkhand, Dr. Sujoy has joined, all the chairpersons, all the past presidents, they're here.
I'm so honored, so honored. So I'll be speaking what are the common aesthetic procedures we in India do, being an oculofacial plastic surgeon. Why we do the aesthetic procedures? Because if you look to the AO book, you see it is very clearly written that we ophthalmologists should be dealing from the forehead to the cheek region. So it is very important. And if you look down, like first laser has been started by ophthalmologists and now being used by the dermatologists. The first prostaglandin, which is being used for glaucoma treatment, now it is used for eyelash extension. The first Botox was started by an ophthalmologist for squint correction, and now it has gone 101 indication. So we ophthalmologists, we are supposed to take whole of the face architecture. And that's why in all the textbooks, whether it's American Academy or Kansky, it is very well mentioned. You can see there are lots of chapters, even now for neck rejuvenation, face rejuvenation, and multiple rejuvenation. So I'll be speaking about the common procedures that we perform, that is the facial plastic surgeries, the injectables, and the thread. So one of the most common procedure that what we do is a blepharoplasty surgery, which is a very common surgery where variable amount of the muscle, fat, and skin are either being excised or it is being redraped and being sculpted. Today, you say internationally, it is one of the most common surgery and having both cosmetic and the functional indication. So this is a very simple surgery where you do first, the most important step, you have to mark the crease and you have to mention how, you have to mark how much amount of skin you need to excise. Depending upon the indication, whether it's an aesthetic indication or a functional indication, we depend how much we measure, we mark the amount of skin that needs to be excised, keeping a rule of 10. That means we need to keep 10 millimeters of skin from the eyelash to the lower incision and another 10 millimeters of the skin from the eyebrow to the upper incision. So you first remove the skin, then this is followed by removal of the orbicularis, only the preseptal orbicularis and not the pretarsal, and then you expose the orbital septum. Once you incise the orbital septum, you will see that the upper lid has got two fat pads. One is medial and one is central. So this central is yellow in color because by origin, it is a mesenchymal structure developed from the mesoderm, and this medial is white in color because it has developed from the neuroectoderm. So they have both origin, and you should always remember that the medial fat keeps on growing as we age. This is because it is a stem cell. I had also done a stem cell research with this medial fat, and I found that it could be transdifferentiated into osteocyte, chondrocytes, and also neurogenic. And this is the first study internationally which got published in the Science Diary. So these are the about the upper lid blepharoplasty. So once you excise, we form the lid crease formation, and this is formed by the closure of the skin. The end point of the surgery is slight eversion of the lash. Like you can see, this is the operator side and this is the unoperated side. The lashes are still straight. So you need to do a slight eversion of the lash, as you can see in this patient. So as I have already mentioned, the indication number one is aesthetic, where you need to crease, to form a crease. And the next is a functional, especially in situation like epiblepharon, dermatochalasis, lash ptosis, and a hooding. So this is what you see many of the Asian islands, especially in Northeast India and also in the very northern part of India, they do not have the crease fold. So what we do a upper lid blepharoplasty and we make the crease. And this has become a very common requirement in my place and also in many other parts of Southeast Asia. The functional indication is basically epiblepharon and dermatochalasis. What happens because there is lash ptosis, it keeps on, touching the cornea. This releases the inflammatory mediators like MMP9, the interleukins. This causes the increased osmolarity. This will reduce the flow, and thus a vicious cycle will keep on continuing. And also there are reports where because of the lash ptosis, the contrast sensitivity is being decreased, the lateral field of view is being decreased, and the most important, the high order aberrations are being affected. So following a blepharoplasty, you can definitely bring a change in the very minute, factors which are responsible for a very good visual acuity. So when we talk about the lower lid blepharoplasty, it is basically used to manage this valley, which we call the teardrop, and the hills, that is the fat. So lower lid blepharoplasty or lower lid treatment is more of a cosmetic treatment because it occurs because the change of the positive vector that we have in the face into a negative vector. So a positive vector means this malar eminence should always lie in front of the corneal plane, and the negative vector is when this malar eminence goes much behind the corneal plane. So why do we have a change of this positive vector to a negative vector? This is because of the topographic changes, the uneven differential site-specific changes in the bone, where the pyramid of the orbit becomes more of a square. And the second most important, the soft tissue changes, which leads to multiple periocular changes, which can be in the form of a dermatochalasis that you can see here. It can be in the form of the eyelid bags. It can in the form of a fistula, and this gives to a double convex deformity that we see in many of our patients. Along with this double convex deformity that we see in the upper lid, on the lower lid, we also see the laxity, the dermatochalasis, the tear trough, and the most important, the periocular rhytidosis. So how do we manage this? The rhytidosis is very easy to manage. We manage with injection botulinum toxin A. You should know a very good understanding of the anatomy. Every muscle has an antagonist group of muscle indicated for the crow's feet, the forehead lines. But when you inject for the forehead lines, do not cross the lateral limbus, because if you inject somewhere over here, there will be a chance of the brotosis. So this central zone is a very safe zone. You need to inject in the subcutaneous plane, and another indication is the glabellar line, especially for the procerus and the corrugator. But when we talk about the valleys and the fat in the lower lid, this is done by the dermal fillers. And this dermal filler can be injected by different ways, which can be in the form of the serial puncture. It can be in the form of the fanning, which we really use in a very high rate, or in the grid pattern. So why do we use this? This especially in case of a very prominent tear. Can you see this trough is so prominent? So you inject the dermal filler where you see the trough, the valley is being much less, the shadowing is decreased, so even the dark circles are much less. But more than that, what we use dermal filler when there is minimum fat herniation. So when you have the fat which is being herniated just in the medial and the central, much behind the plane of the anterior lacrimal crest, these are the situation where we go for the dermal filler. And how do we inject the dermal filler? This is basically done with a cannula where you mark this periocular region, you mark this depression, you mark the fat, and once you do that, you use a cannula, we push the cannula, because the blunt tip cannula, the chance of injuring the blood vessels are less. And these dermal fillers, a hyaluronic acid, gives a very good tissue penetration, tissue integration. And when you look to the result, these are the results. See, it has concealed the fat and also, managed to, treat the tear trough. And the results are just after the surgical procedures. And not only this, when you look to the patient from the side profile, you will see the change in this negative vector to a positive vector. So a non-surgical way also you can manage by concealing the fat and correcting the tear trough by using the dermal filler. And the results are just immediate. If you look to the patient out here, this lady comes with this fat bag and with the tear trough, and this is a marking. This is on the table, you can see a much better correction of a lower lid. And this is another lady with multiple procedures with a dermal filler injection that you can see here, where I have treated the trough. And when you look to her in the final result, she looks like a mother, daughter to her own self. This is how she comes to us, and this is how she looks done. And so these are some of the cases. But when you have a proper double convex deformity, when the fat is much anterior to the plane of the anterior lacrimal crest, this are the situation we have the lower lid blepharoplasty. So the lower lid, we usually have basically the 3 fat bed. And then what you do, you need to do a transconjunctival incision, expose the 3 fat bed, and don't cut the 3 fat bed. But you should always protect the inferior oblique muscle, which lies between the medial and the central fat bed. And then you fashion the 3 pedicles of the fat. This fat will now use as a filler. What you need to do, you release the osteocutaneous ligament and transpose this orbital fat down into the cheek region by creating this 3 fat pedicle. And then what you see, the result, you will see a very good effacement of the lid cheek junction. You can see the fat pads are not there. They look so much rejuvenated. And the most important thing is the conversion of this negative vector into a positive vector. So these are few of the patients that I'll be showing before and after the surgical procedures, which I have also reported in few of the journals. And you can see the conversion of this negative vector into a positive vector. So I'll just be concluding with my last types of procedure that we do. These are some of the patients following blepharoplasty upper and lower lid. And you can see the very common procedure with what we do is the thread. This thread is a PDO thread, which is like, which accepts it, the body accepts it very well, very inert. And you can do a very good lifting of the eyebrow. You can see this lady just before and after injecting thread, like she has got very droopy thread. And this is how we push the thread. Advantage of this, these are known as cock thread. You need directional. So once you put the thread, you need to lift it. And this is how you lift the eyebrow. And this is once you are done with the lifting, you do the other side. And this is how you see following the surgical procedures. And you can see a very good correction. You can see done a non-surgically also. You can do a very good, brow lift. And this says sometimes there are different types of thread. The best is the cock thread, which I have shown you, where you can pull the eyebrow, you can lift it up very well. Sometimes in a heavy person like this, we give something like a twin thread also. We try to push it further. Advantage of this twin thread, it leads the synthesis of collagen. The skin becomes better. The aging changes is much reduced. And you can see a good correction. So these are some of the patients where the different types of threads are being used. This lady who has come to me for a blepharoplasty, along with the blepharoplasty, I'm using the different types of thread. This thread will not only help in the lifting of the eyebrow, but also will give a very good correction to her skin changes. So these are some of the facial aesthetic procedure that we as the oculoplastic facial surgeons perform. Thank you very much for your patient hearing.
Wonderful, wonderful.
You are so wonderful.
Beautiful presentation.
You should be the next chairman scientific committee.
Nice presentation. Thank you so much. I
You are
tried.
far above the post you currently hold. You are
so
brilliant.
much.
And the
Thank
kind of surgeries you have done, the kind of aesthetic procedure you have done, even people in Bombay, the aesthetic people don't do. The ophthalmologist is doing.
Yes. But
Dermal injection is not very easy. Had it been that easy, the heroine Rekha would not have been such depressed under eyes.
You know, I'll tell you good news now. One of the old Miss India, now she is coming to ophthalmologists like us to do all her procedure. So that is also good news for all of us.
What's her name?
No, I cannot say. This is very
Sushmita said.
No. Okay, but still, I feel the face belongs to the ophthalmologist. Why? Because all the muscles of the eye and all the muscles of the face are connected. So this is the main modulus. So all the muscles of the forehead, muscles of the nose, muscle of the face is connected. So it is very important that we should know the full anatomy and work on the face.
और दुनिया was today. उनका दुनिया का present बोलना.
Thank you so much and really honored. And I always say that Jharkhand Society is like my own home. I consider myself to a family of Jharkhand Ophthalmological Society. Thank you so much.
Jharkhand Ophthalmological Society. Family, and we have supported you wholehearted. You are so brilliant.
Thank you so
much. Now to the another brilliant.
Okay, so I would like to welcome Dr.
Another very hardworking lady.
Yeah, I hope you can see the screen.
Thank you so much.
Hello.
Yes.
Dr. Anagha, we welcome you and thank you for making time when you are multitasking between two CMEs at the moment. So, Dr. Anagha is Medical Director in Anil Eye Hospital, Mumbai. She is member ARC currently and Secretary Maharashtra Ophthalmic Society also. She has received many awards, Best Surgical Skill Awards at Women Ophthalmological Society in Hyderabad this time, and Gold Medal Award by the Vice President in 2018 in IIRSI. She is also adept at doing multiple live surgery demonstrations in international and national presentations. So we welcome you, ma'am, and please go ahead with your presentation.
Thank you so much. Thank you. Start sharing now. Yes, yes. I hope you can see my screen.
Yes,
Is my screen
ma'am,
visible?
please go ahead.
Yeah, thank you so much. At the outset, I'd like to thank from the depths of my heart, Dr. Bharti Kashyap ma'am, Dr. B.P. Kashyap sir, and the entire team of Jharkhand Ophthalmic Society for having me here. Thank you so much, everyone. And today, I'm really honored and privileged to give the keynote address for FLAX, the way forward. So friends, no financial interest in any of the things shown here. The role of femtolaser assisted cataract surgery today is on the rise. And the reason is because cataract surgery today is more of a refractive procedure than just treating cataract. We have a lot of demanding patients where surgery demands greater precision, greater accuracy, and greater safety. So let us see whether really and truly femtolaser assisted cataract surgery is truly the way forward. So if you look at all the procedures, what can be done with the femtolaser, we have 4 important things. And one is the capsulorhexis, the lens fragmentation, incisions, and also the arcuate incisions to treat low power astigmatism. So this is an actual video of how we need a separate operation theater, a separate machine. So first the docking is done, and then you have an integral guidance system of the OCT where you can find out the layers of the anterior lens capsule, the pupillary edge, and you have the capsulotomy, the lens fragmentation being done, as well as the arcuate incisions and the incision, and it is done in 2 minutes. Now we have different kinds of docking which is done, and today we are using the liquid optic interface. I'm using the Catalyst system, and if you compare it with the applanating surface that was being used, and it's still being used in some other profiles, here you have corneal posterior folds, as you can see in the top here, which can cause laser beam aberrations leading to incomplete cuts. So a water immersion helps to avoid any of these corneal folds, and then you can have a postage stamp perforation and a complete cut. What is the advantage of the capsulotomy with the FLAX system? We all know and we all will agree that even though we have been doing cataract surgeries for the past so many years, it is the consistency and the reproducibility which may or may not be there in the hundreds of cases that we do. So what we need today is perfect centration. You need a good circular with a good edge strength consistently in all our cases, with little or no risk of radial anterior capsular tear. So here we have a capsulotomy that is performed, typically a 4.8 to 5 or 5.25 millimeters. And you can see that we are now raising the capsulotomy flap with a viscoelastic, and it is gently then brought out of the incision. So you can see a comparison of how a femtosecond laser capsulotomy is there compared to a manual one. Sometimes you may have a perfectly circular capsulorhexis done manually, but it may not be centered perfectly to the lens, especially with premium lenses like toric lens. Recently, I had a patient where a toric lens had got a slightly misaligned, rotated, as well as slightly tilted because one of the edge of the capsulotomy capsulorhexis was just beyond the edge of the toric lens, and that had caused a residual astigmatism. A lot of literature and studies have shown and proved that greater efficacy and safety of the femtosecond laser system, making it more precise, accurate, and reproducible in all our cases. We all know that the elasticity, the thickness, and there could be fibrotic changes in the capsule, and in all our patients, getting a reproducible result may or may not be always possible. So the greater reliability of these capsulotomies and the time taken is less than 1.5 seconds. One of the major advantages is you can actually center these either on the pupil or on the limbus or on the scanned capsule, especially in cases of subluxated cataract, or you can custom center it depending on the condition present. Also, if you look at the nuclear fragmentation, one of the biggest advantages is you have a pre-cut nucleus, which reduces the phaco power by almost 43%. in effect, it reduces the phaco time by almost 51%, especially in very high dense cataracts, and if you have especially corneal guttate changes or few endothelial dystrophy, then the kind of trauma that is caused is significantly reduced. Also, you have the reduced inflammation and reduced corneal edema postoperatively in these cases. You can also use segmentation like quadrants, sextants, and octants, and very dense and hard cataracts. You can also use softening techniques, which even changes and makes very small cubes, and that helps in reducing the phaco time. So these are certain studies that have showed that a lower EPT is there compared to a standard phacoemulsification procedure. Now, this is how the picture looks. So when you have raised the capsulotomy flap, removing it from the main incision, you can see a yellowish glow, and that is because of the air bubbles that have been trapped behind the lens. So when you just tap them and do gentle minimal hydro, those air bubbles can be easily removed. And now we are going ahead. You can see there are these pre-cut nuclear fragments. So all you need to do is just separate them very, very gently. So the phaco time is reduced very significantly as you have these pre-cut nuclear fragments, and each of these fragments can be easily picked up and emulsified. You can see the capsulotomy already, which is so perfectly in the center and circular. And now once the phacoemulsification is complete, we go ahead with the irrigation aspiration. For beginners, irrigation aspiration could be a little difficult because remember the femtolaser cuts the cortical fibers vertically. So you need to just release it and loosen up the cortical fibers before they are removed. And for all our premium patients today, a lot of our patients who come to us demanding torics or multifocals and multifocal torics, you can see that in these cases, you have a perfect centration and you have the best visual outcomes with all these patients. So next is if all these different situations, now you have flags where we have used it in white cataracts like this, there could be certain skip areas. So all you need to do is just ensure that the capsulotomy is complete, and then the rest of the procedure is the same. You can go ahead with the phacoemulsification. In white cataracts, the penetration for nuclear fragmentation is not as good, but definitely it reduces the risk of the Argentinian flag sign, which is one of the biggest risks in mature intumescent cataracts, where you can have a radial tear and it can lead to disastrous results. In case of subluxated cataracts, one of the major advantages is you have a capsulotomy in a closed chamber, especially when you need to put a CTR. You cannot afford to have an anterior capsular tear, and making a capsulorhexis in case of subluxated cataracts is so important, because if you don't have the perfect capsulotomy, it can cause a disaster and you may not be able to put in a CTR and preserve the capsular bag. This was a patient of trauma where we had done a femtosecond laser. As you can see, now we are rifting the capsulotomy flap. You can see that there is a subluxation of almost 2 to 3 clock hours. We have used capsular hooks to maintain the integrity of the capsular bag, and we are going ahead with the nuclear removal. Now, once the phaco is done, very gently, that reduces the risk and increases the stability. Now we are putting in the CTR from the side port, and that helps in now bringing in the zonular bag towards the sclera. And now go ahead with the irrigation aspiration. The capsular hooks can be now removed. We are putting in the intraocular lens, and this reduces the complication rate very, very significantly. So the centration of the intraocular lens also becomes much, much better. In posterior polar cataracts also, where there is a very high risk, in cases of these patients, we use flags very regularly. The advantages are you get a perfect rhexis. So just in case we have a rent, you have a very good capsulotomy in order to put in a 3-piece lens. You have a pre-cut nucleus. So in these cases, remember, we cannot do a rotation of the lens, we cannot do a hydro dissection. So you have a pneumo or a femto delineation already done. So in these cases, it becomes very, very easy. So as you can see here, we are not rotating the lens, but we are picking up each of these pre-cut nuclear fragments and removing them so that now the risk is reduced significantly. So once this is done, the nuclear fragmentation, the phacoemulsification is being done. Each time you remove it, you remember that you should always push in viscoelastic. So the messages are, even the the OCT, you may do it pre-op, but even during the OCT, what you can see during on table, during the flax procedure, you can see that there could be a posterior capsular rent pre-existing, so you can be mentally prepared. And you have a good epinuclear cushion, which is customized, and that can help in giving a good cushion for preventing the PCR. Dr. Abhay Vasavda sir has already described this femto delineation, where you have an extra enhanced cushioning to the posterior capsule and reduced risk of PCR. In case of hard brown cataracts, femto delineation helps in increasing the safety. The softening of the nucleus helps to tackle the harder grades. You have a perfect capsulotomy for sulcus implantation wherever required and predictable refractive outcome. So this was in fact a police officer who had a very dense brown cataract, where we did this under topical anesthesia. You can see the capsulotomy flap has been removed, a very gentle hydro, where you have these air bubbles behind the lens which are trapped. Now that can be removed. And now we are going ahead with the phacoemulsification. So all you need to do is now chop and emulsify these pre-cut nuclear fragments. And you need to separate out these pre-cut nuclear fragments as we are doing here. And because of the pre-cut femtolaser quadrants and the softening that is done, this helps to reduce the phacoemulsification time and also the phaco energy, so as to reduce the phaco power that is released to the corneal endothelium. Here we are using a visco with sodium hyaluronate and chondroitin sulfate to protect the corneal endothelium also. And each of these fragments can now be removed very, very easily compared to a routine phaco we would have done, or sometimes in these very hard brown cataracts, you might need to go ahead with doing SICS. So you can do whatever works best in your hands, but definitely flax has helped us to make all these surgeries very, very simple. So can glaucomatous patients withstand the femto procedure? Yes. With the liquid optic interface, there is a very modest IOP rise, no corneal fold, so there's no contraindication for these patients. There are these studies which have shown that cases of glaucoma are no longer contraindications. Yes, cost is a factor. So today, my indications for phaco is to reduce phaco time in brown cataracts, especially with corneal guttata, and in posterior polar cataracts, and better centration in multifocal IOLs, toric IOLs, and subluxated cataracts. You may have special situations like this was a patient where you had an IPCL surgery done, already came to us with nuclear cataracts. So we did a femto in these cases. Here, remember, even for the biometry, you can go with the optical biometry without any problem because these are optically clear media. But when you're doing a flax, remember, you might need to make certain changes in the energy settings. And remember, the OCT in the femto laser might consider the anterior, neck, but here you have to actually manually bring it to the anterior lens capsule. This was another patient, this is my last slide, where you have a 49-year-old patient who was one-eyed, 18 cut RK done as well as LASIK done, and the other eye was lost due to RD. So here again, we went ahead and you can see there are these lot of deposits in the flap area in the corneal stroma. We went ahead and did a flax in these procedures. You can see the OCT cornea, which is showing a lot of deposits here, but we had made certain changes during the settings. As you can see here, there's this extent and changes in the energy setting. The segmentation repetition was changed. The anterior pulse energy was changed. And you have the vertical spot spacing that was changed in these cases so as to get the best results. You can see the incision depth also was changed, where you are using the capsulotomy pulse energy was changed. And we went ahead with the surgery. So to conclude, flax today helps us to more precision, greater accuracy, greater safety, and giving us a perfect capsulotomy also helping to reduce phaco energy and time, to give us better visual outcomes to all the patients. So if we fail to adapt, we fail to move forward. So today, compared to what we started when I did my residency to today, I think we have a great way forward. So fem to laser can be considered as probably a way forward, especially in special situations. Thank you so much for your kind attention.
Very nice talk, Dr. Anga.
Thank you so much, ma'am. Thank you.
And I must say that you are one of the most hardworking person in the entire ophthalmic world. So you do so much, and you don't have the support of a same fraternity spouse. Still, you are working so much. You have centers, and you are in the political area also. Of course, I mean AIUS political area. So I really appreciate you, and we are moving forward. And first, we are taking Sahiba's procedure at airport. So I request Dr. Ashish Shyam to introduce Dr. Sahiba Sethi.
So, Dr. Sethi, are you there?
Dr.
Yes,
Sahiba.
Yeah, thank you so much for making time. Dr. Sethi is currently at the airport on way to somewhere. So we have moved up her lecture. It was much down the list. So she is a consultant in Arunadaya Deseret Eye Hospital, Gurgaon, and she has done her glaucoma fellowship from Shankar Nethralaya. She's a gold medalist in MS Ophthalmology, and she is the winner of Best Paper at ARVO, Florida 2014, APCRS, AIOS 2020, DOSCON 2020, APGS 2020. So very, very, very brilliant ophthalmologist of our generation. And she's also a pioneer in MIGS. So we welcome you, Dr. Sethi. Please go ahead with your talk.
Thank you so much, ma'am. Are my slides visible, ma'am?
Yeah.
My topic is top mistakes in
Dr. Audio can be a little better if you can. The audio is not connected.
The audio is not okay, sir?
The audio is not okay. It's not clear. And can you please make it on a PowerPoint show with all the slides?
Sure, sir. I had actually recorded this because
Yes, it's okay, but you can put it on a slide show.
I'll present from a slideshow. So thank you so much, Bharti ma'am, at the outset for giving me this wonderful opportunity. So my topic is going to be top mistakes in MIGS. And according to me, I think the biggest mistake one makes is in choosing the right patient. So we should know that these patients that MIGS applies to are going to be primary open-angle glaucomas, pseudo-exfoliative or primary glaucomas. These patients who need a target IOP of not more than or not less than mid or high teens, and the ones who are actually having problem in taking their medications or having side effects due to it. All other sorts of glaucomas like juvenile open-angle, secondary glaucomas, even primary angle closure glaucoma, application of MIGS is questionable. The second mistake we commonly make is in doing an inadequate pre-op assessment. And MIGS is applicable only to mild to moderate glaucomas, which can only be ascertained on the basis of visual fields and not on the basis of how high the IOP is or how many anti-glaucoma medications the person is on. So whenever there is a need for very low intraocular pressures like advanced glaucomas or normal tension glaucomas, MIGS is probably not the best fit. Also doing a thorough gonioscopy pre-operative, determining that you have a good view of the angle, there's no corneal opacity or degenerations, also there is no in the angle is of utmost importance. So this is basically a mistake I made in one of my own patients wherein there was a hard cataract, and this was a patient wherein the cataract surgery was combined with a mixed procedure. So after doing the cataract surgery, the cornea was edematous and After taking the first nick of the trabecular meshwork, the reflux heme completely obscured my view, and in this case, the MIGS had to be abandoned. So in such cases where you anticipate that you may have complications or an eventful surgery or maybe a hard cataract or low endothelial cell count, maybe doing MIGS before your cataract surgery is a better option. Then next would be incorrect positioning. So the proper positioning of a patient for MIGS is when the surgeon sits temporally, the patient's head is tilted 35 to 45 degrees away from the surgeon, and the microscope is tilted 35 to 45 degrees towards the surgeon. So when this sort of a positioning is maintained, you get an on-fast view of the angle, which means that there are distinct structures, trabecular meshwork, scleral spur, and ciliary body band that you can see very distinctly. But if the positioning is incorrect, you see all these structures very close to each other and indistinguishable from each other. So this is where the view of the angle is there, but then you can't see the angle structures very well. But when the patient's head is tilted further away, that is how you correct this wrong positioning. You can see that there you can get a beautiful view of the angle, and this brown line is a distinct trabecular meshwork that you can see. The second mistake we make is in having a poor understanding of the angle structures before embarking on MIGS. So over here, this is a video of a surgeon who wishes to be anonymous. The orange line we know is pointing towards the trabecular meshwork. The black line is actually the root of the iris. And over here, a bang procedure is being performed from the level of the root of the iris. So improper understanding of the level of your different structures can also lead to situations like these, wherein you can have bleeding or cyclodialysis. The next mistake we make is not making very clear corneal incisions. Now, the problem in making more limbal incisions in MIGS is that you can have a bloody field, and if the blood enters your anterior chamber or obscures the angle, you may have to abandon your MIGS procedure. Also, using a very good cohesive viscoelastic is the backbone of a good MIGS surgery. I use a BioHylar 1.4 with no financial interest over here because I feel this is a very good.
Sorry to interrupt. Your slide is not moving. Sorry to interrupt.
Oh. Now, sir? So is it moving now?
No, still not. Not yet.
Your slides are not moving, Sahiba.
Oh. So should I redo it, ma'am?
No. We have listened.
Doctor, you need to put it on slideshow.
You start from the slide where you are now.
You have to go to the third slide. Third slide you have not seen actually.
The cohesive viscoelastic slide?
Yeah, third slide. Mistakes of choosing next, the third one. You get out of the screen, share, again share it.
Okay, sir. So now is it visible?
Yeah, just click on the share, just click on the slide share option on the bottom where you see that's it.
Right?
Yes, just keep
now
the
perfect.
Okay. So this is the slide where I think I got cut off from, right? Okay, anyway. So using a good cohesive viscoelastic is also very important. And over here, I use a BioHylar 1.4. Why? Because it's a very good cohesive viscoelastic which maintains the anterior chamber very well, irrespective of how many times you go in and out of the anterior chamber. You can also see that how thick it is, and it sits very well. It doesn't flow off anywhere. When you put the lens on top of it, you have a brilliant view of the angle, and it maintains the anterior chamber, makes it deep, and maintains it very well. Next mistake that we often make is overfilling the anterior chamber with viscoelastic. Now, what this can do is, because these are cohesive viscoelastics, it can cause iris prolapse and a messy surgery thereafter. In the end, I think the most important tip from me would be an adequate pre-op counseling. Now, the mistake we usually make is overpromise to the patient. So don't overpromise, always underpromise and overdeliver, because with MIGS, still we don't have a very good understanding of how much intraocular pressure drop we are going to achieve, how many anti-glaucoma medications we are going to be taking the patient off. So these are certain definite questions we can't really answer to the patient. So only choose very motivated patients patients who are anyway going to undergo cataract surgery and have glaucoma and are on anti-glaucoma medications, maybe 2 or 3, and you can just say that we are doing this, it will probably lengthen your surgical procedure by 10 to 15 minutes. And what we are attempting to do is lower your anti-glaucoma medications by 1 or 2. And if you're very lucky, probably off it. So always adequate pre-op counseling is extremely important. Thank you so much.
Thank you so much, Dr. Sethi. I would like to now invite Dr. Harshita. She's a young ophthalmologist in Ranchi practicing glaucoma, and she'll be presenting on mistakes in IOP measurement.
Thank you very much, ma'am. Is my screen visible, ma'am?
You are visible and audible both, Harshita. Go on.
Ma'am, screen is visible, right?
Yes, yes, everything.
Okay. Thank you, ma'am. Thank you, ma'am. A very happy afternoon to all of you. Myself, a glaucoma specialist. Deep gratitude to Bharti Kashyap ma'am for giving me the opportunity to speak and listen to the renowned speakers from around India. My topic is mistakes in recording intraocular pressure. So intraocular pressure is the main modifiable risk factor for the development of glaucoma and a fundamental tool in the already diagnosed ocular hypertensives and glaucoma. Even if IOP measurement in vivo has always is just an estimate of the true IOP, which is actually measured through invasive manometry, it has always been taken as a predictor of severity of glaucoma progression, to check the progression of glaucoma and also the efficacy of treatment. Hence, it is important that we should measure the IOP accurately and precisely in our clinical practice. So just to summarize, to avoid a wrong diagnosis, a wrong treatment, under treatment, over treatment, and definitely our trust in the patients. Goldman applanation tonometer has always been a gold standard for IOP measurement, but obtaining an accurate IOP reading can be challenging at times. This is the calibration rod, which is used for calibrating the Goldman applanation tonometer. It has 3 dial positions, 0, 2, and 6, corresponding to 0, 20, and 60 millimeters of mercury pressure. Just to go through a video. This video shows how calibration is done for a Goldman applanation tonometer. The calibration rod is fixed at 0 mm of mercury in the holder and tightened. It is attached to the applanation tonometer, and then the entire instrument is fixed with the help of a foot plate to the slit lamp. The dial at the 0 position, the feeler arm at the dial position 0 should move freely anteriorly and posteriorly with the movement. When the dial position is moved backwards, the feeler arm should move towards examiner, and when it is moved forward, it should move towards the patient. Similarly, at position 2 and 6 also, the feeler arm should move in the above set form. If the feeler arm does not move in the way explained, the IOP reading is inaccurate and calibration need to be done. So what are the common positions of errors? Parallax error. If there is the incorrect positioning of the eyes of the patient, eyes are wandering, or the head of the patient is not properly placed, it will lead to an incorrect IOP measurement. Calibration error, we've already seen. Wrong eyepiece. So Kubota and Nagata have observed that the type of slit lamp also affects the IOP measurement. For example, hat stripe slit lamp, the prism of the tonometer is aligned with the right part of the slit lamp optics. Hence, the pressure measured with the left is higher as compared to that with the right and the binocular. Similarly, Rodenstock slit lamp, the pressure measured with the right is more as compared to the left, as the prism is aligned with the left. Apart from this, Any pressure to the globe, eyelids while measuring the intraocular pressure will increase the pressure on veins and it will increase IOP. If the patient is squeezing the eye, you are about to touch the lids of the patient, there is the Valsalva maneuver by the patient or lid retraction is there. All these things, they affect the IOP readings. The amount of fluorescein which is used to stain the cornea will also affect the IOP measurement, like absent or minimal staining. Less staining will cause underestimation and vice versa. Accountable corneal astigmatism, irregular corneas, thin corneas, thick corneas. We all know that central corneal thickness is important and a thinner cornea will lead to an underestimation and vice versa. A number of nomograms are available to we do the CCT corrected IOP. Patient positioning. In the supine position, the IOP is higher than in sitting because of the increased episcleral pressure. Apart from this, inter-observer variability. To address these issues associated with Goldman applanation tonometry, multiple new modalities have come like tonopen, eye care, which are used in different situations. Like tonopen has been found more accurate in corneal surface abnormalities. Eye care is also one of the widely used reliable measurement for IOP, but it is affected by the measurement angle and the positioning of the probe. Subramaniam et al. Has compared the eye care tonometer with the Goldman applanation tonometer around 1,000 eyes with more than 22 millimeters of mercury and patients of glaucoma treatment. And he has found there is large differences in the values. So the take-home message is that there are multiple methods of IOP measurements which are available with advantages in different situations. However, they do exist the limitations, which should be considered while we are interpreting the observed IOP results. For correct measurement, calibration is must and should be done once or twice a year. Thank you for a patient hearing. I hope I was able to make to the time.
I think certain eye conditions like dry eye, they do affect the measurement because that makes the fluorescent film thinner than normal.
Yes, sir.
Just a comment on Dr. Harshita. If you were measuring with the tonopen, I think each and every time you have to, every day at least, you have to calibrate. That is much more important.
Yes, sir.
What we don't used to forget actually.
Yes, sir. So even the silicon cap, just to that has also to be changed, and it also gives a 10 readings, like the aggregate of 10 readings. That is how it gives the final reading.
Yes. Some of the instruments are fixed at 9, some of the instruments are fixed at 10.
Yes,
and they give an average. But if
Yes.
you are not changing the cap in each and every patient, it is very difficult. To
Yes,
get that.
True, sir. True.
How much practical it is actually? Yes, that's my question.
Sir, tonopen, because obviously, sir, in a it depends because it becomes expensive in a setup where we are dealing with patients who are not socioeconomically so well off, because if we are changing the cap every now and then, that is what I feel, sir. Because every time you have to change the cap for the tonopen. But in cases where the patient cannot sit upright, in those cases, tonopen and eye care, all these instruments becomes a handful of we get an idea.
Tonopen is very handy for the screening purpose, actually, for
Yes,
OPD and
sir.
screening purpose.
Yes, sir. Yes.
Very, very handy. Thank you. Thank you. Nice presentation.
Thank you,
Even
sir.
the DCT, dynamic contour tonometry, you have to change the plastic cover.
Yes, sir.
Sir, a good option is Perkins handheld. It is pretty accurate and it is portable and it suffices doing the same things, and it is not so costly also.
Rashi, we are not talking about you because you are so experienced. Even your fingers will tell you what is the pressure.
Yes, sir.
So, but I really want to know about why DCT, dynamic contour tonometry, failed, because we have done, I have also done, and it is very good. And learning curve is not that much. Better than applanation. Dynamic contour tonometry has not become very successful. I want to know why.
It is successful. It is successful, but it is costly because of the plastic cover. Number one. Number two, it is almost comparable to your application tonometry, except for the dynamic control DCT. In that, you don't have to take the thickness of the cornea.
Yeah. Sir, I have a question, sir. As you have used dynamic contour tonometry, sir.
Yes,
so, sir,
we have.
Yes, ma'am. So, sir, how can uncooperative patient be used? Like I have read, what I have read is it needs at least 8 to 10 seconds. The patient has to sit very firmly and should not move. So how
no, if you can do Goldman application tonometry, you can do DCT.
Yes.
If you cannot do application tonometry, you cannot do DCT. And then I don't know, it is very difficult for me to make the patient sit down properly. I keep the eyes open. Akolo. I mean, it's such a tough job. And even whatever you do in a lot of conditions, you cannot do any of these tests like application tonometry or DCT. Ultimately, the digital tonometry you have to do, or probably the Jhos tonometry you have to do because of if there is any corneal opacity, you cannot do it. Because there is any epithelial aberration, you cannot do. There are a lot of, the condition in which which you cannot do all these.
Right, sir.
One thing that is commonly missed is that when we do an application, we forget to do a CCT correlation. So that IOP noted is just the IOP noted during that procedure, not the CCT corrected IOP. That can give a wrong estimation also.
Yeah, very true. Rashi, I have a question for you. So do you do CCT in each and every case, number one? And number two, if you are not doing it, do you consider the CCT taken elsewhere to be okay, or you have to do your CCT yourself? What principle do you follow?
Personally, for all my cases of glaucoma, I do a CCT. And I do a CCT because there is a difference between the optical method of measurement and the ultrasound probe. So ultrasound probe is technically more correct. So I don't know what CCT measurement tool has been used for anyone else who has done it previously. So that is one thing. But I never let my therapy be guided by it. Like corrected IOP is just a guide. It should never be the rule. That is the recommendation by Glaucoma Society also. So thicker corneas will have higher IOPs, but you cannot become complacent about it. Thinner corneas will have low IOPs. So you should always be on your watch, but you can never take it like a maths that if CCT is high and pressure is, you can never do it like that. It is just to tell you the risk factor that glaucoma is more associated with thinner cornea and less with thicker.
And one more tip I wanted to know from you, Dr. Rashi. In cases of cataract, people say remove the cataract, the pressure will come down by itself to a normal limit. What is your policy?
In angle closure patients or narrow angle patients, if there is a cataract and I have to decide between cataract and YAG, I usually do a iridectomy in the eye that has to wait. And I recommend to the patient that you should go ahead and get your cataract done, because that will make it easier for me to assess your disc. It will give you more reliable fields. After cataract, I can do it. And of course, the pressures will come down. So in those cases, I definitely like to do cataract first. But if there is no cataract, then I don't think there is any indication. I generally don't do cataract removal to control IOP in clear lens. Clear lens extraction, I'm not very comfortable with if I can do a PI.
No, we are not talking about the clear lens extraction in cataract. Yeah. Thank you, Rashi. Thank you.
So, so now we should move forward. Dr. Rashi, please take the seat.
I hope everyone can see my screen. We have been doing very high-end topics, and now we are coming down to the basics, which will be more helpful for the students.
But let me introduce you. Dr. Rashi Shyam is again one of the worthy daughters of worthy father. Her father, Dr. B.K. Verma, used to rule the private practice of Jharkhand, and she is a very prolific glaucoma person, and she looks after the Kamal Eye Center, which is founded by her daddy. And welcome, Rashi.
Thank you, ma'am. Thank you for your kind words. So I'll make it as quick as possible because we have very esteemed guest speakers waiting and there is a long.
And I am not going to give 30 minutes break. People will take lunch one after the another when they are free. So there will be no break because we are 1 hour late.
So my talk today is going to be upon common mistakes in gonioscopy, and we know that gonioscopy is a very, very important part of examination in all glaucoma patients. So there is a sequence where gonioscopy should be done. Since it is a contact procedure and it disturbs the ocular surface of the eye, so we should do the visual acuity, anterior segment exam, tonometry, slit lamp. If there is an OCT scan to be done in undilated pupil, suppose visual field has to be done, or keratometry, central corneal thickness measurement has to be done. All these should be done before we go ahead with the gonioscopy. And then if a fundus examination has to be done, then of course gonioscopy should be done before to assess whether it is safe to go ahead and dilate the patient. Now, there are certain contraindications to gonioscopy also. One is obviously if the patient has a red eye or infected condition of the ocular surface. If there is recent post-op period, like in very recent TRAB or cataract surgery, or if there is a risk of wound gape and corneal abrasions are there. Now, in cases of trauma where we have significant hyphema obscuring the anterior chamber, then there is no point in doing gonioscopy, nothing will be seen. In open globe injuries, of course, sometimes the pressure on the globe makes the injury worse, so it should never be done. And intraocular pressure, if it is very high, then again, significant corneal edema is there. So in that case, if it is there in one eye, we can do the other eye gonioscopy to make out what the anatomy of the involved eye is. And if there is a blebitis-like condition or a thin cystic bleb, it is not safe to do gonioscopy. It will make the bleb leak. Now, prerequisites, we all know anyone who is doing gonioscopy can go through this. And the only thing that I would like to say is use the right hand for the right eye and left for the left. And superior inferior angles you have to view in the gonio mirror. It is preferable to do all 4 quadrants. And once the gonio lens has been removed, please tell the patient that there will be a little persistence of blurring of vision for some time because methyl cellulose gets stuck to the ocular surface and makes the patient uncomfortable. So how do we proceed? The first thing is air bubbles in the gonio mirror make it very irritating when you're doing gonioscopy. So one very easy way to avoid that is make the syringe inverted and keep it for some time. The air bubble goes up, and then when you take the methyl cellulose out onto the lens, it is without bubbles. Same you can do with the bottle if it is there in a 5 ml bottle. This is a short video to demonstrate gonioscopy being done in my chamber. So I'm a right-handed person, so I insert the lens with my right hand and then change my hands to stabilize the lens on the eye. And a parallelepiped light of the illumination is used, and it is a coaxial arrangement of the illumination and viewing arm. Now, since I use a 2-mirror gonio lens, I can see the gonio images in the superior and the inferior image at the same time, and then the nasal and temporal quadrant at the same time. And once I repeat the superior inferior viewing, then to remove the lens, a slight tap on the side of the eye is sufficient and the lens comes off. So what are the normal structures that can be seen? Usually for beginners, it is best to start from the root of the iris, and you see the little bit of the ciliary body band in an open angle glaucoma, and then you see a scleral spur. Then beyond that is the pigmented trabecular meshwork, then the non-pigmented trabecular meshwork, and then the Schwab's line. So now I come to where mistakes in gonioscopy happen. One is when we see a shallow AC on slit lamp. Here we see the slit lamp on the iris, the beam on the iris and the beam on the cornea are absolutely touching each other. It is like a flat chamber. But when I do a gonioscopy and I do an indentation gonioscopy, I can see angle structures here. So first confusion happens in narrow angle glaucoma when we suspect it, and it is actually a plateau iris configuration versus angle closure. Here some structures will be seen. Here there are no structures that are visible. So this is angle closure. This is a plateau iris configuration. Now, the other thing is when we see iris processes and when are we seeing peripheral anterior synechia, there are some differences. Iris processes are very fine. They extend into the scleral spur. They follow the concavity of the angle, and you can see the angle structures beneath it. But when there is an anterior synechia, then you will see that there is a broad area of iris which is adherent to all the underlying structures, and it bridges the concavity of the recess and it resists the movement of the eye also. So in these cases, it can be occludable angle. From chronic uveitis, it can be post-surgery where these kind of peripheral anterior synechia are happening. Now, the other thing is I find many clinicians confused when they see a pigmented trabecular meshwork and whether it is a Sampolizi line or a pigmentation that is there, which is normal. So in this figure, we can see that all the angle structures are there and there is a pale pigmentation of the trabecular meshwork in the posterior part. Here, the pigmentation is uniform and it is stretching across the whole angle. Here, the pigmentation is heavy. It can be called 4+. It can be there in any inflammatory condition. It can be then normally also in Indian eyes. But Sampolizi line, it shows as wavy lines of pigmentation, which are a little beyond the trabecular meshwork. Now, neovascularization and blood in Schlemm's canal. This is also where commonly mistakes can be made. So neovascularization, the first thing is sometimes it is aggressive and you will first see the neovascularization on the iris itself. But if you're looking at the angle and you see only a very small area where you have these small pale blood-like vessels which are seen present in an open angle, then you know that this is neovascularization of the angle. However, if there is a blood in Schlemm canal, it is not a normal condition. It usually happens when there is raised episcleral venous pressure or when you kind of press onto the cornea a little more, which makes the blood reflux into the Schlemm's canal. That is usually a whole band of pale red color, which will be seen where the TM is. So it is actually not seen normally. It will be seen in certain conditions, and then you know it is blood in the Schlemm's canal, not NV angles. So these are the few things that I could find where mistakes can be made on gonioscopy. Before I conclude, I would like to continue on to my second presentation, which is there on optic nerve head assessment.
Okay, go ahead.
So I hope the screen is visible.
Yeah.
So this is the, I think, the key point in assessing glaucoma. We have to have a good idea on how to assess the disc and where we go ahead and mistake assessing an optic nerve head, calling it glaucomatous where it is something else. So first, how do we do the method of clinical examination? What is the best method to see the disc? There are many methods. You can do direct ophthalmoscopy, indirect ophthalmoscopy, you can do stereoscopic photography. And but the best method is to do a slit lamp biomicroscopy using a 78 to 90D lens. If the pupil is not dilated, then it should be a dark room or a mesopic light condition. And then you must repeat it in a dilated pupil if narrow angle is not suspected or gonioscopy is all right. So
not visible.
Is the slide not visible?
No, I can't see the slides.
Oh, it's visible.
Yeah,
No,
visible to me
no,
also.
ma'am. Nothing is visible.
Okay, let me share
Not
it.
visible to us.
Let me share it again.
Why don't we use 4-mirror gonioscopy, Rashi?
It's pretty bulky and heavy, sir.
Gotcha. Otherwise, no problem.
Otherwise, no problem.
Because if you use 4-mirror, you don't need a thick viscoelastic substance.
Normally in the OPD, I use a Zeiss 4-mirror, which is handheld. Is it visible now?
No, it is not.
I have been using Posner, and Posner 4-mirror is very light, very easy to use, and we don't need coupling, so it is very convenient for me. I've been using it regularly.
That is what I do also. Most commonly I use 4-mirror, and suppose the patient is not very comfortable, then I use a.
Yeah, we can see your slides.
Yeah,
We can see your
visible.
slide. Okay.
So there are 5 hours which we have to stick to when we assess an angle. I know that with practice, I see most of the details in the disc, but I know that when I had started out as a PG, just the disc reflex was enough for me, and you used to feel very happy that I've seen the disc. But the 5 hours are, you have to look at the ring of the sclera to identify the limits of the optic disc, whether it is small, moderate, or large. This is very important. Then you have to look at the neuroretinal limb for its color, size, and the CD ratio. And retinal nerve fiber layers for any wedge defects. Then the region which is outside the disc for alpha beta zone and peripapillary atrophies. And finally for disc hemorrhages and pre-retinal hemorrhages. So there are certain things which are typical for a disc, but they may always not be normal. So what is typical? Disc is vertical in size and the cup is horizontally oval in size. That is the first thing. Then it follows the ISNT rule, which we all know. The inferior rim is the thickest and the temporal rim is the thinnest. The color of the rim should be about pinkish yellow, orange, and both discs are usually similar in size. If there is a 0.2 cup difference, then you should get alerted. And the central retinal vessels are slightly nasal to the center. Now, when we see the RNFL reflux, we must focus on the superior and inferior parts of the disc. So variation of a cup disc has a wide variation for normal in the population. It can be from no cup to a 0.9 cup, and both can be normal. So in this picture, we see a very large disc and it has an almost 0.75 to 0.8 cup, but this is a normal cup. It is not glaucomatous. So again, when we look at the 5 hours, we can see that ISNT is maintained. There is no focal notching anywhere. There is no RNFL loss. There is no disc hemorrhage, no nothing. The rim is also nice and orange. So this is a large physiological cup. However, when we look at this other picture, we can see that there is a small disc hemorrhage at 6 o'clock. The inferior rim is slightly thin over there. And we can also see that the rim color is different. When we compare the two discs, we can see that this is orange and that is pale. So the other disc, which is again a 0.8 cup, is a glaucomatous disc. Now, small discs usually have no cup or a very small cup. So if there is a slightly larger cup, maybe 0.4, 0.5 cup in a small disc, then you should always be a little hesitant in calling it normal. So vertically in this disc, we see that the cupping is vertically oval. Normally cups are horizontally oval. So that is the first red flag. Again, ISNT is not maintained here. We can see that the rim is a little thin. We can see there is a wedge defect at 5 o'clock and the rim on this side is also pale. And so we go ahead and label it suspicious glaucomatous cupping, and then our field will be done and it will probably come with a superior defect. Now, sometimes the disc looks pale, but it is a neuropathy which is not glaucomatous. This is very important here. We can see that the cup is smaller, like a 0.45 to 5 cup. And in general, the disc is a bit pale. So here we know that some neurological problem can be there. And when we do a field, then we get a hemianopia bitemporal. Now, tilted discs are very difficult to identify because they have an atypical topography. And in myopes, it always becomes very difficult to assess whether the disc is glaucomatous or it is a normal myopic disc. So in this, if only the reflex is taken, this whole thing will be taken to be a disc. But when you do a good dilated 90D examination, you will see that this whole area is actually a temporal crescent. And then the disc is there. Now this disc, we might think is normal. However, when you look at it carefully, we see that though it is tilted, it has a large cup, which can be normal for myopia. You can see that here the rim has become thin. And there is a bending of the vessel when it is coming out of the cup. So this is highly suspicious for glaucoma. Myopes in general are predisposed to glaucoma also. So we go ahead with the glaucoma investigation in this patient. Now, optic disc drusen, again, the disc reflex is whitish, but when we look at it closely, we see we can hardly make out where the scleral ring is. We can hardly make out where the cup is. And overall, the disc has a bumpy, convoluted look with vessels going on top like this. And the best way to find out whether we are looking at optic disc drusens is we look at a ultrasound and clearly a drusen can be seen. Now, myelinated nerve fibers, here again, this is very prominent and we immediately term it as a myelinated nerve fiber. This, if we don't look at carefully, the whole posterior pole looks whitish and then you get confused where the rim is, where the cup is. However, between the two pictures, I would say this is more normal because it is pink. There is no deep cupping, there is no shallow cupping, and mostly ISNT is maintained. However, in this, we can see that it is slightly thin here, it is slightly thin here, and this part of the rim is a little pale. So I would like to go ahead and do a glaucoma investigation for this patient, not just see the myelinated nerve fiber. And of course, myelinated nerve fibers also give rise to certain field effects. So we have to correlate whether the field effect is because of this or because of the rim thinning. Optic disc pits, I think Kashyap sir will be better able to tell us more about this, but optic disc pits also give us a large cup look, and we can see a serous maculopathy in this patient. And when we suspect optic disc pit in such a patient, then again, if we do a field, they will come positive for some field effect because macula is involved as well as part of the nerve fiber layer. So then the diagnosis based would be the summation of what the other ID is like, what the pressures are, what is the corneal thickness, and then we can decide whether actually this patient needs any glaucoma medication or not. Finally, I come to disc coloboma. If the child is seen early, then we know that disc coloboma is present, because in a young child with low pressure, this kind of disc is usually not seen unless it is a big coloboma. On careful examination, we can see very large cup. We can see neuroretinal rim missing in one area. And these discs don't usually progress to anything more beyond, but the child should be followed for other problems. So disc colobomas and morning glories are another type of disc which look very different. And I think that about covers all the type of atypical discs which we can confuse with glaucoma. Thank you so much.
Dr. Rasi, once in a while we get a hyperopic disc with a very small cup, but when you go for a glaucoma investigation, we get a frank glaucomatous scotoma.
Rashi, please stop sharing the slides.
Absolutely, sir. We should be very careful with small hyperemic discs. And as I said, small discs don't have any cup. So if they have a cup and any focal thinning anywhere, then we must investigate.
Thank you.
Rashi, please stop sharing the slides. Okay. So first, I request Dr. Rashi, who is the coordinating this session, to introduce Dr. Medha Prabhudesai. She is a very senior glaucoma surgeon, Dr. Medha Prabhudesai. She's from Pune. Am I right?
Yes.
Please introduce. So our guest faculties are really from all over India, and they are all leading their subspecialty.
So ma'am, after you've done with your presentation, if we could put up the slide with your biodata on it, but I would like to introduce Dr. Medha, as she's currently the director of Vision Foundation Pune, and she has been an honorary assistant professor in Bharati Vidyapeeth Medical College Pune also. She has more than 30 years experience as a glaucoma consultant in active practice, and she is a fellow of the Shankar Nethralaya Foundation, Chennai. Now, she has multiple papers and in peer-reviewed journals, as well as in national and international conferences. We heartily welcome you, ma'am.
Thank you. Thank you for your kind introduction. And I would like to thank Dr. Bharati also for giving me this opportunity. I'll be talking basically on mistakes in ASOCT in glaucoma, and basically they are angle evaluation. So assessment of iridocorneal angle can be done with the help of gonioscopy, which we have seen in detail. Next is UBM, and next is OCT. So let me see how we can do what we can do with ASOCT. So assessment of A structures involved in the pathogenesis of glaucoma can be done very well with ASOCT. It provides us a definition of ocular tissues comparable to histology and can be performed by a technician and should be interpreted by the physician. It is definitely complementary to gonioscopy and not a replacement. That you have to understand very well. So the top mistake in identifying is relying only on ASOCT without doing any gonioscopy. So because though this is an objective test, the interpretation can be subjective. So you cannot visualize the angle. It's not possible to see anomalies in the angle, which is pseudoexfoliation, peripheral anterior synecdoche, pigment, and neovascularization in the angle. Also, light conditions can affect the angle, which is not seen or sometimes not very appreciated on gonioscopy, and you cannot rely totally on automated algorithms of ASOCT. The next mistake is taking images from some other devices and comparing to your device, which is not possible because they are not comparable, because these machines differ in their OCT technology, modeling parameters, dewarping algorithms, and assumptions about the refractive indices of the patient. So other mistakes are poorly aligned scans, imaging artifacts, attenuation or shadowing because of the multiple opacities near the limbus, and inability to identify Schwalbe's line on or anterior iris surface. So these are the poorly aligned scans. You cannot make out where the iris is, where the angle is. You cannot really make out where the angle iris is inserted. So these scans should be totally discarded. The shadowing effect or rainfall effect, what we see is because of the opacities or the arcus near the limbus or any opacities in the perilimbal tissues, and it can be compromised, and you can actually highlight and see if they are really good or see. So here, though the angle appears open, you can see that there are the anterior synecdoches, the iris has been pulled up. So subjectively, you need interpretation, and you need a very good interpretation from this. The next is operator dependent mistakes. Operator has to be familiar with the purpose of the image and its proper acquisition protocols. So he also has to take into consideration the lighting conditions which affects the pupil, because the angle width can narrow or widen as the pupillary size changes. So this is a scan of ASOCT in a photopic pupil with the light conditions on. When the pupil is small, you can see how the eye angle is behaving, and here immediately in a scotopic condition where the pupil is slightly dilated, and it can appear that the angle is totally narrow or oppositional angle closure is there. So this has to be taken into consideration. Position of the meridian of the ASOCT is also important, because as you can see, the same patient with different meridians, the angle can appear differently, iris can appear convex, and you have to take into consideration this also. Mistakes in the interpretation are because of the difficulty in identifying landmark structures, image distortion, examiner dependent factors, and errors due to auto segmentation of the algorithms. So let's see them one by one. So we know that this is a Descemet's membrane where it ends, and that is a Schwalbe's line, and this is a corneal wedge here. So this is a scleral spur. So you need to identify these structures, and then only you can define where the angle is and how the angle is. So this is angle here. So again, Schwalbe's line, then the trabecular meshwork. Here the dotted line is showing trabecular meshwork where the scleral spur ends. So next is mistakes due to subjective interpretation. So different examiners interpret the ASOCT angles differently. So they have different interpretation of the position of the landmarks. The level of agreement, various research studies have shown the level of agreement is moderate in grading ASOCT images, and this can cause a source of error when comparing images over multiple visits or among different practitioners. Image distortion can be there because these images are acquired are not perpendicular to the ocular surface, and there is a risk of diffraction phenomenon, and this gives rise to distorted images. As you can see here, the iris is totally inverted here, and it's difficult to make out how the angle is here. So the next is ciliary sulcus and posterior ciliary body cannot be imaged. This is because of the can you mute? Can you please mute? I can hear some voices. Next is poor penetration of the iris pigment epithelium, and here obviously the ciliary sulcus and ciliary body cannot be imagined, and this can greatly impact interpretation, especially the auto algorithms of the scans. You cannot rely only on the angle configuration and the angle measurement, because if you see here, the iris is pulled upward and this is a patient of chronic angle closure. Okay. Next is, again, angle recession cannot be seen very well, though you can make out, but still it is not possible to see how much angle recession is there and what exactly you are seeing, because the angle visualization is not there in the ASOCT. So there are multiple static factors like lens vault, anterior volume, the relative length of the vault, then iris area, iris thickness, angle opening distance. I will not go into details of this because this is a very vast topic. TISA is also there, either 500 or 750. So all these static measurements are there, but the algorithms are based sometimes in some machines on subjective inputs. So and for AOD and TISA, you have to locate the scleral spur manually. So this may induce error, and the specificity of this is reduced by frequent poor visualization of the SS. Errors occur in automatic segmentation algorithms also, because there is a failure of correct segmentation. It is very commonly seen in images with good quality also, and this can affect anterior chamber volume and iris volume also. They are more frequent in narrow angles, especially angle recess, iris root, posterior surface of the iris, and pupillary margin. Even in wide angles, the anterior surface of the lens cannot be segmented and cannot be located properly. And one study showed that in ASOCT, automated segmentation error resulted in large ACV and smaller iris volumes, which were again associated with anterior chamber depth, anterior chamber width, lens volume, and the CCT also. So again, significant attenuation of the signal occurs when penetrating the lens, and this there can be errors in the segmentation algorithm of posterior surface of the iris and pupil margin, and also incorrect location of the angle recess can be seen, and one study has shown it is almost as high as 84%. So these static risk factors, various studies disagree whether these association, that is risk factors along with PACD, are statistically significant. And Chang et al. Has shown that irregular iris surface made the AODs not very accurate. So these all these automated segmentation and automated measurement should be taken very carefully. So to summarize, ASOCT is not to replace the conventional gonioscopy and to supplement and augment angle evaluation. We do have major advantages, that is non-contact nature of the examination. We have repeatability and reproducibility. We do have quantitative and qualitative information, but needs very careful evaluation. It may help in screening programs of primary angle closure glaucoma, may improve our understanding of glaucoma surgeries, and invaluable tool for ophthalmic research. I would like to thank all of you for your patient hearing and giving me this opportunity. Thank you.
Thank you so much, ma'am.
Thank you.
I'm calling Dr. Ajit Hazare to be ready. Dr. Vinay Nangia. In the meantime, Dr. Rashid, please carry forward the session. Thank you, Dr. Medha. Thank you so much.
Thank you. Thanks.
Madam, what is your experience about the UBM while measuring the angle?
No. I don't have any experience with UBM. I've never done UBM, though I send my patients to UBM, but I don't have any personal experience.
Okay. Dr.
So we had UBM at our center. I think it is only useful when actually you cannot visualize anything because of blood or dispersed hemorrhage in the anterior chamber, where you want to see the angle or you want to see whether iris is bulging or the lens is a little dislocated. Otherwise, if the cornea is clear and visibility is there, then
If you want to visualize structures behind the iris where we cannot visualize with OCT, then it is most useful.
Yeah, especially when the media is very hazy in cases of, let's say, coronal opacity, or the measure absolutely hazy, and you want to know what is the condition of the lens, or what is the condition of the IOL, what is the tilt of the IOL or lens, and at the same time, what is the effect of this tilt on the angle. This becomes very, very useful. And while doing ASOCT, it doesn't take everything into account. But then when you do USG, you see what is the tilt. You go to even the posterior part of the lens and you see what is the condition of the lens. It tells you what is the tilt.
True, very true. You can even see Descemet's folds, envies, and even if you have a iridodialysis PI, whether the PI is patent or not, all those things you can see very well with ASOCT. And with media opacities, small pupil and the thick iris, if you want to visualize anything behind, whether the haptic is touching the iris, why there is inflammation. And as you said, everything, Dr. Kashyap has said everything. So there UVM helps very well.
And also, ma'am, for ciliary body structure.
Yes.
True. So I would like to now invite Dr. Tanisha. Please present.
Hello, ma'am.
I would like to introduce Dr. Tanisha. She's a young glaucoma surgeon. She has done her long-term glaucoma fellowship, and she's working in CC consultant.
Ma'am, are my slides visible?
Yes, yes.
Okay. Thank you, Dr. Bharti, for giving me this opportunity. I will present on perimetry, and my topic is basically related to recognizing and dealing with artifacts. First, make sure that we have chosen the correct strategy and the correct target size and the data entry is right. Also, ensure the payment is good, which is paramount to carry out the business. So, this is a classic example of suddenly the values are going to 0. So this is very
mute
Please mute. So if the patient has drifted back from the machine, or the lens the carrier has been placed very far away from the patient's eye and not just clearing the lashes, then we can get such artifacts. And this 0 suddenly in the values indicates that this is a RIM artifact because it is not going to be following any RNF2 pattern. So this another interesting printout that I came through is the data entry is about the right eye, but as soon as we see the blind spot, we know that the left eye is being tested. So we have to go back and get the test done again. I'll come back to the liquid trial lens. So in case we have a pseudophakic young there's a lot of background noise.
Lot of noise, please.
Yeah, and there's a lot of background noise. So in a young
Dr. Deepak, please take care. While talking to your wife, please switch it off. Please go on mute mode, sir. Dr. Deepak.
बहुत मुश्किल हो रहा है बढ़ाए बाल वेकेशन में नहीं बाल बढ़ाए नहीं बढ़ाने से भी आता है
Okay, so I'm back to my slides now. So in a young patient, the machine fails to calculate the section.
Body में नहीं आ रहा
patient has undergone a surgery. The fields that we get might not be correct. So again, here I'll emphasize how the change in target size from 3 to 5 will drastically improve the parameters. Here you can see the parameters are bad, and on changing the target size to 5, there's a drastic improvement. So if we now know that there's a single paracentral defect in a 24-2 printout, we can switch to a 10-2, which will highlight the defects more substantially. And there's a reasonable balance which can be achieved by a new strategy called the 24-2C, which adds 10 test points extra in the center. So in this patient, which I have been following up for the last 6 months, he came to me in December, then again in June 2023. So when I noted that the patient is showing a VFI 1%, I asked him to undergo a 24-2C where the central points were more highlighted, and I could rule out that any went to the fixation was not there.
Very important topic, Tanisha. Hold on. A coordinator from NTOD. Please mute Dr. Deepak for a moment. Yeah, he's muted now. Okay. Thank you. Okay, go ahead.
So here again, this is a very interesting artifact which is not commonly noted. As soon as you look at the fields, you can see that the blind spot has shifted much below the horizontal meridian. So what could have gone wrong? This happens when the patient has not shifted back the fixation after the foveal threshold has been tested. So when the patient is still fixating here, the blind spot will shift down from the meridian. The whole field will actually shift down. You can see here. So the patient has to be clearly instructed to go back and look at the fixation. Now here in this case, this is the disc finding where inferotemporal rim thinning is noted, and a very well correlated finding on the field can be noted, a superonasal defect, but we see that the reading is a very high false negative. So I'll take it with a grain of salt and not discard this, although the 25% false negative comes out, but since it is correlating well, we should keep this field. And this again is a very classic, very exemplary cloverleaf pattern in a very high false negative. Now, as soon as we see this very dreaded white scotoma, we know that we have to discard this field and not interpret this. And this disconnect between pattern deviation and the total deviation plot, where the pattern deviation is much, much worse than the total deviation. We know that this is a high false positive. So we have to discard this white scotoma fields. And this again, although the readings, the parameters are well in place, but then when you see this defect where total deviation is normal and the pattern deviation is only showing this defect, we know that there are certain hidden false positive, and why this happens, I'll come to it later if time permits. Normally, this is what we get when we correct the total deviation to achieve the pattern deviation. So, yeah, this is interesting because here we see the gaze tracker showing such a reading where the patient seems to be looking at a tennis match, but the fixation losses recorded by the machine is very, very low. So what do? We go back and look at the disc. So disc is having a very large peripapillary atrophy. So when the machine goes and projects stimuli on this, the fixation losses cannot be pointed out, but the patient is actually moving the eye a lot. The reverse is true in this case where there's a very tiny disc, although the patient is maintaining gaze totally. If you see the gaze tracker, it's awfully stable, but the fixation losses here are very, very prominent because the disc of the patient is small. So whenever the light is being projected, it is probably falling on the adjacent retina, and the blind spot is not being mapped correctly. This is another interesting case where the patient underwent a LASIK surgery and failed to inform the technician who was doing the fields. So in the repeat field, the machine already gave this -4 and the fields were very bad. But when this was removed, the fields drastically improved in this young myope. Now, by looking at this, we can know that this is not following any pattern of the RNFL distribution. So this this was a case of a dermatocollosis, and when we tape the lid, we can see that this defect goes away. So now mistakes while labeling progression. Progression can be either darkening of the existing scotoma or enlargement of the existing scotoma. So if we look at points which are within or adjacent to an existing scotoma, they are more likely to represent true changes than the points which are far away and have no special relation to the existing defect. Also, the cluster of points are more likely to be true progression rather than random points which are scattered. So this is the GPA printout. And lastly, I would say that certain patients fail to do fields no matter how many times you try or what you explain. In such patients who have such bad parameters, you should switch to some other mode to follow the patient and give up eventually on fields, because this patient will consistently perform poorly on the fields. So the take home is, I would say it is prudent to treat the patients and not the fields, and the importance of correlating the visual field outputs carefully with the patient history and clinical examination. Thank you.
Thank you so much, Dr. Tanisha. I would like to welcome Dr. Ajit Hazare for his presentation now.
Thank you so much for inviting me for the midterm conference. Thank you, Dr. Bharti. Is my slide visible and am I audible? Okay.
Yes, very much.
Thank you so much. So we'll be quickly going over the top mistakes which happen in OCT evaluation. And what we know is that the OCT machine has become so common and easily available to most of the practitioners available in almost every city. So the OCT data is a treasure house of information, and it is usually very, very simple to identify defects which happen in the OCT printout. But the challenge is when we are looking at glaucoma suspects, when we are looking at early disease, and when we are looking at progression analysis, especially in an advanced glaucoma. So if we look at the common sources of mistakes which happen when we are using OCT, just a minute. Yeah, so the most common mistakes are because of operator errors, patient errors, that patient is not seated properly or other things, patient pathology, that's the eye is not really in a good condition to do a correct OCT, or there are software errors and there are clinical interpretation errors. And what are the most common mistakes that happen during OCT and its evaluation is that we base our clinical decisions on poor OCT scans. So the image quality is poor and that gives rise to a bad decision. Or we are looking at a single OCT scan because only the printout is available to us, and that scan has not gone through the area of interest. So it's not giving us useful information. And the other common mistake is that we have multiple printouts from different machines and we try to correlate the results from one machine to the other, which makes which makes analysis quite difficult. The other thing is that sometimes in healthy eyes, we come across RNFL and GCA defects, and these show up as red areas on the OCT scan, and this is called red disease, while actually the eye is normal. And the opposite of that is the green disease, where there is glaucomatous defect already happening, glaucomatous damage already happening in the patient's eye, but the OCT is unable to pick it up. When we're looking at progression for glaucoma, especially in early progression, then we have the OCT printouts generally tend to give us quadrantic maps for progression, but we need to look at the clock hour maps, and failure to look at the clock hour maps on the printout is an important source of error when we are looking for progression. Here's an example of poor image quality. This can happen due to wrong data entry, so the comparative database is wrong, or there's a misalignment of the scan circle around the disc, as you can see in this scan on the right side, where when we center the scan properly, the inferior RNFL defect completely disappears. So this can happen due to poor patient positioning, or it can happen due to dry eye and other things. So what are the other causes of poor image quality? Dry ocular surface is the common reason. Then very small myotic pupil can give rise to scotomas, or it can give rise to black areas on the scan. Media opacities, blink artifacts, then vitreoretinal interface abnormalities, typically VMT or ERM, where ganglion cell layer analysis cannot be done accurately, motion artifacts because the patient is not able to fixate properly, or the OCT machine itself is in a poor condition with a lot of dust inside, and this gives rise to low signal strength for the OCT. When we are looking at vitreoretinal, when a patient has ERM or VMT or interface abnormalities, then you have to avoid looking at the ganglion cell layer analysis because that's going to give confusing picture. Instead, you can rely more on the analysis of the RNFL data over a long period of time. For example, on the screen, you can see on the left-hand side, you have the RNFL, which shows gradual progression over few years. And on the right-hand side, you see the ganglion cell layer analysis with the ERM, and that is not showing any useful data, while the RNFL analysis is correlating with the progression on the visual field. In certain, let's say 5% of the normals, you can get red areas on the scan. And how do you rule this out? So you rule this out by correlating the RNFL and the GCA. If it's happening in both the scans, then it's likely to be abnormal. But at the same time, you need to look at the scan quality and the details of the scan. For example, here in this patient, this is a patient with stable RNFL and GCA over 7 years. And if you look at the IOP is also stable between 11 to 20 and has stabilized over the last 3-4 years. The right eye consistently has a superior RNFL defect, but if you look closely at the TISNET map, you see that the superior RNFL bundle is more temporal than expected. So compared to the normative database, you will end up with a red defect on the scan report. So these are the things you need to look at, correlated clinically with the clinical picture, and then you come to a conclusion whether it is really abnormal or normal. The other challenge is that trying to assess whether the glaucoma is progressed, especially in advanced glaucomas, because there's a concept called floor effect, where if the RNFL thickness is less than 50 to 55 microns, then the machine is unable to pick up any further damage that may be happening. But the other part of the RNFL scan may still be having good data, so that can be compared over a long period of time. For example, in this example that you see on the screen, there's an inferior RNFL wedge defect, but the rest of the RNFL is still within the normal range. So the rest of the RNFL can be followed up over a long period of time to see if there is any progression that is happening. So in summary, we have to pay attention to the ocular surface, the patient position, and comfort, and media opacities like PSC cataract or corneal scars. There has to be always careful correlation between RNFL and the ganglion layer analysis. And if ONH angiography is available, that also gives us additional information. So if there is consistent defect seen across all the three, then the chances of our analysis are more likely to be accurate. Serial studies of the scans over a long period of time help us in picking up defects that are insignificant initially and may become significant over a period of time. And this can guide us to detecting early progression. Thank you.
Thank you so much, sir. A very, very well presented, clear-cut take on OCTs in glaucoma. I would now like to invite Dr. Tanisha with her next presentation, please.
Thank you, ma'am. So next presentation is about mistakes in initiating glaucoma therapy. So before we subject a patient to a lifelong glaucoma therapy, the diagnosis of glaucoma should be reasonably established. And a complete examination of angles is a must, as already has been emphasized by Dr. Rashi in earlier slides, because we tend to miss out patients of angle closure, and we have come across cases who have been put on topical anti-glaucoma, and all they need is a laser, but laser has not been done. So the patient continues to progress. So gonioscopy is a must. All they need is a laser iridotomy to prevent the progression from happening. Again, a lot of prescriptions come in where based on a single IOP reading, patient has been subjected to anti-glaucoma therapy for life, and DVT has not been carried out. So all this has to be taken into account. According to the recommendations of early manifest glaucoma treatment, recording of the baseline IOP, how the patient is presenting, is a must, because at least a 25% decrease of IOP from the baseline is needed to reduce the risk of progression. Again, the target IOP range has to be very individualized and has to be repeated and checked and reset with time. And it also tells you and guides you which the initial drug treatment should be. Central corneal thickness, which has already been pointed out by other speakers, that we should not be using these nomograms to achieve a correction factor, but it should be kept in mind that thicker corneas will have an artificially elevated IOP and thinner corneas will have decreased IOP than the true IOP. And also the thinner corneas are an individual risk factors for glaucoma. So we'll start with monotherapy, and accordingly, if the drug achieves target IOP, we can continue. And if we have given a unilateral drug trial in the second eye, we can start. If the drug fails to reduce IOP by at least 15%, then we can consider switching class. If the drug has reduced IOP, but not up to 15% and not reaching the target IOP, then we can consider adding or switching and keeping this one in reserve. So that is what we'll follow. Intra-class switching is only possible with prostaglandin analog. Suppose bimatoprost is not working, we can give a trial of latanoprost and or travoprost, but otherwise it is not possible in other classes of drug. So the prescription should not be too complex. Efficacy, compliance, safety profile, and affordability should be kept in mind while prescribing the drugs. So if it is very prudent to remember that more than 2 pharmacological preparations with a maximum of 3 active molecules, more than that should not be prescribed, because it is not going to be additive or beneficial in any way, and it will not be very well tolerated. So maximum tolerated medical therapy should be kept in mind, and the drugs that we are prescribing should have synergistic effect and not the same mechanism of action. So if the patient is already on systemic beta blockers, the topical beta blocker will not be very significantly helping in reducing the IOPs. Also, if the patient is a hypertensive and taking drugs which are lowering the perfusion pressure because of the nocturnal hypotension, that may also lead to progression of glaucoma. So that should be kept in mind. Proper clinical history should be taken. And systemic as well as the local side effect profile should always be kept in mind while making the choices. One thing I would like to emphasize is when prostaglandin analogs are not taken in night, they will not have the effect that we need to blunt the morning spike in IOP. So the 9 p.m. prescription is important and should be emphasized on. Again, in normal tension glaucoma, before labeling them as normal tension, although essentially they are treated in the same line as primary open angle, but before labeling them as normal tension, a DVT should be carried out, CCT and gonioscopy. To rule out primary angle closure is important, because at times angle closure presents with normal IOP, but later it spikes during the day. So I would come down to these prescriptions where Combigan, which has brimonidine and timolol, has been prescribed with alphagan, which again is brimonidine, and this will not help the patient, would rather cause more side effects. Again, here dorzolamide has been prescribed with timolol, but the prescription is like 4 drops. Patient and the physician, I don't know how they'll make out how many times the drops are to be given. Here again, Sinbrinza, which is brimonidine brinzolamide, has been prescribed with brimonidine and timolol combination, which will not be very helpful to the patient and will increase the side effect. So all this should be taken into account. In ocular hypertensives, we should treat the patient if the IOP is consistently more than 28 to 30 millimeters of mercury. And in a young patient or a one-eyed patient, a patient who is going to be lost to follow-up, we should consider treating the ocular hypertensives, especially if the patient has suffered a vascular occlusion in the past. And while prescribing, medical jargon should be avoided and simple formulation should be given to the patient. Thank you. So customizing and individualizing is important. Thank you so much.
Thank you so much, Dr. Tanisha.
Thank you, ma'am.
Can we have the next PPT, please, on screen? Vinay Nangia, sir, have you joined? So I would like to invite and introduce Dr. Vinay Nangia. He is the director of Suraj Eye Institute, Nagpur. He has been a former president for Glaucoma Society of India. He is also an alumni of Shankar Nethralaya, Chennai, and has also trained in UK and the Harvard University in Boston. He has more than 170 publications in peer-reviewed journals, and we welcome you, sir.
Yes. Can everyone hear me and see me?
Yes, yes.
Okay. Thank you.
You are audible.
Thank you. Thank you very much for having me here today. And I'm going to take you through a short talk on mistakes while assessing the progression with the retinal nerve fiber layer. Oh, I don't know what's happening. Sorry, it's not moving actually. Can everyone hear me?
Yeah, we are hearing.
Yes, sir.
For some reason, the slides are not moving.
You can hear. Yes. Now it's moving.
Yes, moving, doctor. So, so the average change that is acceptable for the average retinal nerve fiber layer thickness is about 4 to 5 microns for glaucoma progression over time. But because of the lower reproducibility of sectorial compared with average retinal nerve fiber layer thickness, a relatively more significant change would be needed in sectors for similar confidence of actual change. So that means you're looking at somewhat a larger change in the temporal, superior, and inferior quadrants. So the aging loss for average retinal nerve fiber layer is roughly about 0.52 microns per year. But for superior, it's expected to be about 1.35 microns, and for inferior also about 1.25 microns. This was over a period of 30 months, and therefore it can't be taken as the gospel truth, but it does give us an important guideline as to what we should consider when we're looking at progression of retinal nerve fiber layer. So one should treat with caution if there is statistically significant slope of less than 0.05, because about 25% of normal eyes may be shown to have this change. So you need the significance of the slope, but you also need to visualize how much retinal nerve fiber layer change has taken place, and that should ideally be much more than the normal loss that takes place over time. So I will take you through some examples, and this is a patient where the segmentation lines join up. So inferotemporally, where you see the blue arrow, the red and the blue line have joined up, and that is an error in segmentation because it never goes down to 0, because less than 50 is what is the flooring effect. So when it's 30, 40, 50, this kind of error is very important, and we should note this when we're looking at progression. This is another error that you can see where if you take a look at the blue arrow, you can see that's a superotemporal hump, and there is a segmentation error there from 2015. And when you go down to the one that was done in 23, you'll find the segmentation error is largely resolved. It's not perfect, but it's giving you an impression that there has been a significant loss of retinal nerve fiber layer over the last sort of 8 years. Now, this is important because the rest of the retinal nerve fiber layer is very significantly damaged, and this patient, whatever vision he has, may just be dependent on the hump of superotemporal retinal nerve fiber layer. So it's very important to check for the segmentation. Now, this is an epiretinal membrane that you can see. The blue arrow on the top right tells you the epiretinal membrane. And when you go to the image just below that, you'll see that the red line covers the epiretinal membrane, actually. Therefore, you're getting a falsely high retinal nerve fiber layer thickness in this region. Of course, this region is not very important, because it's in the nasal side, but that is an example. And you will see in the next slide that I show you. Sorry, it's stuck actually.
So maybe you can stop sharing and then start sharing again.
That's what I'm doing, but somehow the computer is not allowing me to do anything more. I'm not able to. There you
I've
go.
stopped it. You can share again.
Is it better now? Can you see it if I just?
No, sir. You have to share again, sir. I've stopped it from my end. You can share again.
Okay. Is it all right now?
Yeah.
Okay, so I won't make it into I won't go to the play screen. So you can see that this is the same slide that I showed you because of the epiretinal membrane. And you can see here, there is a significant epiretinal membrane here. And the top right slide where you have the blue arrow, you'll see that the red line is segmenting the RNFL below the epiretinal membrane. And when you go to the slide below that, you'll see that the blue arrow here shows you that the red line has gone above the epiretinal membrane actually. And this is of 2022 and this is of 2023. So these kind of errors, especially with epiretinal membrane, you should be very aware of, especially when the error takes place in the temporal retinal nerve fiber layer, because that's the most important part of the retinal nerve fiber layer, and the membranes are all temporal actually. So that is a very important thing to just keep in mind. So segmentation also is a challenge because of the blood vessels, and sometimes it cuts the blood vessels. So if you see in 2015, there's a part of the blood vessel that is below this blue line. And when you come here, you'll see that the blue line is encompassing the edge of the blood vessel very nicely, giving you an impression as if the retinal nerve fiber layer thickness has increased. This is also much more common when there is significant retinal nerve fiber layer loss. This is a case of retinoschisis, and you can see here that there is significant retinoschisis. And fortunately, over a period of 3 years, the retinoschisis resolved. That is well known, and you can see that there was significant thinning. So when you get thickening with retinoschisis, you may not be able to assess the degree of glaucomatous damage, as you can see from this area here below right. And this is a very classical early retinal nerve fiber layer progression. If you take a look at the green line going here and you come down here, you'll find that there is a significant loss here. There's a significant loss of almost 22 microns. And you can see here the light gray line is from previous scan that was done in just a few months before. That was in February, and the second is in September. So between February and September, 22 microns loss has taken place. So when you do get accurate segmentation, then I think, the retinal nerve fiber layer really helps you identify pinpoint locations where something like that has taken place. So significant optic disc cupping will often lead to segmentation errors because of the flooring effect. It bottoms out. But you may still wish to assess the OCT to follow up on, especially for the macular retinal nerve fiber layer, which tends to, it doesn't undergo damage very quickly. And that's why we continue to have central vision till the very end. Epiretinal membranes and retinoschisis are the major causes of errors, and myelination of RNFL can also cause significant segmentation errors. We always think that we should look at different images and images without the segmentation to get a clinical impression of the accuracy of segmentation and health of the retinal nerve fiber layer. That is not merely depending on the numbers and not merely depending on the segmentation. Thank you very much for this opportunity. Bye. Thank you.
Thank you so much, sir. So our next presenter is going to be Dr. Abhishek Onkar. Sir, are you there?
Yes, ma'am.
Let me introduce Dr. Abhishek Onkar. Dr. Abhishek Onkar is running the Devghar AIMS. He is the HOD and he is a prolific cataract and glaucoma surgeon. He has keen interest in glaucoma, and every time he is a faculty also for glaucoma. Every time we have a conference, he always participates and presents in glaucoma session. So welcome, Dr. Abhishek.
Are the slides available?
We can see.
Okay.
चलो बेटा दूसरा करते हैं. दूसरा करते हैं.
Respected chairpersons, seniors, and fraternity, good afternoon to you all. Thank you to the Jhos Scientific Committee and Bharti ma'am for providing me this opportunity on a topic which is like not well addressed, rather than it is taken for granted most of the times. That is mistakes in managing drug intolerance. Why is it so? Is because we have been exposed to drug intolerance to anti-glaucoma medications right from our undergraduate education from second prop itself. So it has been like ingrained in our studies, and we take it for granted rather than address it. So just coming to why this topic is important again is because all these chronic diseases, adherence is the key to achieving a good success to the treatment. And it has been reported that non-adherence ranges from 16% to 30%, and in glaucoma up to half of the patients, up to 50% of the patients develop ocular intolerance. And among the 4 major causes that have been suggested for non-adherence, like forgetfulness, cost, and education level, tolerability is one of the major factors that influences how the patient is compliant to the medication. And the studies have suggested, as we can see, for the patients who were adherent, they even identified in 25% of the cases that medication side effects is a barrier, while patients who are non-adherent, it almost was double of that numbers. Now, so what this leads to is a catastrophic vicious cycle where drug intolerance leads to non-adherence and non-compliance, worsening of symptoms, and to counter that worsening of symptoms and progression, we go on to additive therapy, with again the escalation of therapy again paramounts to the drug intolerance and eventually leading to the failure of medical management. So just be highlighting some of the mistakes that we encounter and what we can do about it. So just a very common example where that is the minor ocular intolerance, where the patient started on prostaglandin analogs, complaints of hyperemia. Now what we tend to do is like alarm, because patient is already alarmed that he has been diagnosed with glaucoma, and with red eye they have become all the more grieved. So what we tend to do is either add a lubricant which contains a preservative, which again doesn't help the cause, or we can change the medication or stop therapy. So these are the mistakes that we tend to do, while a simple thing like a patient education and counseling regarding these common adverse effects, which actually are not hampering their vision or any other ocular component. So that has to be counseled, and patient has to be taken into confidence regarding this, rather than resorting to more additive treatments and exposing them to more preservatives, which can be harmful. Another take is some symptoms which can be alarming for the patient, and which the patient presents, like again for prostaglandin alone, hypertrichosis or iris discoloration. So that again, the patient would be like very much worried about the cosmesis factor regarding this, and we may be lured to change the treatment or stop the therapy. But again, building the trust and emphasizing, not only taking the patient into confidence, but also emphasizing the importance of these drugs as the first line treatment, and as just as a single drug, how they can be beneficial in countering their glaucoma IOPs. So that building trust is important, and that is where we fail to actually take the patient into confidence and change to some other therapies. The third is the alarming ocular intolerance cases, which is common to almost all the subgroups of anti-glaucoma medications, like dry eye and keratitis. And now that we tend to counter by changing the medication, stopping the therapy, or most commonly adding the lubricants or steroids. Now here comes the role for avoiding adding lubrications with preservatives. And actually, when we are first diagnosing the case, patient history and examination of pre-existing dry eyes could help. So rather, if the patient already has a history of dry eye, so overlooking the cost, actually we can go for preservative drops, which can help the patient in the long run. And fixed drug combinations, that is subtractive therapy rather than additive therapy, would be more helpful in these cases. Now, Systemic medications intolerance is one thing that we are very much worried about. Like, for example, if the patient complains of metallic taste with carbonic anhydrase inhibitors, now that is a minor systemic intolerance, and we do not need to change the treatment or stop the therapy. But again, it's the patient education regarding punctal occlusion. Just a simple thing which we fail to address to the patient most of the times, and very commonly we definitely do not demonstrate how to do that. So that is something that we need to put into practice regarding the patient education fact. Now, this is the last thing that we should be talking about, that is the alarming systemic intolerance. Like, again, this I had experience during my PG training when the combination of brinzolamide and brimonidine came. So we were very enthusiastic and we prescribed drugs, and it had excellent controls for the patient. But in a fortnight, we had 3 cases with elderly patients complaining of falls and dizziness. That is something you should be worried about, and not there. This is where we actually have to forego with persistence with the treatment if other things are not working, and actually we should be looking for changing the treatment rather than persisting with this treatment, because elderly patients leading to having dizziness, sustaining falls and fractures is something we do not want. So taking patient into confidence and letting them know about the adverse effects. Punctal occlusion to reduce the systemic side effect, that has been shown, like 60 to 65% of the systemic absorption can be avoided just by 3 minutes of punctal occlusion. And that is something we have to stress upon, because if you do not perform a punctal occlusion, that is like almost like intravenous administration of any drug as compared to oral administration. It just bypasses the first pass liver bypass function. And definitely some home support can be provided, or telemonitoring can be helpful in these cases. And changing medication is something that you should definitely be looking forward in these cases. And yes, novel medication delivery systems like the corneal contact lenses or the pumps can be of use in these cases. And lastly, but not the least, is something that we fail to document, is very common thing, which again, as I said, we have been taught for long when has been asked to us in the vivas from our undergraduate days, is something about the patient's history, medicine history, and the drug history and patient's other history that are important. So like with timolol, it can be a breathlessness or COPD or asthma that can be there. So this is where we actually have missed the points. Though it sounds very naive, it happens. And that is something that we need to accept. So proper history and examination are a key to it. And just to highlight what we already know is, like the alpha adrenergic agonists, we should be careful about prescribing them with TCAs or the MOIs. Similarly, with the other classes of drug, I won't go into the details of these things, which we already know, but yes, that has to be emphasized. And yes, so just I will be ending with this presentation by saying that appropriate and early detection is definitely important to adjust the management strategies, and formal education sessions have been shown to be very effective in alleviating patients' fears and their concerns about it, and educating the patient regarding the disease. Once they start comprehending the disease, they try to appreciate it, and once you address their concerns and beliefs, that helps in making those adverse intolerances more acceptable and better treated. And reduction of preservative subtractive therapy rather than additive therapy, and use of fixed combinations and punctal occlusion go a long way in these conditions. And lastly, I would say that we are treating the patient. So what we should be prescribing is what drug is best for the patient rather than what is best in the literature. We are treating the patient as already outlined by the previous speakers, and not the disease itself. So that is something we have to take into consideration. So I thank you for this talk. Thank you.
Thank you so much, sir. Now we have 2 guest speakers in line waiting for very long, so we will move on to the next talks. I invite Dr. Rahul Parikh, sir, to present.
Okay, can I share my screen?
Yes.
Sure. Dr. Parikh has...
Dr. Parikh, please, we have to introduce you first.
Okay, I'll stop. Sure.
Yes, stop sharing.
Okay.
We have to first introduce you.
Yeah, doctor.
Chika is also here. Dr. Chika from RPC.
Okay.
Hello, ma'am.
Hi.
Hello, ma'am. Sorry, we were caught up in a conference. I'm Dr. Upsham here. I'm also back in line now.
Can you see the slides, sir?
Yes.
Okay. So, sir, sir is director of Shriji Eye Clinic and Palak Glaucoma Center, Mumbai right now. And he has been editor, International Glaucoma Review 2018. He has been chief editor, GSI Guideline. He has been the GSI treasurer from 2005 to 2006. He has been the joint organizing secretary of annual GSI conference from 2011 and senior editor of IGO from 2007 to 2013. So, sir, we are greatly honored to have you here today. And Bharti ma'am, please.
Yeah, please share your slides.
Yeah, thanks, doctor. Thanks for inviting. So in next 6 minutes, I'll try to cover the basics, few important point in trabeculectomy. Can you see my slides?
Yes.
Okay. So we know the trabeculectomy is gold standard for glaucoma surgery, even with lots of newer update in MIGS and lots of other surgeries. Trabeculectomy is gold standard, and the perfect bleb is where there is diffuse, translucent, microcystic, and relatively avascular. Now, to make that, we have to make certain adjustment during the surgery depending upon the patients and what mistakes we make. I just try to cover in next 5 to 6 minutes. Now, this is Penco's technique, and most of the glaucoma specialists have adopted or modified little bit. And Penco's technique is really revolutionary because it has reduced the complication as it improved the success of trabeculectomy. So I'm not going to talk about his technique or modification. I'll just talk about few important mistakes we make. So the first thing, pre-operative. Now, glaucoma, the surgery preparations has to be start pre-operatively. So planning, of course, counseling is important, but we have to stop anticoagulant because it increases the risk of suprachoroidal hemorrhage. Certain anti-glaucoma medication we must stop, like pilocarpine, prostaglandin, or any drug which is causing the hyperemia, because it increases the fibroblast proliferation and reduces the success rate. And I would very strongly recommend that at least start, if the patient is hyperemic on long-term anti-glaucoma medications, if eyes are red, then start low-dose topical steroid a week before to increase the success of surgery. So this is pre-operative. Now, intraoperatively, the most important thing, when we do the conjunctival dissection, you can see my blade is going more than 10 millimeter. A wide surface dissection, 10 to 15 millimeter, posteriorly, laterally, is very important because it gives the huge surface for the mitomycin application and for the diffuse flap formation. So this is one important thing. If you are not doing it, start doing it, because that will increase the success of trabeculectomy very clearly. The second mistakes we make, either we underuse or overuse mitomycin. Now, antifibrotic agents are very important in success of surgery, but certain patients may not be suitable. So if the patient is high myop, thin conjunctiva, fragile conjunctiva, maybe you should stop, not use mitomycin. On other end, if patient is on multiple medications, having very high pressure or high risk of failure, the use of antimetabolite is very important. 0.02, 0.04, I use both. But when you use mitomycin, don't use single sponge, use multiple sponge, use much away from the conjunctival edge. So your conjunctival edge should not get damaged with use of mitomycin. So away from edge, and also use subscleral application. So I make a subscleral flap and I use one sponge under the sclera also. So reduce the subscleral fibrosis. And make sure that you remove all the sponge after whatever time, 1 to 3 minutes you are doing it. Count it and wash it thoroughly. I have seen scleral necrosis because of the not removed scleral sponge, the mitomycin sponge. So you have to be very careful when you use mitomycin, remove them all. Now, the second is scleral flap. Now, the scleral flap is very important. It's the first step in making the flap. At least half to 2/3 thickness The base should be at least 4 millimeter. Of course, there are people who do a small mini trap. I'm not doing it, and I would not recommend unless you are doing a trap very routinely. A 4 millimeter base is very good. If you are making contractular 4x4 in single dissection, you can see my dissection. It is clean. If you have ragged edges, then it increases the risk of fibrosis. Now, if you are making thin and thick flap, unfortunately, I don't have, because I started recording for last 10 years and I never had, because I'm doing glaucoma surgery for more than 2 decades. But if you are having a thin flap, start dissecting at a deeper level. If you are having a thick flap, start dissecting at superficial level. Because if the flap is too thin, it increases the risk of overfiltration. If the flap is too thick, it increases the risk of underfiltration, because there will be too much of pressure and the blade failure would be high. Now, the next important thing, window. Now you can do pulse trabeculectomy. I usually do the standard, use the 11th number blade or Meringotom, or you can do the Vanas. But it should be at least 1 to 1.5 millimeter. And second most important thing is overlap. The overlap should be at least 1 to 1.5 millimeter. If the overlap is less, the risk of overfiltration is very high. That is the mistake most of the time we make. Second, if the ostium is too small in relation to your flap, the pressure the flap would exert would be high and it would lead to underfiltration. So the flap size should be in relation to the overall flap size. Closure, if you are doing too tight closure, it will lead to underfiltration. If it's too loose, overfiltration. So that is the mistake we make. It should be mild, moderate, and you can adjust. You can do, I always make paracentesis and look for the filtration. And if it's all filtering, you can always use one more releasable. So this is very important. I always use releasable because it allows me post-operatively to adjust my blade. So you can have more releasable sutures or adjustable sutures and use post-operatively their sutures to adjust your filtration. Check filtration, as I said, some people don't use paracentesis. I routinely use and check for the filtration. So it gives me the idea how many sutures I should put on table and how to adjust post-operatively. Now, post-operatively, as we are running short of the time, I'll just quickly cover the first small leak. We, in a busy practice, sometime if the AC is not shallow, we may miss small leak if we don't look carefully. So small leak has to be looked carefully. So if your pressures are low in relation to your bleb formation, consider there is a small leak. So use do the Seidel test very carefully. Look for the leak because that has to be treated in an immediate post-operative, not surgical. Sometimes you can just put the contact lens, the large diameter contact lens. So the small leak has to be leaked very carefully. Minimal choroidal effusion. Again, if you don't look diagnose early and don't treat properly, it will cascade a reaction, a complicated chain which leads to the bleb failure. So choroidal effusion need not have a shallow AC. Again, immediate post-operative is too shallow. But if your IOP is too low in relation to your bleb or AC is little shallow, look for the choroidals, because choroidals, even if you can just see the ora serrata without indentation, that also is a sign of already choroidal effusion. You have to look very carefully, diagnose the cause and treat it. So for the long-term success of trabeculectomy, these small things are very important. Early failing bleb is very important. If too much of vascularization, so even because early failing bleb may have a normal pressure. So if you don't treat, overall trabeculectomy failure would be high. So treat, diagnose, because there can be multiple reasons: internal blockage, tight or subconjunctival. Identify the treatment is very different. There's some people speaking in background. Please.
कंफ्यूजन होगा तो पूछ लेना। उसमें 10,000 रुपया लिखे थे, लेकिन 10,000 तब लगेगा जब आगे का जरूरत पड़ेगा।
Coordinator,
Dr. Mukesh sir, please unmute sir.
हो जाएगा 2,000 में ही हो जाएगा, तो फिर थोड़ा डीप जाएगा तो 5,000 लगेगा ना, 10,000 जैसा जरूरत हो।
Dr. Mukesh sir, please mute yourself sir.
Someone is murmuring.
Okay. So you have to identify the cause. I'm not going to talk about it because it's too long. And the last thing is diagnosing early sign phlebitis, because early phlebitis, if it means it can lead to the endophthalmitis also. So that there are the dreaded complications. You have to diagnose. You can see this is opaque phleb, totally avascular. This was the early phlebitis. You diagnose this early and you can save the patient's vision. So these are the things pre-operatively, intraoperatively and post-operatively. Some basic things I have tried to cover. As time is running short, thank you.
Thank you so much, sir. I would like to invite our next speaker, Dr. Shikha Gupta, to please present.
Please her introduction slide.
We were very fortunate to see her perform live on MIGS. She is a pioneer in that field, and currently she is in a professor in associate professor in RP Center AIMS. And right now she is doing a lot of work in MIGS with multiple national, international awards. And she is a co-author in many publications also, with more than 150 peer-reviewed research papers and multiple awards. So very dynamic glaucoma surgeon. Dr. Shikha, we welcome you to this midterm Jhos.
Thank you, Dr. Rashi, and I also would like to thank Dr. Bharti for inviting me for this dynamic conference, and also Jharkhand Ophthalmic Society. So I'm sharing my screen now. I have a compilation of a video of the complications on AGV.
The sound is not enabled.
Sound is not audible?
Yeah, just on the right hand side, 3 dots. Just click share sound, and you will have a drop down. Or you can stop
I
share.
can't see the 3 dots.
Can you just stop share for a minute, doctor?
Yeah.
We'll restart. And just stop share.
Therefore, it was
audible now?
Sorry, yeah, now you can again. Sorry, just click on share once. Left hand side, you should see share sound. Just click that. Ensure that it is checked. Once you do the screen share,
the capsule.
Yeah, perfect. You can start from the beginning, doctor.
In many situations, we feel that which takes away all the pleasure from both the patients and the glaucoma surgeon. These certain circumstances, they arrive uncalled for and leaves the surgeon unprepared. But once we know what all things can happen, we can be better prepared and deal with these situations to help our patients immensely. So this is the first case which had high IOPs post AGV surgery. He was a one-night patient, operated VR surgery, and we had implanted a AGV tube some time back. Despite multiple needling attempts, the IOP continued to rise after each episode of needling, and therefore it was decided that because of a thick Tenon's capsule around the plate, a capsulectomy should be performed. So we went ahead and debulked the Tenon's capsule and excised the capsule, followed by primary repair of the overlying conjunctiva and the Tenon's capsule to bring down the pressure. On table, it was found that the IOP had lowered and the conjunctiva was secured. This is the second case. This is a child who had undergone an AGV tube in the intracameral space. The patient is phakic, but it was found to touch the cornea in the postoperative period, and therefore it was decided that we will put in polypropylene anchor suture in front of the tube so that it could pull the tube back along the plane of the iris. This was the desired outcome. So 2 sterile flaps, partial thickness, they were fashioned in 10 o'clock and 2 o'clock position, and a 9-0 double-armed polypropylene suture was used to anchor the tube. So a 26 gauge needle was used to dock the polypropylene needle. For both the needles, it was repeated, and in the end, the sutures were fixed and the tube anchored behind. This was the third case. This was another lady who had undergone an AGV tube. She had operated via surgery, silicone oil globules were present, and the AGV tube was placed in the sulcus. However, post-operatively, the pressures continued to remain high and we could not visualize the tube within the sulcus, and it was seen on UBM that it was sequestered between the capsulo-iridic adhesions, and therefore a basal iridectomy was created and the tube from the sulcus was taken out in the intracameral space, and also intraocular trimming of the tube was done and it was little longer in size. So a basal iridectomy helped us to change the position of the tube from the sulcus, which was capsulated because of the iridocapsular adhesions, and bring it out in the intracameral space. This was another case which was operated via surgery and had oil blockade post-operatively. The oil meniscus globules can be seen around the tube. This is the meniscus sign which was seen, and therefore we decided to go ahead with the venting incision within the tube. So these vents have been described, which take away the oil globules and prevent the occlusion of the tube by the oil globules. However, intraoperatively, we could see that despite multiple venting incisions, the oil globule in the form of meniscus still persisted. And we thought that these venting incisions may not be enough for the IOP to get lowered. To deal with such a situation in a non-invasive manner without opening the conjunctiva, we first tried to aspirate the oil from around the tube, but that oil, because it was a silicone tube, it continued to adhere to the tube, and we could see that the oil meniscus was now in the tube and was not going to the plate. And we envisaged that this will take a long time in the post-operative period for reducing the IOP. As a result of which, we went ahead with the intracameral flushing of the tube. We took BSS, and by bending the tube a little bit within the intracameral space, we flushed around 20 ml of BSS inside the tube, and we could see that the oil meniscus was no longer seen. This was a case of AGV which had developed a tenon cyst around the tube, around the tube and the plate, leading to high IOP. So we routinely are doing needling of the AGV plate on the slit lamp, because these patients in the hypertensive phase require multiple needlings before they could settle down and IOP remains stable. So by anesthetizing the conjunctiva initially and in the swinging motion of the needle, the IOP can be brought down on the slit lamp only without taking the patient to the OR. This is the case in which we had planned to put this tube in the sulcus, and we had made an entry with the needle, 23 gauge needle, behind the partial thickness scleral flap at around 2.5 millimeter from the limbus. But as we directed the tube through this opening, it went on to settle in the pars plana space. So this was a vitrectomized eye, and this could have been the case, but however, still due to the risk of vitreous, remaining vitreous, including the tube, we wanted it to settle in the sulcus. So we took the tube out again, and through the same incision, we directed it more horizontally along the plane of the iris rather than directing it in a posterior fashion. And through the same incision, it now came to be placed within the sulcus. So sometimes, because of the tube being directed posteriorly, the same incision can actually cause misplacement of the tube, which can be easily redirected on table, and these small things should be taken care of immediately at the table. So this was a case where hardly a stump of the tube is visible. This is an operated VR surgery again, and pseudophakic eye. He had multiple episodes of high pressure post-operatively. So, but it was not, resolving with needling. So we saw that there was tube retraction due to fibrosis around the plate, leading to high pressure. So we decided to extend the tube. So this was an indigenous method. We took a cannula of the venflon, cut it from the plate, and used it as a perfect extender to the tube. We pulled the tube out intracamerally rather than that is described by opening the conjunctiva and taking out the tube and then extending the tube and repositioning it back in the intracameral space. We just pulled out the tube in the intracameral space through the limbus, put the tube extender, beveled it, cut it short, and then reposited it in the intracameral or the sulcus space, and this patient continues to have stable IOP post-operatively. The length of the tube can be titrated according to one's need, and since this was a case of tube retraction, we wanted the tube to be a little longer in length in case of future retraction, which actually is now much shorter than as depicted in the final post-operative photograph in this case. So to conclude, we can have various situations and these can be dealt in a more non-invasive manner in a better way if we know that these.
So this is about the AGV and the complications.
Thank you.
Any questions? Yeah.
I think all the glaucoma's experts must have got benefited by this. She's doing
hopefully
of the newer procedure. Dr. Rashi, Dr. Tanisha.
Definitely, ma'am. And the tube extension video was awesome. Like we have always thought how the tube could be extended, like in.
Yeah, we have sent it for publication. It's not yet published, but it is an indigenous method. Otherwise, you need to open the conjunctiva and then lengthen the tube, then reposit it. It requires a lot of conjunctival dissection. Especially we are doing these kind of cases in operated vitrectomized eyes. So there's a lot of conjunctival scarring also. So to close the conjunctiva again is also difficult. So we always aim that we do it in a more conservative manner, any re-surgeries for the operated eyes. So that is our goal.
Approach was the perfect.
And that the protruded tube and touching the cornea was also very nice management.
Thank you, ma'am.
Okay, please keep you involved in future also. Dr. Shikha, thank you so much.
Thank you so much, ma'am, for inviting me.
Thank you. You are always welcome, Shikha. So now we are proceeding to the fourth session. What is ideal, but what's practical? This is the session we are conducting first time across India. इसके पहले ये session कभी conduct नहीं हुआ है. This is a very innovative session, and this invites a lot of discussion. And Dr. Tejas Shah will be the chief coordinator of this session, along with Dr. BP Kashyap and Dr. Pritish Pranoy. The chairpersons are Dr. Sharma. Has she logged in? Dr. Bharti Sharma?
Yes, ma'am, I am there.
Okay. Dr. Ravi Dr. Bharti Sharma is chief of Tata Hospital, Cornea, and overall head of the department of ophthalmology. Dr. Ravi Barbhaya, has he joined? Dr. Ravi? I think after 2 times confirmation, if people don't join, what can I do? Nitin Dhira, he was here only. Dr. Indranath Prasad.
Yes, ma'am.
Okay. Dr. Abhishek Shadev. Dr. Abhishek Shadev.
Yes, ma'am.
Where is Dr. Abhishek Shadev?
Yeah, I'm here, ma'am.
ये roll call हो रहा है क्या?
रोल कॉल करना ही पड़ेगा ना. रोल कॉल करें नहीं. अभी करना पड़ेगा ना. चेयरपर्सन
स्कूल का याद दिला रही
है. कौन डिस्कशन में भाग लेगा? You have to participate in the discussion because this session is much more a discussion.
Yeah.
So the first, Dr. Pritish Pranoy, please take carry forward the session. Dr. Pritish Pranoy, please unmute yourself.
Good afternoon, everybody. We are about to start the much awaited session, that is what's ideal but what's practical.
Yes.
And the first speaker is our guest speaker. I'm introducing
पहला
Dr.
तो keynote address है.
Yeah.
पहला तो हमारा keynote address है by Dr. Tejas Shah.
Yes.
So please introduce Dr. Tejas Shah, Dr. Pritish Pranoy.
Yes. Is it visible?
Yes.
Yes.
It's a privilege for me to introduce Dr. Tejas Shah, who is the founder of Ahmedabad Eye Laser Hospital Private Limited and Goodbye Glasses Laser Center. He was the ex-chairman, Scientific Committee, Gujarat Ophthalmological Society, Chief Organizing Secretary of 69th AIOC in Ahmedabad, was the member Scientific Committee and the contriver of SS Surgical Skill Training Course, and was also the Honorary Secretary of Ahmedabad Ophthalmological Society. We are greatly honored to welcome you, sir. Please proceed, sir.
Thank you, Dr. Pranay.
Thank you.
Very warm afternoon. In Ahmedabad, it's quite hot. Can I share my screen, please? Is my video visible now?
Yes, sir. Please go ahead.
It's visible. Now, yeah.
Excellent. At the outset, let me thank all the Kashyap's et al. In the Jharkhand Society for any instructions for me?
Nothing. Please carry forward.
So,
Go ahead.
I'm going to talk to you about post-operative complications of phakic IOL, which means the complications which were not intraoperative. So this is a case where the toric IOL has actually rotated, a toric phakic IOL. And so this was after 4.5 years, close to 4.5 years. And so we decided not to exchange it, but give it a try of just rotating it. So the fundamental of any phakic IOL is that everything happens inside the chamber, not in the sulcus. So here we are trying to, I think this is a exchange of a phakic IOL, a toric phakic IOL, my bad, sorry for that. The next one is a rotation. So this is a hand-on-hand technique, which is very simple, and it frankly took us a lot of time to understand this procedure, but it is now a very, it's a gold standard of how to actually try and take out a phakic IOL. There are many ways you can do it. We were done with the help of a phakic IOL loading forceps, but then we found that the simple McPherson is a better option than that. And that was a very easy way of. So this is a patient where the phakic IOL is going to be rotated. This patient had a very stable phakic IOL for about 4.5 years. And so we thought, let's not exchange it. Let's try to understand why it moved. And so we wanted to actually rotate the phakic IOL back to its original position, which is what we are trying to do. Coming to the principle, like I was saying before, we need to bring the phakic IOL inside the anterior chamber, and then only we can actually maneuver any attempt of movement of this phakic IOL. So our first and primary aim would be to try and bring the haptics out of the anterior chamber into the anterior chamber, and then rotate the phakic IOL, and then again put them back in the sulcus. So this is what we are trying to achieve. This is an edited video, but what we are trying to do is we have tried to put some viscoelastic even beneath the phakic IOL to create a space so that we do not harm the crystalline lens. The most challenging part of this entire surgery is that you have to make sure that you do not end up having a cataract. Also, sometimes there might be some fibrosis. So luckily, we do not have much over here, and because should not have a fibrosis in the sulcus, but it has been reported. So it is very easy to bring it to the anterior chamber, rotate it to its position, and again bring it back to the sulcus. So here we are able to finish bringing the entire phakic IOL in the anterior chamber, and then we are trying to rotate it to the position which was intended initially. And then we will again go ahead and enclavate the haptics inside the sulcus. As you can see, this was at 180 degrees. So now we have been successful in bringing, and so we'll again let the haptics go behind the sulcus or behind the iris inside the sulcus. So if you can very easily achieve bringing the phakic coil to the antechamber, this becomes a very easy procedure. This procedure we did before some 2.5 years, and luckily this phakic coil has not rotated again. This was from the Star company. You can see that we try to maneuver everything from the side ports, because the side ports are the smaller ones, and they do not, and these are the ones which are used, and the chamber does not actually deflate. We do not want the chamber to deflate. And here you can see the viscoelastic is also coming out from the centraflow. Since there was no exchange, everything was done from the side ports. And we achieved a very reasonable, okay. So the next one is an IPCL removal. In fact, this was my first ever case. This was done probably some 10, 12 years back. If you notice, this particular patient has a dilated fixed pupil with a lot of pigments. And if you see, there was no centraflow. This patient this was the second eye of this patient. The first eye had gone very well. And the second eye, the patient had continuous vomiting and headache. And they did not report to us for 2 days, thinking that, okay, this is for something else. And unfortunately, the patient ended up like this. And this is one patient where we could do nothing. We just had to remove the phakic coil and let the patient be just a plano, and ask him to wear a contact lens, because the other eye was already okay. Now here you will see, probably you will try to identify that there is a cataract behind this phakic coil. So again, the standard procedure of bringing the phakic coil inside the antechamber. The only comfortable position in this particular surgery is that we are going to remove the cataract, and so you can be a bit complacent. Even if you touch the entry capsule, you are not going to do much harm, because as such you're going to remove that. And as you see, we were trying to struggle to bring the phakic coil inside the chamber, and then actually trying to maneuver it in a position so that we can remove it from the main port. Again, after so many years, we have now zeroed down to this particular technique of trying to grab the phakic coil with the help of a McPherson and use 2 hands and keep on pulling and pushing out. And this really works well. If you can see the second hand, it pulls a bit, then again we try and do it with the second. The advantage of this phakic coils are that it's so malleable that it can very easily be taken out from a 2.8 millimeter incision. But again, the pupil usually goes down. At this point of time, you can phenocaine or something and try and get the pupil to its normal, not to its original size, but you can definitely try and get a big one. And then it was again a routine surgery. You can see we were implanting a 3-piece IOL because this was probably an expand series. The power of this phakic coil was, I think, -4 or something. And these are no longer, they are not available in single piece IOLs. So we went ahead with the 3-piece intraocular lens. This was probably a very traumatic surgery. We also brought a lot of iris to the wound, and you can see while after implanting the IOL, we had to actually suture the wound. It's very important to go beneath the IOL also and remove all the viscoelastic. And as you can appreciate, a lot of iris was shaved, but well, this was not actually a situation which we wanted to be very happy with. So these are the few surgeries which I would like to share with you.
Please mute your audios. Please mute your audios.
सब लेके बैठे हो, अभी गया नहीं है, एक ही साथ आएगा।
Mukesh, Mute your audio.
Yes, sir.
Mukesh,
Oh, sorry.
please mute your audio.
Great. Any questions for me or should we move ahead?
Dr. Tejas, may I ask you a question? Dr. Kashyap here.
Yes, please. Dr. Kashyap.
First question is, how are you, sir?
I'm doing fine.
The second question is, one of your toric IOL moved.
Yes.
Let's say after 4 years or so.
Yes.
Did you try to find out the cause? Why did it happen?
No, frankly, no. Frankly, no.
So
If
if
it
one
rotates,
IOL can rotate after 4 years and you are rotating the same IOL into the original position, sir, it will rotate again? The logic says so?
That's what I mentioned. That we thought that since it was stable for about 4.5 years, let's give it a try, just rotate and pray to God. And if it doesn't rotate again, we'll not exchange it. But it has not yet rotated. This has been now more than 2 years follow, and it has not rotated. There are so many reasons for this kind of a rotation. This was a late rotation, not something which happened in the first month or 6 months. And the patient was very happy. This was also a very odd, about 6.5 diopters. So we thought rather than spending on a new phakical, this was a star ICL. Let's try and rotate it. It's easier than explanting and then reimplanting. And we have till now succeeded. And that's the reason I shared this particular video here.
So my question is, logically, if the lens has rotated, doesn't matter after 1 year or 4 years, so it will rotate again. Because the science says that there is something wrong somewhere. That's why it has rotated. Probably a smaller size of the IOL. So I think it should have been explanted and you should have put in the new IOL.
Ideally, it should have been explanted, but practically, I thought this is a very simple 5 minutes procedure. Let me give the patient a benefit of doubt. It could be many reasons that we have not understood. And so let me just go ahead and implant the same phakic IOL. And God forbid, it has not yet moved. So my decision of not explanting, I'll tell you what, sir, whatever you do, explanting a phakic IOL is always a very traumatic procedure. And then reimplanting it again. The iris definitely goes down, and there's a lot of iris pigment dispersion also. So we thought, let's do the easy way. And for me, this was the practical way.
Sir, I have a question.
It is very valid.
Tejas sir, good afternoon. I have a question, sir. Sir, you showed that case wherein there was no central flow and the IOP got high and the patient was vomiting for 2 days. I recently had a case like now I'm implanting IPCLs which have central flow, but still the patient probably ended up with a high IOP because the patient was vomiting for about 1.5 to 2 hours. And I gave Diamox and all, and everything settled. I didn't have the courage to.
Vivek, let me interrupt you. Sorry, I really want to make this point across to everybody. Diamox does not work. It has to be a vitreous shrinking agent. You have to either use a mannitol or you have to use a glycerol. Diamox, rather, what happens is Diamox decreases the aqueous material. There is a viscoelastic trap. By giving Diamox, you're decreasing the flow. So I was going to come to that. This patient was about 12 years. This was one of the very initial IPCLs. Sorry to interrupt your thought process, Vivek, but I really wanted to drive across this point. And so now onwards, we have stopped asking the patient to leave immediately. We see the patient 1 hour inside after the procedure. If we feel that there is no rise of pressure, we allow the patient to go and tell them that if you have the slightest pain, come back or go to a GP and get a mannitol. Or we have done it once or twice. We felt that we were not very happy with the viscoelastic removal. We went ahead and gave a mannitol. A mannitol shrinks and you will see the effect in 20 minutes. So please no Diamox in phakic IOLs. That was the message which I wanted to give you. Sorry, please go ahead.
Very good message.
Do you use the Carpinol after implanting IPCLs at the end of the case?
Sometimes no longer. I no longer use. Now we have experience of about 15 years. So Carpinol, we have done it. There are certain high myopes. in whom you do not see any pupil. The iris is like from limbus to limbus. So in this kind of patients, we try to give carcinol, but just try to, because we don't want to irritate the iris, we can definitely just touch the iris and it will constrict, and no longer use any cyclopentolate. If you use cyclopentolate, then the iris does not constrict. So with the tropicacin plus, our iris is very easily slightly constrict the moment the phakic IOL haptic touches the iris. It's bound to touch the iris, correct? So we have stopped using carpinol. Carpinol is contraindicated in high myopes. Dr. Kashyap will definitely validate that point.
Sir. Vivek, I have a point here. If I suspect that even after all the taking measurement and all that, if the overall diameter of the lens is probably, if you have chosen more, like say white to white diameter, if you have not taken properly and is little on the higher side, in that case you must, if there is any doubt, in that cases only I put a pilocarpine and see whether the pupil constricts or not. If the pupil constrict properly, it means that it is a good size. If the pupil does not constrict even after pilocarpine, take it from me that the IOL, the overall diameter is very high. It's bigger.
Very, very practical point, Dr. Kashyap.
Yes.
Excellent. Thanks for bringing it out. That's so important. The moment the iris does not go over the vault of the phakic, that means something is wrong. Absolutely. Excellent point.
But what do we do at that point? If we find that on the table?
No, you're not going to do anything on the table because there are so many things which you have not understood. Previously, the phakic coils used to self-adjust in a day. At that time, they used to come in normal saline. Now they come in BSS. So they say that whatever you see on the table is going to be there on the next day. But you still have to wait for a day or so and then take a decision to explant based only on the sign of iris not covering the phakic coil, the pupil not going down on the phakic coil. I would not go ahead and explant. I would just still wait for an hour, for 24 hours.
I'll beg to differ here in one sense that if the pupil is not constricting, I feel that the lens on the higher side and the patient is likely to develop glaucoma, I then and there do the peripheral buttonhole iridectomy.
But if the vault is high, the iridectomy is not going to be of help, Dr. Kashyap. Then you need a phakic coil of a lesser or a smaller diameter, which obviously you will not have in your operating room. See, they gave you two phakic coils, but they're of the same size. Now, if the vault is high, that means that the phakic coil is longer, right? So you need a 0.3 less vault or a length of the phakic coil, which you are obviously not going to have it. So what you can do is you can tell the company that I feel that the vault was high and I would need a replacement tomorrow or day after tomorrow, which will be 0.3 or 0.5 because you have to actually measure the vault. If the vault is 1000 microns, then you might even have to decrease it by 2 sizes. More than 1000 micron, then you might have to decrease by 2 sizes. That's why we should wait because we cannot defer and take a decision on the table. We need to actually see after the phakic coil has stabilized and see the vault. If the vault is about 700, 800, you can still wait, depending on the AC depth.
So, sir, even if you do a peripheral buttonhole iridectomy, even if the vault is high, so you are taking a chance and it can work. It works in my cases. So, if the PBHI is done earlier, if you want to exchange the lens, there's no problem. That's no problem. But at least you are giving it a chance and it may work, and it works.
Next time, I think I'll give it a try. Excellent idea.
Sure.
So I have a question. Can I say?
Request the chairpersons to join. Dr. Ravi Daulat Barbhaya, Dr. Nitin Dhira, Dr. Indranath Prasad, Abhishek Shahdev is here.
Abhishek, go ahead.
Very smart, young surgeon.
I have a question.
Is heading the Shrestha Eye Hospital. Is the cataract consultant.
Sir, actually, can I speak something? Can you hear me?
Dr. Abhishek, are you talking to me, correct?
Yeah. Can you hear me, sir?
Please go ahead. Please go ahead.
Okay. Actually, I just want to ask you, sir, can you combine this surgery with ARS or you go for the IPCL or ICL? Like,
No, I could not get your point. Combine the surgery?
yeah, the surgery with ARS. ARS is a adjustable refractive surgery. Like we do a LASIK before IPCL or ICL.
Well, frankly, the companies do not like me because I have stopped using phakic IOLs. Toric phakic IOL, sorry. See, we are a one-stop solution, so we have an examiner inside our OTC. So what we do is we always make a flap, and we have stopped using toric IOLs. We save about 25,000 rupees because each toric phakic IOL costs about 12,000 rupees more. We make a flap, go ahead and put a monofocal, a non-toric phakic implant, and believe me, 70% of our toric patients do not even turn up to come back for removing the cylinder which was there. They are so happy with just the monofocal toric. So the toric IOL problems of rotation, trying to rely upon the company for their calculations, everything is gone. And what we do is we also aim for about minus 0.75, minus 1 lesser correction, so that it becomes very easy to go ahead and do the examiner ablation on the top of the cornea. We do it every time.
Yes, that was the point actually. Making a flap is a good one option actually. Instead of
Yes.
having whatever, yeah.
Make the flap, do not even lift it.
Yes.
I just did it yesterday only.
Yes. Thank you.
It saves money and you become very accurate. You're not going to rely only on the company for the calculations. I'll share with you one of these Indian companies. Instead of right eye, they label the left phakic IOL toric and they gave it. Imagine the surgeon. The surgeon did 2 surgeries simultaneous and both of them were swapped. And imagine the surgeon. Left was right and right was left. If it is a non-toric, it doesn't matter. Excellent. Thank you for bringing that out. I do not want to speak because the companies do not like me.
Dr. Pritish,
Yeah.
please take forward the session.
Yeah, the next speaker is Dr. Upsam Goyal. Are you there, sir?
Dr. Upsam Goyal?
Yeah, he's there. He's there.
Dr. Upsam?
Yes, ma'am. How are you?
I am fine. So your topic is ideally a video consent has to be taken from a patient, preferably before the day of surgery. And is it practical? So before that, please introduce Dr. Upsam Goyal.
It's a privilege and honor to me to introduce Dr. Upsam Goyal, who did his MS Ophthalmology from King Jhos Medical College, Lucknow in the year 1990, and his fellowship in the Medical Research Foundation, Chennai, 1992. Presently, he is practicing as PCI Center in Lucknow. He has immense work experience, personally performed over 30,000 anterior and posterior segment surgeries, among the pioneers of 27 gauge vitrectomy in India since 2013. He is the pioneer in the field of digital imaging also. First in India to introduce the high resolution digital 3D angiography, designed a high resolution flashlight light slit lamp photograph system for ophthalmology, developed new visual acuity contrast sensitive charts, and developed new air insufflator also. Now I call upon Dr. Upsam to just proceed with the slides and do the honor.
Thank you so much, sir. And thank you, Dr. Bharti. I think now my internet was very unstable. And it's very nice. Hi, Dr. Dolly, Dr. Medha also there, all from Shankar Netralaya. So it's nice
So
to
you have a big gang of
yeah, yes, so my slides are very limited. I just switch off my.
I know it's a lot of discussion point.
And I would just like to add, all the participants who are not yet a member of this WhatsApp group, you can please message me and I will add you to the group. We are now 1,500 strong.
1,500?
That's fantastic. Okay. So I've been heading the IMA, local IMA as the legal, as the head of the legal cell also. And this is one thing I've been telling doctors. that all these rules and regulations that are piling up against you are only because you're not united. If you are united, the only rule, the only law that any country follows is the law of who's got the maximum number of dandas in his hands, to be honest with you. All rules, all regulations have been changed in not only India, all over the world, depending on what people have demanded. So that is one thing. If doctors remain, united, then the rules will start coming in your favor. And the moment you are disunited, this is what happens. But anyway, so moving on to what is, I hope you can see my slides.
Yes, sir.
Now, the question is, a video consent has to be taken from the patient before the day of surgery. That is an ideal situation which people are talking about. Now, what does the law want? I mean, let's try to understand that basically. That what does the law want? The law wants that whatever system is there should be transparent, right? There should be a lack of ambiguity, and there should be a sense of fair play, which is fair for everybody. If I want to buy something from the market, or if I want to get any service from the market, then this is fair. I mean, I have so many of my patients who are the politicians or judges or people in the judiciary, the lawyers, senior lawyers, as well as people in the police. And I always tell them, look, sir, this decision of putting healthcare as a consumer thing is one of the worst decisions ever. And believe me, 90% of the judges agree that yes, that is true, because there's so much of litigation going on, so much of this going on. But they typically say, Doctor, because the fact remains that everybody does not practice in what is expected out of the integrity of the profession. So that is why the law comes in. Now, the legal system is such that 90% litigations occur because after the front end staff, your front end staff is the person who has mismanaged something or the patient is unhappy. The next thing that happens is most patients, if they are unhappy, what they're looking for is some kind of a financial benefit out of it. That's it. I mean, we have been practicing for more than 30 years now. Until now, only, I think one, not even two. Yes. One patient came to me and started threatening me. The DG police was sitting next.
This place so beautiful. The actual part.
I think there is people who have got their mics on. Can I request everyone else to switch off the mics unless they are speakers? So Sayanti, I think your mic is on. Okay, thank you. So, and that was it. Dr. Sayanti, are you listening, please? Your mic is on. Can somebody please mute the mic of speakers who are not participating?
The support team, you please be very alert.
Entered coordinator, please mute her mic. Entered coordinator, please mute her mic. Yeah, thank you.
Thank you so much. So basically, what was happening? So now this is threatening. Now, why was he threatening? Because he thought that we had done a surgery which was an expensive surgery which he couldn't afford. We went to the cops. We told them that this is the matter. They just gave him a call and said, "Look, you want something wrong? You go to the court." In 33 years of practice, there has been only single litigation, and that also on frivolous grounds. And the patient wanted to extract something out of us. We did not yield. We went to the court, and that matter is closed. Why? Because at the end of the day, if you are taking out time for the patient, I'm telling you, that time you save is much, much better. ये जितने rules है ना कि आपको पहले video consent लेनी है, नहीं लेनी है, rules, put the rules aside. Just put yourself in the shoe of the patient. I've myself been to doctors. हाँ बस एक इंट्राविट्रल इंजेक्शन लगा देंगे तुम्हारी डायबिटिक रेटिनोपैथी के लिए. That is it. That is the end of the statement. But damn it, you have to tell the patient that he will require multiple injections. So that is how you do it. For example, in our own sheets, what you've done for diabetic retinopathy, for glaucoma, and now you're doing even for cataract is, there's a diabetic workup sheet. Uske niche do QR codes hai. Now there are two lectures. One is one lecture which I've recorded and put on YouTube, and another is a discussion between, जैसे हम लोग का discussion हो रहा है, there's a discussion between 5 of us. Ajay Rao is there, Dr. Dinesh Talwar is there, Dr. Lalit is there, I'm there, and we put it on YouTube. And I tell the patient कि आप please इस link को, इस video को देख लो, समझ लो. After that, if you have more questions, please come back to us.
And if you tell me you have not seen the video, I'm not going to start treating you. You know, one patient came to, I don't have time to see these videos. I said, then sorry, I don't have time to treat you. Go to somebody else. That is it. If the patient has a clear, transparent idea of what is happening to him, it is good. And आप लोग जितने experienced doctors हो, you can all make out that yes, this patient is somebody who has not understood your instructions. Abhi, there's one patient, I told him, you got a macular scar, sir, you will not improve by cataract surgery. So he says, finally came to me, Doctor Sahab, इस बार surgery कर ही दो. I said, okay. But then I made him write on the form that I have been told very clearly that my vision may not improve after surgery. So next day, his son comes along. He Doctor Sahab, ये क्या लिखा है? I said, this is what I want to tell you. Third day, the patient himself came along. Again, he said, Doctor Sahab, in that case, let me not get operated just not. I said, yes, that's what I'm trying to tell you. So that is what I'm trying to say. So, अगर आप video लो, या written consent लो, whatever you do, as long as it is clear and transparent what you're trying to get to the patient, I'm telling you, be your patient's friend. Forget about I was running 3 groups of Harris Doctors United, and I'm telling you, we are getting frustrated with our own patients, despite the fact that our patients are being nice to us. Of course, it happens, especially the critical, heart patients, जो critical care में होते हैं. It is true that these patients can create ruckus, especially if the patient dies or something. I'm operating another patient on Monday, high risk critical case, diabetic, hypertensive, cardiac events. So I told the doctor, I said, look, these are the risk factors. And if you want, I will also call the anesthetist. And I told her, I said, it cost me $5,000 to get the anesthetist, but I'm going to pay for him from my pocket because it doesn't matter to me. I want the safety of the patient. So that is the kind of a thing. If you are there, so if there is a transfer, now, if the matter goes to the court of law ये पूछता है कि transparency थी कि नहीं? Were you transparent enough in your dealings or not? Now, one of the judges of the Consumer Protection Forum of the entire state is a good friend of mine now. He told me, Doctor Saab, आपके paper पे आप ये लिख दो, advice second expert opinion. And the moment I said that, then Justice Roy, another sitting judge of the Lucknow High Court, I operated on his father. And when for some reason, I wrote that, he said, Doctor Saab, this what you have written is a wonderful thing. Because if such a paper goes to us in the court of law, we say, okay, this doctor did not say out of greed, mere se ilaj karao. This doctor said that you can go and you can get treated by anybody ever. I mean, get a second opinion by an expert. So that is the kind of a transfer. Lack of ambiguity, that is another thing. Bhai, kya hona hai? I mean, so many patients come to us. My God, वो एक दो इंजेक्शन लगा के हमारे पास आते हैं कि डॉक्टर साहब उन्होंने तो कहा था इंजेक्शन लगाना, आप तो कह रहे हैं अब कह रहे हैं कि और इंजेक्शन लगेगा. Oh my God, why was not that told beforehand? वो लेजर कर दिया डॉक्टर साहब उन्होंने, आप कह रहे हैं और लेजर होना है. Why was not that told beforehand? So all that information is contained in the lecture, which the patient has to listen. And then at least I tell you, please sit down with me, and I will spend as much time as you want before we start your presentation. That is the thing. Sense of fair play. That is something I think we all must have it, and all senior doctors. Let me tell you, the most successful doctors I have seen, they all have a sense of fair play. If you feel कि नहीं यार इस patient के साथ जाती हो रही है, चाहे हमारी गलती थी, चाहे उसकी गलती थी, but he is suffering because of something. There's no harm. You can treat the patient. Yeah, you can even treat for free if it comes to that. You can do that. So once you have a sense of fair play in action, in place, then I'm telling you, you will be saved from a lot of problems. Documentation is good for everybody. NABH है हम लोगों का, जितनी चीजें ये क्या कहती है, सिर्फ डॉक्यूमेंटेशन ही तो मांगती है कि भाई डॉक्यूमेंटेशन दिखाओ कि तुमने ऑटोक्लेव किया तो वो दिखाओ, उसके अंदर सारा का सारा डॉक्यूमेंटेशन है कि नहीं. So whether it is just a video consent or not, it doesn't matter. Your own documentation should be there. आपने लेंस लगाया, अभी one very senior, very leading center, वहां से patient आया, उसका टॉरिक करता 56,000 की सर्जरी हुई है, and there is no mention of what IOL has been used. You know, this is the kind of a thing that is not done. So documentation should be there. That is good for everybody. Documentation and reasonable documentation. Again, I'm trying to. If you feel, if however you feel that this patient is a very high risk patient, or this patient is something जिसके दिमाग में कुछ नहीं गुजरा, आप वीडियो कंसेंट जरूर लो. Take a video consent. And in fact, we have 2 international trials for which is also going on in our center. There it is mandatory to have a video consent, and the whole thing is recorded. So that is the kind of a thing which is my basic advice. Basically, all common sense things. Use your sense, be fair, and put yourself in the patient. You don't put yourself in your shoes. That is all I'm saying. And like I mentioned, in our own sheet for diabetic retinopathy and glaucoma, we have so similarly glaucoma sheet में there is a glaucoma lecture, which our consultant has recorded. It is on record. So even if it goes to court of law, he will say कि साहब हमने इसको बोला हुआ है और ये है, and this is there. So you cannot change what is there on the YouTube, and therefore this is what we are going to follow. So thank you so much. It was nice being with everyone. And if any question, discussion, we will have to answer.
So you mean to say that what situation when the patient is looking very uncooperative, we should take a video consent, or if we are getting them sign the documents,
Yes, ma'am.
sufficient?
No, ma'am. What I'm saying is, it's not a matter of cooperation. What I'm saying is that if you feel that this patient is not really understanding your what you're trying to tell him, maybe because of lack of education, and there are those patients. You've answered one question, the second question is ready before you finish your first answer.
Yes.
ऐसे patient को मैं डांट भी लगा देता हूँ. I said, shut up and listen to what I'm trying to tell you, because what I'm trying to tell you is important. Tomorrow you will ask me the same question all over again. अब फिर मैं कहता हूँ लिख के दो मेरे को कि तुमने सब कुछ समझ लिया है कि नहीं.
वो तो सही है. वो तो सही है. NABH also requires a lot of documentation. Even those hospitals who have done their pre-assessment thing, they also have a lot of documentation. So
yes,
video consent thing is a new thing to us.
Video consent can be taken for high-risk patients where there is either a high risk to the eye or to the life. Definitely, I think we can do that.
So you show the patients your counseling videos?
Yes, ma'am. So there are again got recorded videos on YouTube. One is my own lecture, a 7-minute on diabetic retinopathy. The other is this 5 people interactive thing, which is about a 30-minute lecture. Then Dr. Alma has got her own one, which is on glaucoma. And similarly, now Dr. Shabir will be preparing her own talk on surgical glaucoma.
But I also do the same thing, but then many people in our same fraternity, even in my hospital, they criticize this. The counseling video should not be shown like this. I have this habit too of showing counseling videos, my own video.
No, ma'am. These videos which I'm talking about are not counseling videos. They are videos about the facts of the.
Yes, yeah, that's what I'm saying about the facts.
Example, now, a lot of these patients, post-surgery patients, they come with floaters. Most common complaint, and they will eat your head about it. So what we did was, हमने अपने consent form, I mean the pre of instruction form है, उसकी में लिखा दिया कि कई मरीजों को ऑपरेशन से पहले और ऑपरेशन के बाद मकड़े और जाले से देखता प्रतीत हो रहा है, ये सामान्य लक्षण है जिसके लिए अनावश्यक परेशान ना हो. Now imagine that is there on my pre-op, that is there on my post-op. So the moment the patient says, I pull out, I said, देखो ये लिखा है ना, and मेरा काउंसलर भी पहले से point out कर देता है. I have been able to save the skin of not only myself, but on several of my colleagues also. जिनके यहाँ से patients came back, साहब बड़े फ्लोटर है, पहले नहीं बताया, मैंने कहा जी सामान्य लक्षण है, and it is so common कि हमने इसको छपवा कर दिया इसके ऊपर. That is the thing. Again, documentation, transparency.
Yes, to me also it sounds good if the facts you are explaining, and if one patient starts taking 15 minutes, 30 minutes extra,
yes, ma'am.
You are saving time.
Yes,
exactly. Excuse me.
Dr. Kashyap, just one more thing, and another thing, in your cataract thing, you should always mention कि मोतियाबिंद के ऑपरेशन के बाद भी चश्मे की आवश्यकता पड़ती है. Even if it's a goddamn EDOF lens, it doesn't matter if there's a trifocal, that focal lens, I don't care.
Yes, even if it is
that
EDOF,
should be there.
Let's consider video consent only right now. I believe, because otherwise this will go on till evening. Yeah. So at the end of some 2 or 3 days of deliberation, the group not actually concluded, but they decided that the court does not want a video consent. They want a physical document. So that was one inference we had after 2 or 3 days of deliberation between 1,000 members. The second was that yes, you can take a video consent, but then nobody is sure how long and how many terabytes you would actually require to store, and that also can get corrupted. But the best way of doing it is a physical signed document. And we also were funnily, jokingly talking that just keep a video camera and point towards the video camera. And even if you do not record it, the patient feels very, very comfortable. Okay, something has been done, and they don't go ahead and do much about it. But ideally, it's a lot of responsibility to keep that video consent. And so it was decided that at this moment of time, we do not require a video consent. It is a luxury. If you can afford and if you want to do it, do it. Because everything before surgery is counseling. Everything after surgery is negligence. Whatever happens, that's what. Thank you.
So
Thank
I
you,
think we
Dr.
should proceed. Go ahead, and Pritish Pranoy, please take the session forward.
Now the
Ideally, we should have a three-piece
Now-
IO backup for every cataract surgery, and practically is it? So our own speaker, Jhos, Dr. Vivek is there. He's a very prolific cataract and refractive surgeon, and from Jamshedpur, and he was the very good organizing secretary.
Thank you, ma'am.
Annual conference of Jhos.
Thank you.
And I see a lot of potential in Dr. Vivek Kedia.
At the outset, I'd like to thank Jhos and the whole Jhos committee, especially our CSC, Dr. Bharti ma'am, and our secretary, Dr. Mitra Boss, for giving me this opportunity to speak in this esteemed forum. I'll just share my screen. Is my screen visible?
Yes.
Yeah. Just a sec. So I'll be speaking on multi-piece IOLs. Ideally, it should be there for every cataract surgery. We all should have that as a backup. But is it actually practical to have that? So I have no financial interest in any of the products. We all have been using PCIOLs for cataract surgery. We know there are single-piece PCIOLs made of acrylic or multi-piece PCIOLs with acrylic optic and PMMA haptics. The single piece is semi-rigid, has semi-rigid acrylic haptic, and it can be easily implanted through a small 2.2 or 2.4 mm incision. And there, the haptics are bendable. But since these haptics are thick, they are not recommended to be put in the sulcus. But there can be certain conditions wherein you are stuck during the surgery, like if you have a runoff of the capsular excess, then you have to convert to a can opener, or say you have an Argentinian flag sign in a white hypermature cataract, or if it's a huge brown cataract and you have to make a rhexis which is much bigger than the optic size, or in the worst case scenario, in cases of PCR. So these are the common conditions that we all encounter, and we just pray that if only we had a three-piece IOL to save our day at such situations during the surgery. So before we had a three-piece IOL, there were PMMA IOLs which can be implanted in the sulcus in case you don't have a three-piece IOL and if the capsular excess margin is intact. But again, this requires you converting from phaco to a SICS incision and increasing the size of the incision, and that defeats the whole purpose. And other than that, if say that the whole bag is lost or there is not adequate zonular support to put an IOL in the sulcus, we had the options of putting AC IOL or iris claw lenses in the anterior chamber. Then came PMMA scleral fixation IOLs that again can be implanted in the sulcus. But then the three-piece IOLs were actually a savior. These thin haptics, which are made of PMMA or polypropylene, they can be implanted either in the capsular bag or in the sulcus, and they can also be sutured to the iris or sutured or glued to the sclera. So these were the saviors in most of the complications of cataract surgeries, and that was the purpose for which they were mostly reserved. But so when you have a PC rupture with say there's an ideal capsular excess, so you can implant these three-piece IOLs with an optic capture wherein the haptics are placed in the sulcus and the optic goes behind the capsular excess margin. So you get these oval shaped of the anterior capsular excess, and that stabilizes the three-piece optic in the center of the eye. You can again use these same three-piece IOLs for scleral fixation or for glued IOL surgeries. But knowing all this also, if you are a good surgeon and you rarely have complications, so you feel that I really don't need this backup, because it's not always easy to have the backup of these lenses. So certain times it happens, like I had this wake-up call, and the wake-up call was this surgery, which was of someone very close to me, probably one of the most important persons in my life. And I didn't want to operate upon her, but then she was adamant that you have to do it. The surgery was going absolutely fine. And I had this small piece of cortex stuck on the endothelium. And I thought that, okay, I'll remove it later on. The cortex came off well. Since this was a VVIP patient for me, I thought, okay, I'll polish the PC. And right at that moment, I felt that, oops, something has gone wrong. So there was a PCR in this case, and I had actually planned a multifocal lens to be implanted in this case, and I didn't have a three-piece backup. So I was in a soup. I did vitrectomy, and I went ahead with the same multifocal lens. Now the idea was that to implant this in the sulcus, and I have seen one of my gurus do this procedure, and I just took that confidence from there and I implanted it in the sulcus. The haptics were in the sulcus, and the optics of this panoptics lens was actually tucked behind the capsular six margin. And I did an optic capture with this panoptics lens. And thankfully, the case went on well. And my mother ended up with just a 0.5 cylinder at 90 degree. Post surgery, she is 6'6" N6 and extremely happy with her vision. So, but this was the surgery that told me that I ideally do need a backup of a multi-piece lenses. And then after a series of negotiations with certain companies, and this was my standard, the common lenses that I use, and this didn't have a multi-piece backup. But then after negotiations with a company, the whole library of multi-piece lenses appeared, and now I have more peace of mind, and I do my surgeries with much more confidence. So the idea is that it's ideally you should have a multi-piece backup, but certain companies don't give you library. They'll ask you to purchase the lenses, at least the common adapters, and then put that in stock. So you are kind of stuck with that stock unless you use it on a regular basis for your regular cases also. So that is one way of moving the three-piece library if you have, or if you can negotiate with the companies to provide you a library, and on the use basis, if they can charge you for the lenses, then it becomes quite comfortable for you, and you have that peace of mind for every surgery that you take up in your OT. Thank you.
Very nice presentation, Dr. Jhos.
Very nice. It has happened with us also.
Yeah, so I think we also keep some lenses here, but we mostly decide pre-operatively. Depends upon the case. If the case is tough, where we expect some zonular loss, or we very hard cataract, we expect that the cataract can there we do always keep a backup on the lens. So,
But we also have backups, but then if you have planned panoptics, VVT, so in such cases, the patient expectation is very high. And if you, tremendous vitreous disturbance has not taken place, you can do with the minimal vitrectomy and the optic capture. So you should go the way Dr. Vivekedia sailed through, because in our hospital also many cases are managed like that.
I want to make one point very clear, that we are over promising. Please stop doing that. Anything
Absolutely.
can happen at any point of time and at any stage of the surgery. Even if you have implanted the lens, that is gone inside the bag, and the moment you come back for IA, you see that there is the PCR. I mean the
Very true. Very
so let us not over promise to the patients.
one another comment, we not only keep the 3-piece library, but we are also taking a printout of the 3-piece IOL to be implanted in the circus. That power is also standby with us. So in all the cases, we have always a standby. What power has to be implanted for 3-piece if be required for the circus?
Sir, what difference do you encounter in such readings like for sulcus? Is there a much difference, or if we have
Yeah, of
the
course, there is a much difference because the different IOLs has a different A constant. So suppose your
Okay.
IQ lens is 119.1 and then the 3-piece has a very different 118.2. So
Yes,
huge
sir.
difference will be there. And the placement is also has a difference.
What power will come for in the bag implantation? Try to reduce 0.5. That is justified with that particular A
That is
constant.
not all for the all cases. Depends upon the power also. For the myopia,
Yeah. For that particular
power will
lens,
be
A
huge
constant.
difference between both of them. If it is in the circus.
Correct.
So frankly, this situation can be actually divided into pre-operative and post-operatively. Many times it so happens that we have a polar cataract, or we already know that something has gone wrong. And in those cases, we are very vigilant. We have vitrectomy team ready, everything is ready. And in that case, we can also have a 3-piece IOL ready. These days, keeping a library of 3-piece IOLs is slightly difficult because of the GST issues. Once they are out of their hospital, they have to pay the GST. And we have become very good surgeons. So the reason or the need for a 3-piece IOL has also started decreasing. In fact, I do not even remember when I had an emergency or an urgent need of a 3-piece IOL. But then if it is a position which is envisaged that, okay, something is going to happen, you can always go ahead and plan and keep a few 3-piece IOLs. But then there is also one school of thought that if the situation has gone wrong and it has gone very badly wrong, and if you're not very confident, it is very, very, very important that if a person has been all the life implanting a single piece IOL, which goes through a shooter, whenever you try to implant a 3-piece IOL, it goes through a screwing kind of a injector. And they are not always very, very controllable. You can always sit back, close the wound, go ahead and try to implant the IOL in the very next sitting. There are people who also believe to do like this also. Just my few thoughts which I shared.
I think just make a point that multifocal and trifocal IOL, whatever we are thinking, they are a little bit of forgiving actually. It's not that trifocal is best or multifocal is best in these situations. And we have to discard that. But I think the trifocal IOL can be implanted in a little bit of compromised capsular position also.
Dr. Sanwari, then your mic is on, please. You switch it off.
Next session, Dr. Pritesh, next speaker.
Now we can move to the new next speaker, our own speaker, Dr. Alini Anuradha. Her paper is on ideally we should only do applanation tonometry for all patients. Practical, is it? Dr. Alini, are you there? Please
Hi,
share.
good afternoon, Dr. Pritesh. Thank you very much for giving this opportunity.
Let me first introduce Dr. Anindya Anuradha. Dr. Anindya Anuradha is a prolific glaucoma and cataract surgeon. And one thing I appreciate about her that she, like Dr. Archana, she strikes balance in academics and the clinics. She's not totally lost in academics. She's neither she's lost in academics nor she's lost in clinics. She's in between. So, and she's a young, very hardworking lady, and she runs the ophthalmology department of Medica single-handedly. So, welcome on board, Dr. Anindya.
Thank you, ma'am. Thank you very much for giving this opportunity. I'm going to share my slide. Just let me know if it is shared properly. Is it visible now?
Yes, yes.
Yes. So, yeah. Thank you very much. Okay, so already, ma'am, thank you for giving this such a humble introduction. So today I'm going to present on ideally we should only do applanation tonometry for all patients and how practical it is. So I don't have to prove like, applanation tonometer is the gold standard. It is already, in the literature that we don't have to debate about. And let me clarify that I'm not going to talk about applanation tonometer when it is contraindicated, like it is a contact procedure, so it cannot be done in an infective case, or if the eyeball is ruptured, or there is an open globe injury, and so also if the cornea is already scarred where it is going to give a false reading. So in that case also we are not going to discuss as that part. So now my discussion is going to be restricted only where applanation can work, it has the possibility to work. Okay, so why should, and if even if it is gold standard, then why should we want to avoid something gold standard? Sometimes we say patient cannot sit or not cooperative. However, for that thing, we have Perkins applanation tonometer. The method, the theory behind Perkins is also applanation. So it actually does not give anything different. So it is again a applanation tonometer. We should not consider it is something different. So whenever patient is not cooperative, we can go for G. If the examination is done under GA, our Perkins should be ready. And if we are not planning for GA, mild sedation we can also use for Perkins applanation tonometer. So now comes to, there are some cases, it's not about sitting position. It is not, that cooperative when we cannot change. Actually, patient can be motivated with proper counseling also. However, we again think about it is going to be time consuming. So there is the point, it comes to delegation. So what is delegation? Because right now, we are in Jhos podium. Dr. Bharti Kashyap ma'am is there. So everybody knows Bharti Kashyap ma'am can do best in everything. However, she also understands that she cannot be everywhere. So that is why the team is there. So this is delegation. So leadership is in decentralization of work, but centralization of responsibility. In delegation, the ultimate responsibility and control still remain with delegator. So if anything will go wrong in Jhos, so obviously Bharti ma'am will come forward and take the responsibility. So this is delegation. Okay, so how are we going to use this delegation in how to do it, use it in IOP measurement? Our all vision technician, ophthalmic assistant, optometrist should be trained for applanation tonometer and following concept, like correct method of the procedure, possible errors, possible cause of corneal abrasion, theory behind it. Just think you will be giving your, ATM card to your kid without telling, how to take care for the money and when to use and when not to use. So what will happen? So like that, if we are going to train our assistants regarding the applanation tonometer, we must train them the must needed theory behind it also. So what I can say, to the end, that clarity is power. Okay. So, but on the other hand, I have to clear that trust should not be blind. So random repeat check is a better choice, and it should be, and the people can have, some other instruments with them, like that can be combined with applanation tonometer, like applanation with non-contact, applanation with rebound, applanation with tonopen. If suppose they will find, there is a variation, they can definitely go for repeat check. They can ask you for recheck. So this repeat check, see, most of the time, if the assistant is good enough in checking with applanation tonometer, you most of the time see the patient dilated. Even if the patient is dilated, you are rechecking the pressure. The pressure difference should not be more than 5, 1-2 difference is okay. After dilatation, it will definitely happen. But if it is going to 5, then either you are doing it wrong, or your assistant is doing it wrong, or your instrument itself is not calibrated, or the assistant instrument is not calibrated, or you have missed in gonioscopy that the patient needed PI and you missed it, or the PI is already patent. After that, the IOP is, if it is rising, it can be a plateau iris syndrome that you have missed. So, with the rechecking habit, you not only confirm your ability of your assistant, you also differentiate between your diagnosis and between your equipment calibration status. So next comes the question, is an expert's hand, NCT or other tonometer recording system is more faster or cost effective than applanation tonometer? No, not at all. So why should we, settle down something, low standard? So when we can achieve the, best, and we should, break our comfort zone, go ahead that we should teach each and every assistant of us for doing a very good applanation tonometer in the patients. So come just to summarize, clarify the concept of your assistant regarding applanation tonometer completely, then ask them to do practical on their own colleagues and see that how they are doing. When you are satisfied, ask them to apply on the patient. However, you go ahead for a evaluation, and if any problem identified, then again clarify the concept. Thank you very much. Obviously, it will take a time, but it is definitely going to repay you. Thank you very much.
Very nice. Madam, this method is very good for institutes, but people like us who are running their own clinics, if we start doing 80 for every patient, everyone more than 40-year-old who's coming to us, it becomes very difficult. Because
I said that is why your assistant should be very strong enough in applanation tonometer. The technician should be really good.
Yes.
You need time, but once you develop that team is going to be, excellent.
So ideally, we should have an applanation tonometer and do it for all such patients, but practically, and for about 90% of our practitioners, this is not actually possible. Some of the doctors who are PD of 50, 60 patients, most of them have an NCT, and that is how they end up trying to find out, or you can say weed out a patient in whom they might require an applanation. In fact, my question is, we used to try to debate, should we use a fluorescein dye before applanation, or we can also do without applanation? Dr. Anindya, if you can talk about that. Because
the fluorescein is must for all glaucoma patients, but yes, as you said, because of the time restrictions, if we are going for a applanation for all the normal patients without fluorescein, that will preserve your time. So if something abnormal eye pressure you found out, then you want to fix, because without using fluorescein, hardly there will be a difference of 2 or 4. That makes a difference for the glaucoma patient, but for a normal patient, having a healthy optic nerve, if the 16 instead of you noted it down as 14, it really does not matter.
How much difference would an NCT versus a properly done applanation have?
No, NCT, in applanation cannot be just changed by NCT. It's something, not comparable at all. And as you said, 50, 60, I have trained all my optometrist assistant, including the students, who just come for a few months also. The applanation tonometry, this is must and must. They do on themselves first, at least for 1 month they have to do it on themselves. Then we check that yes, and they are doing it without corneal abrasion. When they have to do on themselves, they are very careful, so they don't want their colleague to do corneal abrasion and get a slap. So that is how they get trained very nicely.
brought up
Dr. in India, if I can just add a word here, we are using both applications. Every chamber has got an AT, but we are also using a rebound tonometer, the one which comes from Finland. And we found that in some patients, the readings are almost identical.
Yes.
But,
Yes.
and then
Some
and
patient
good thing is,
almost identical.
not
Yes.
not also in most patients, and they remain identical throughout. And in some patients, there's a huge difference. I mean, our rebound may be giving 40, and the 80 may be giving 24. And again, in these patients, this difference remains all the time. That's the very interesting thing we noted. It does not change. So therefore, if for normal screening, let's say we are doing just a glaucoma follow-up, we see what is the difference. If the patient has got a minimal difference, then we just keep telling them, "Aap aa jao, go for an RT," and you can go back very quickly, you know. So it's very easy. It's non-traumatic. It does not require anesthetizing the cornea. So there's no corneal dryness and there's no corneal, consequences of any drying of the cornea. You don't have to put anything on the eye. So it's a barely a 5-second procedure. And then we
Yes,
tell
sir.
all patients,
Yes, sir. If it is, combined with applanation, how you said it really, it gives immediate feedback that your applanation reading is going right. Because applanation is a subjective procedure. Any expert can do it's wrong. So, it should be a habit to do it twice, touch it, you come back and again do it. That is how, we are being taught from our glaucoma fellowship days to do that. And, in Toronto, that is my fellowship is from Toronto, and that is where I saw, all the technicians are very well versed with applanation, and that is how, it reduces the difficulty of the doctor. So that is why I really think, let's empower our team.
And because of this, what we are able to do is we are able to screen everybody, even the attendants we screen free of cost, We say, "Jitne log hai, sab apna get your pressure tested,"
Yeah,
That's it.
yeah, it's very nice thought, sir.
I believe let's move forward because there are a lot of
entire team for this applanation tonometry. It's not easy job.
Ma'am, once done, your life is so easy.
Yes, that's true. That's true. Maybe we have not done once we started doing teaching. It will be easier.
Ma'am, actually, what we do, we teach to 2-3 people, then ask them to teach, then we recheck. So, they are also enthusiastic. Oh, we taught 2-3 new students. So, by teaching them, they learn even much better.
Okay.
So that's why, our job is reduced.
So we have taught them OCT and all the diagnostic procedure. We have taught them the big things, specular, OCT, oculizer, so many things, Almaster, but we have not taught this. We have not taught. We will send 1 or 2% to you, and then they will start teaching everyone. So one of our person is with you, Mamta.
Yes, she is doing good applanation. Absolutely correct.
Okay.
Very nice, girls.
Mamta is with you.
You have trained so nicely. Very efficient.
She's your right now. She's doing some fellowship with you.
Yeah. Yes.
Yes. Okay, Dr. Pritish, please take forward the session.
The next speaker is Dr. Deepika. Her presentation is ideally fundus pictures should be taken from the childhood and stored. Practical, is it? Dr. Deepika, please. Madam, kindly.
So before that, I should introduce Dr. Deepika. Dr. Deepika is a pediatric ophthalmologist. She is very young, looking very beautiful girl, but she is very smart. She's an SN alumni, and she does medical retina also. She's practicing in Bokaro. So she will be talking about fundus pictures should be taken from childhood and stored. Practically, is it possible? Ideally, it should be.
दीपिका का चेहरा क्यों नजर नहीं आ रहा है?
Deepika,
are you there?
I'm calling her. So if she's not here, please carry.
I think, ma'am, just check. Maybe you have to unmute her.
Yeah, I'm sharing my slides, ma'am. The camera is off, but her voice is visible.
Yeah, we can see the slides.
Yeah, my voice is audible, sir.
Yeah, but it's not clear.
Hello. Now, is it clear, sir?
You have to speak loudly.
Yeah,
Okay,
or
sir.
put the
I'll
mic
try.
closer. Yeah.
Is my slides visible, sir?
Yes, yes.
Yeah. Thank you so much, ma'am, for the kind introduction and also for giving me an opportunity.
अरे जोर से बोलो.
Go nearer to the mic, please.
Yeah. Now, is it audible, sir?
Yes, yes.
Yeah. Thank you so much, ma'am, for the kind introduction and giving me the opportunity. Now, I'll be discussing a few case-based things in order to deal with the topic and justify my topic. The topic is ideally fundus pictures should be taken from the childhood and stored. Practical, is it? When we are dealing with the child, it's very, very difficult even to examine the child. Taking a fundus photo and storing is also quite difficult, right? So, my first case is 5-year-old child who complained of diminution of vision associated with redness and pain. He had a trauma by the wooden stick. So he was having a finger count vision of 1 meter in the right eye. We took fundus picture for that child. That was having RPE trophy. So if we are able to take fundus picture for the child, this can be used for the patient education and further prognosticate the case. Subsequently, we manage the case with the oral steroid and the topical steroids, and the vision improved to 6/80. So this kind of fundus picture can help to educate the child and the parents that we are treating this case and how we are going to proceed for this. And the second thing, this also can be stored and used for academic or the research purpose. My second case is APROP, especially the atypical APROP, zone half APROP. This was the fundus picture that we take from the fundus photography camera. The slides is showing atypical ROP, especially in the zone 1 with the dilated tortuous vessels near the macula. So we proceeded with the injection anti-VEGF and the laser for the patient. Subsequently, the laser were done and the vascularization reached up to the periphery. So these photographs can be used to show to the parents how severe the disease was and how it was treated well. So this type of fundus photography, if we can keep it in a record, that can be used for academic purpose, patient compliance, and also to deal with the medical legal cases. So this fundus photography is very, very important. Another case was a patient with the vitreous hemorrhage with the zone half APROP. This was also given the injection anti-VEGF, ROP laser was done, and in the subsequent visit, the vitreous hemorrhage resolved. So this kind of fundus photography can be used for patient education. Also, we can discuss with our colleagues how the vitreous hemorrhage resolves in patients, how long it takes, and we should not panic. Also, we can teach the parents that this was a vitreous hemorrhage and your child is in the developing age. So the child is also having a risk of developing amblyopia. So this type of fundus photography recording is very, very useful. Another case was neuro-ophthalmologist, 10-year-old child complained of diminution of vision in right eye. And there was a history of bone tuberculosis and patient was also having renal disease. The patient was having vision of 660 in the right eye with the disc edema, hemorrhage at the disc margin and macular scar. Otherwise was normal. So we took a fundus photography in this patient. The disc is showing disc edema with the macular scar. So this kind of photography is very, very important, like to document the case, especially in this medical legal era. Subsequently, there was also the RPE changes, and we proceeded with the oral steroid and also giving the treatment for TB. And in the follow-up, vision improved to 6/12, and there was resolving of the macular edema, and temporal vegetative time. So the fundus photography in this case is helpful for documentation, prognostication, also for the educational purpose. My other case was optic neuritis, a 12-year-old child who complained of diminution of vision in the right eye since 22 days, and there was no history. There was RAPD in the right eye, and vision was hand movement, and also the disc edema. In the fundus photography, we can clearly see the disc edema with the macular scarring, macular edema also. So we propose a differential of neuroretinitis in this case and proceeded with the treatment. So in conclusion, the non-mediatric ocular fundus photography can be used as an alternative to the routine ophthalmologist, especially in the clinical setting, including the pediatrics clinic. Also, this technique can help in the photo documentation for the better understanding of the patient and also for the research purpose. But practically, is it very definitely not. Even the child, if we touch the child, so some of the children are very, very cranky. They don't even allow us to do any of the examination. So taking the fundus photography in them is beyond say. But especially if in some patient we can collect the fundus photography and do the examination, so it will be very helpful to us. Thank you so much.
So, madam, your recommendation is to take photograph of all the patients of suspected future problems or the present problem to be compared with the future resolution of the problem. Is it necessary?
No, sir, it's definitely not necessary. But if we can document the things, then it would be better for the patient, doctor, and for the academics also. My recommendation is not there, but especially if we can like do for a couple of patients, then it would be very helpful.
Yeah, because the problem is the doctors are tying their hands themselves by saying that this should be done, that should be done. Because nowadays, if your prescription does not have a complaint and a vision and intraocular pressure, your prescription is not complete and you are bound to be, penalized by the court. So if we discuss these things that everybody should be taken photographs, so the court is going to ask you, did you take the photograph? If not, why not? So there's a negligence.
Yes, sir, you have tell the right point.
Yeah, but then you have a very nice idea.
I would like to interrupt the thought process here. The whole idea was a bit different. Is it necessary that once the child can be actually put on a fundus photograph, should we take a fundus photograph and store it with us for a future reference? In fact, these have now become very rife in certain Western countries where anybody who visits an optometrist, even an optometrist has a OCT and a fundus camera, and they start taking the fundus pictures and doing the OCTs because they get a copay. A copay is about over and above the insurance money that they get, and so there the whole idea was that if we go ahead and take these pictures and store, we can definitely come to sometimes in the future might be able to find out some disease, or we might be able to find out some data which might be helpful for research. So how practical it is, that is what has to be discussed in our Indian scenario.
Good, very nice.
Now we move on to the next guest speaker, that is Dr. Twinkle sir. I'll be introducing him. Dr. Twinkle sir, it's a great privilege to give you an introduction. Dr. Twinkle sir is the director of Manish Eye Institute, Ahmedabad, was the ex-scientific committee members in Gujarat State since 2007 to 2010. Ex-joint organizing secretary for an All India Ophthalmological Conference held at Ahmedabad in 2011. He was an executive secretary of the Ahmedabad Ophthalmological Society from 2009 to 2012, and he has remained a chairman and co-chairman speaker at various state and national level conferences. So we welcome you in this 21st midterm conference. Please go ahead.
Thank you, Prithvish, for a very nice introduction. Thank you, Dr. Jhos, Dr. Bharti, and Dr. Tejas to inviting me. A very good concept which is going across the nation by Dr. Tejas. What is ideal and what is practical? And I thanks to giving me this opportunity. Now, what is an ideal? That whether to change everything in between the cataract surgery cases? Yes, it is ideal. Everything has to be changed in cataract surgery. That is an ideal thing. But it is not practical in certain scenarios, particularly when the very busy practitioners or like a moderate practice like me, where we have at least 8 to 10 cases per day. It may not be possible to change everything in between the cataract cases. So, which are the things to consider when we are considering about the what has to be changed in between two cataract cases? We go one by one, like type of anesthesia, whether it is a topical or a local or a general anesthesia. Preparation of part of OT environment, aseptic precautions on the part of surgeons and assistants, and on the part of equipments and instruments. Let's go each and everything individually. Like type of anesthesia, we go for the local anesthesia. Local anesthesia, there is containing of injection xylocaine, injection sensor cane, injection relays. They are available in the multi-dose vial bulbs. So what we are doing at our setup is we are never utilizing the same bulb for the next session. We mix the xylocaine either in the sensor cane or the xylocaine, and we utilize in all the cases if we are going for the local anesthesia. For anesthetics, we have a separate dump for the anesthetics. Every time we are using this separate gloves, cotton balls, pad and artery forceps, which are kept in the that particular drum, and that similar drum for the all cases in the session. For topical use, nowadays the Sunways jelly is not available, so we are using the xylocaine jelly, which is 30 ml available jelly, and that we are using for the 3 cases for 1 jelly, and we are discarding it. As far as OT environment is concerned and aseptic precautions are concerned, keep ventilation equipment on and OT door closed in between the cases. We prepare the fast disinfecting solutions according to the manufacturer's instructions. We usually using the BD125 as a disinfectant solution. So use a cloth dampen in the disinfecting solution and use the disinfect surfaces that have come in contact with the patient, OT table, cuff of monitor, and 3 feet around the OT table with the sequence following like a top to bottom down or the inside the out. So practically we are cleaning after 3 cases. We are not cleaning after every cases because it is a very time consuming. So we are practically doing after 3 cases. The surgeons and assistants, ideally every surgery surgeon has to be scrub, assistant has to be scrub, and we have to they have to change the cap and mask and scrub. But practically at our setup, the surgeon scrub after 3 cases. Same when new assistant comes out the 3rd cases, we changes the gloves in between the cases, but we are not scrubbing on every cases up to 3 cases. But these 3 cases, this scrub time, the cleaning procedure has been done by the OT ground staff. As far as equipment and instrument is concerned, trolleys, after every 3 cases, we make a new trolley. Instruments, we have 15 cataract sets, which is including the IA cannula. So every surgery, new set has been used. So we are not using the same instruments for the next case. Consumables, we use all the needles, syringes, disposable cannulas. So it's all new for the new every cases. Viscoelastic HPMC 2cc prefill syringe we are using. So every case we are using the new 2cc prefill syringes. But for sodium iodinate, which is costlier than FIR for us, so we changed in a new disposable cannula, but left out has been discarded for 3 cases. Saline is concerned, I am a Centurion user, so I use till the last drop. So as many cases possible with the same saline solution, I'm using it. And equipment point of view and instruments point of view, phaco tubing and cassette. For the same session, the same tubing and cassette has been used because I am a Centurion user. Phaco sleeve, we are changing on every cases, we are changing the phaco sleeve and phaco tip. I have kept the 4 phaco tips, so every 3rd cases we are changing the phaco tip. So now what to the audience? Now can go further discussions regarding each and everything. Thanks for your attention.
Sir, you said after every 3 cases, the cleaning is done around the OT bed. Is it so, sir? Like, do you hold the OT in between for the cleaning?
Yeah, of course. The surgeon asks us for the going for the rescrub at that time.
Okay. So after every 3 cases, even the scrub is done again.
Yes, scrubbing is again after 3 cases. So we are keeping 2 scrub assistants. So the second scrub assistant will start trolley making on another table. And the table which has been utilized has been cleaned up.
I think that was a very candid way of putting your own practice, Dr. Twinkle. And I believe a lot of us also go ahead and do that because it is practically impossible to change everything for somebody who is doing more than 2 surgeries. You know, even keeping 4 phaco handpieces is a lot of money. And also taking care of all the 4 of them is also a lot of money. If you have a warranty of say 1 year for a phaco handpiece, and if you have 4 handpieces, it does not translate into 4 years. All the 4 of them are covered at the same time. So this was just a small example. But what we can do is we can actually try and optimize our own situation. Whatever you described is a very, very practical way of doing it. And I can also vouch for what Dr. Twinkle practices, that the endophthalmitis rate is not at all concerned with whether we changed everything or not. It has absolutely a different root cause.
I agree totally with Dr. Tejas. And the result is, you know, what the government says that the Ayushman Bharat is now successful. They are paying around 7,000 to 8,000 rupees per case, or probably a little more if you have certain other criteria. The problem is all the TPAs, they are also asking to do the cataract cases for those money only. They said that if you can do cataract surgery in this rate, why not this? And there are many TPAs who are capping the cataract for 24,000 rupees to 30,000 rupees. Now the problem is, if you are going to take all these precautions, will you be able to sustain the cost? I don't think so. Even today, just calculate the cost of your machine and the rent of the your building and the electricity bill and the manpower and the lens and the solutions and all that. If you take all these into consideration, along with that, you have to change your machine after every 5 years, and not only change, you have to pay a little more than what we had to spend 5 years back. If you take all this into consideration, you'll be bound to charge much more than what you are charging at the moment. So with this cost being set up by the government is just not possible.
8% inflation and 18% GST. So that it's 26% every year that we should increase.
Particularly, I would like to know from the panelists that those who are using the reusable tubings, how they are using how much surgeries they are using for the reusable tubings. On the same
Which reusable? Centurion?
No, not about the Centurion. Other machines.
Sir, we are using Oatly machine and we are using reusable tubings. So usually what we prefer to do, we do 2 to 3 cases and then again we autoclave it. So
it is
maximum we are
again
doing, yes.
Frankly,
what about the phaco tips?
Same, sir. Once we autoclave, tubing and sleeve and tip, all we're using for maximum 3 cases, and then we were taking another set for phaco cases.
Something very sensible has come out of the Orolab people. They have conceived a new machine called Humming, but not actually a new machine, but this machine has a 500 rupees sensor come tube. So 500 rupees is peanuts, and we do not change it. We can afford to change it, but we still do not change it because there is very little chance that something will egress back inside the eye from the tubings. So tubings, autoclaving the tubings is a bit difficult, but just changing it every day is going to be so easy. This is only 500 rupees. It is a sensor and a tube. You put it on the machine and throw it. And they give you one sensor free with some premium IOL also. So we have started actually encompassing this practice into our surgeries. A sensor which is disposable, and you do not have to autoclave it again, because autoclaving a phaco tube is a bit difficult. So that is our ideal practical way of doing it right now.
Sir, I have a question. In most of the centers, in our scenario, they are doing lots of cases, like 50 and 20 cases in a day. So what is your recommendation for that? Like how the thing should be changed for volume cases?
You know what we follow is we have got a movable OT table or OT bed. So the moment one surgery is done, that OT bed is taken out of the operation theater, and the other OT bed, which is just next to the first OT bed in the operation theater, that comes to my operating under the microscope. And the one which goes out of the operation theater, it is totally cleaned, everything is changed, and then that they are brought in with the patient with the injection or whatever it is. So it keeps on going out and coming in, and every time it is clean. But for the tubing, it remains there. For the tubing, it remains there. The instrument, yes, all the instruments are changed for all the cases.
So my question is for the DBCS or the LPCB cases, which are free cases, which we have to do in the hospitals in the government sector or in the trust hospital. What is the recommendation for this? It's very difficult to have to change every instrument of every cases. What you are saying, sir?
You are absolutely correct. The day was not very far. I, in 1996, operated 400 cases in one day. I had a team of 7 doctors, and then somewhere there was endophthalmitis happened, and then the government restricted now that one surgeon cannot operate more than 25 cases. So these things keep on happening, and the epidemic of the endophthalmitis, it is not very common. It happened once, and then the government changed all the rules. Something goes on, something goes wrong. Again, the government will change all the rules, and then you'll be restricted to probably 15 cases, then 10 cases, then 5 cases. It's going to happen. Then all the suggestions given by you people, I mean, it is good that the tubing has to be changed in each case and all that, and you have to give the proof of everything. So it's being difficult. And now the trust people, the charitable hospital people, they cannot afford this. You are absolutely correct. It's very difficult.
Absolutely. We talk about the flash autoclave. We need to autoclave in the flash autoclave. It's very tough. If you go to the steam inhalation, it's very difficult. We cannot change in every cases.
We can use the same instruments. We can tubings and everything is okay, but we cannot change the instrument. We cannot use the instruments. Instrument has to be re-sterilized before the other case. If any problem is happening, then government also will not excuse you. So even though you are working in a government setup, the government will not excuse you for that. So you have to take care of that part. Instrument cannot be reused for the next case.
What is the take on from the AIOS guidelines? If it is AIOS guidelines for the ethical committee or the AIOS guidelines, is there anything on it? I don't remember actually.
There is a Government of India guideline for the protocol of cataract surgery. It is there on the website, I think, also there. Definitely there.
Sometime back we had AIOS guideline formulated. Is there anything on that?
The guideline also said you to change the instrument after every case.
Guideline.
So I think we can move on to the next session.
To the all the panelists, I want to ask you one question. What is the cutoff point of blood sugar in cases of diabetic? I'm not talking about the HbA1c. I'm talking about the blood sugar level at which you will not operate.
Sir, we
Any operate till 200. Dr. Harpan's Lal operates.
AIOS
till
guidelines said it is
200.
200.
It's not, it should be less than 200.
It should be less than 200. The
And HP1 should be less than 7.
The 200 is random or fasting or PP?
Fasting में कर देते हैं Harpan's Lal.
not even understood what level are we talking. We had a discussion for 3 full days on this and nobody knew what they're talking about. In fact, the diabetologists say that postprandial is of no use now. Most is the fasting, because a postprandial is actually influenced by what you had. If you had mangoes an hour, your postprandial shoots up. But your fasting is even more important because there the hepatic glucose mechanism also comes into play, and the fasting does not change overnight. Still takes 2-3 days. But then again, all this is bullshit. Whether we should operate at 201 or not operate at 201, there is no scientific evidence. At 210 blood sugar level, you will have more endophthalmitis or more inflammation. Nothing of that sort has been done. So it is still a gray area.
Sir, but legally it has to be kept in mind, sir. I mean, even I have operated a phacomorphic case at 270 sugar because it needed the surgery urgently. I cannot wait for the sugar to come down. But then when we look at the legal aspect, then what should we do for such cases?
That is 270.
Yeah.
The UK standard is 270. Dr. Vivek, I think you are there on the group, right?
Yeah.
Yeah, so you might have been going through those 200 messages in a day.
270 is just a data. Commonly, we don't do surgery on that level. Just a data. 270, you do it, that's all right. But normally, we should not do at that level. My cutoff point is 170, 160, 170. I don't do anything above that.
Which has come up.
Sir, why? Why don't you do it?
Because
how big incision do you give, and what do you expect to go inside?
I said 270 is not a cutoff line. It is far above that. So we have to.
No, suppose there is a patient whose blood sugar is 350, 370, and is not coming down by all means, and the patient has got, let's say, phacomorphic glaucoma or the imminent faculty glaucoma. In that case, you have to do surgery. It's a kind of urgency. If somebody meets an accident and he is a diabetic of 400, will he not treat the wound?
What I say, you have to be precise about that. What is the condition? What are the requirements? If you say that it is emergency, forget about the blood sugar level.
Yes.
But in normal
Dr.
condition, you
Kashyap,
have to.
Dr. Kashyap, I like to say that we are performing about 25 to 30, 35
Hi, Dr.
cases
Jakhanwal.
also.
Nice seeing you. Tell me.
Yeah. So we usually follow, you must have seen IIUS has in the endophthalmitis, they have made one booklet. They have circulated a booklet. So a lot of things are over there. And what about the sugar is telling? So we can control the sugar by, we have the anesthesis. So we give insulin injection immediately and we wait for that. And we control in the, and we do it. Because in the general surgery also people do with, when you go to the surgery, they convert to the insulin and all the surgeries are done because the sugar is not a contraindication. Only thing you have to control.
Dr. Jakhanwal, please answer my question. Number one, do you want to control the blood sugar level for 5 hours only? And when the patient goes back home, again, the blood sugar goes up. What is the fun?
Yeah, absolutely. You're correct. It has to be controlled. It has to be controlled throughout.
Yeah, you know that blood sugar is, when your condition is inflamed or infected, the blood sugar goes up. So you control the primary condition. You have to control the sugar, operate the patient, and then settle the patient and then ask to follow it with the physician. Because here we are not talking about the medical emergency. Here we are talking about the surgical emergency. So how you will do the surgical emergency?
One is general surgery and ophthalmic surgery. In ophthalmic surgery, we are talking about two things. One is emergency surgery and then one is the regular surgery. In regular surgery, we have to control the blood sugar. Then we go for the surgery.
Correct.
You rightly pointed out that suppose that you do surgery and leave him, it goes home and the sugar rises. What will happen? So you
Then
have
why
to,
we lose? That is what we are having the anesthesis and we control it. And if the surgery is there, we have to do and then we control it and we get it done.
Dr. Jakhanwal, you
So,
missed
sir,
out the
this
first
is a-
sentence.
so
My
ideally-
first
This is a
sentence
never-ending
was
discussion.
that
Please
suppose
stop
if
it
the
here.
patient
It
is
is 5
diabetic
p.m.
and he's controlled,
I
right?
think
In this case, we have to take a calculated risk-based surgery, and as Dr. Upsam said, told about that, you have to take the video consent for that.
Yeah.
Yes.
Yeah, okay.
घर जा करके सुगर नहीं बढ़ाना है. Please
Sir.
stop here. Please stop here. Because
और
it
नहीं
is
तो
5 o'clock.
नहीं तो
Please stop
कश्यप
here.
में
move to the
कश्यप
next
में
session
रेफर
now.
कर देना है.
Please stop here. Please. Now we
Sir,
are going to
रेफर
start
करने
our...
का मतलब आप शुतुरमुर्ग हैं. रेफर करने का मतलब शुतुरमुर्ग हैं. माथा घुसा दिए मालूम है यार आप.
अरे देखो भाई
होगा
फोन आ
नहीं
रहा है.
सर. ये
Now the
issue ऐसा
Shuttermurg
नहीं
has
चलेगा.
also
अरे
become
अभी
very
हो गया.
aggressive. Chalo, next.
अब हो गया. अब आगे बढ़े. अभी we are going to start Jhos pot puri session, and session coordinator is Dr. Deepak Lakda. He is the professor of ophthalmology in the largest institution of Jharkhand, RIMS Ranchi. Dr. Pritish Pranoy, he is the high volume cataract surgeon from Rajasthan. Dr. Tanisha Ojha, she will be carrying forward this session. She's the glaucoma surgeon. Our chairpersons are Dr. Rajnikant Sinha. He is the ex-HOD of the Math Medical College. Dr. Mukesh Kumar, since morning he's here. He's a very high volume surgeon, cataract surgeon from Jaribagh. Dr. Purendra Bimal, he's not joined. Dr. Pinky Pal is since morning, very active lady. She does tremendous public awareness campaign in the government sector. Dr. Rajni Kujur, she is there also since morning. She is the very good cataract surgeon from CCL Ranchi. Dr. Sujit Kumar also I invited, but I don't think he has joined. Dr.
Purnendu has joined. Dr. Purnendu.
Dr. Purendra, are you here?
Dr. Purnendu Bimal.
Dr. Purendra Bimal, are you here?
Yes, ma'am, I'm present.
Okay, Dr. Purendra is present, and they all are discussing the chairpersons. There's a lot of viewers. So till now it is 5 p.m. and there are a lot of viewers on the YouTube, and the faculty link maybe abhi 40 dikh rahe hain. So everybody is waiting for the gene therapy, and before the gene therapy we listen. So please introduce Dr. Purna Chandra.
It is great to have this opportunity to welcome eminent vitreoretinal surgeon, Dr. Purna Chandra B. from Narayan Nethralaya, Bangalore. He is consultant in Department of Electrophysiology and Clinical Genetics in Narayan Nethralaya. He has completed his post-graduation from prestigious AFMC and followed by long-term fellowship in vitreoretinal surgery in Narayan Nethralaya. He has undergone additional training in inherited retinal disorders and electrophysiology from Moorfields Eye Hospital, London, and completed preceptorship on age-related eye diseases from SafeSight Institute, Sydney. He has also presented several papers on national and international forums and has published many articles in peer-reviewed journals. He has won several awards, including the Rama Mohan Award for Best Paper Retina at AIOS and Best of IGO Award. And his special areas of interest are in inherited retinal diseases, electrophysiology, retinal vascular diseases, and gene therapy. So we welcome you, Dr. Purna Chandra B, sir, for your keynote address.
Thank you, Dr. Tanisha, for the kind introduction. Hope I'm audible. I'll start sharing my screen.
Yes, yes.
Yeah. Hope my slides are visible.
No, sir. Yes, it is visible.
नहीं चल रहा है, चेयरपर्सन बना दी इसमें भी, चेयरपर्सन इसमें ही बना दी है।
Hello. Hello, sorry. Hello, can you hear me?
Yeah.
Sorry, I think suddenly the power went off. I don't know why everything got switched off. I'm
अब
extremely sorry
चेयरपर्सन
for that
बनेगा जो
technical
लोग
glitch.
तो वो सोच समझ के हाँ करना है, क्योंकि छोड़ेंगे नहीं किसी को।
Hello.
He has to be present. अगर वो चेयरपर्सन है तो।
Can you see my screen now?
No.
Sir.
Please share a screen, Dr. Purna Chandra.
It's shared, sir. It's already shared.
राजेश, how are you feeling? कैसे हो राजेश?
Yeah, I'm having fever and bad throat.
He's having fever. He's not well. Still he has joined. अभी क्या होगा? Take ginger tea.
Yeah.
Ginger tea ले लो.
I just
जिंजर टी से क्या होगा? जो लेना वो लेगा कि जिंजर टी से? क्या रजनीकांत जी, ठीक है कि नहीं?
To the point.
उसको फीवर है।
I'm a slide screen now.
I will call you Rajesh after Purna Chandra finishes.
Okay.
मैं तुम्हें कॉल करूंगी तुरंत।
Okay.
This topic is very important practically. It is the latest updates on collagen cross-linking.
हेलो।
अरे सब सो गया क्या?
आ गया है फ्रेंड और को भी लाके देगा पॉलिश करके।
चलो अनिंदिया तो है, पिंकी पाल है, रजनी कुजूर I can't see. She's saying I'm since morning. रजनी कुजूर?
Yes ma'am, I'm here.
अरे तुम्हारा अच्छा now I can see you Rajni. Dr. Mukesh since morning. I really appreciate Dr. Mukesh from Azadibad. सुबह से सुना है पूरा।
We are not able to see your presentation. It is still, it is showing it is.
No, I'm just.
So I believe your network and bandwidth is not good. That's the reason it is not coming through.
तो पहले इस तरह का करवा दें। Should we switch to Dr. Rajesh?
Yes. I think it's better, doctor. No, sir, ma'am. I think we should.
Okay.
Yeah, maybe you can switch it. I'll just look into my connection. I'll switch into a different Wi-Fi network, maybe. Is it better now? Hello?
So you can try once last time.
Yeah, because I just changed to a different Wi-Fi system. Can you see my slides now?
No,
Still not visible.
No, I'm sharing it, but I don't know why it's not showing it. Here, for me, it's showing.
Are you sharing for the first time, doctor? It's a new laptop.
No, I shared it. I shared it.
It's there. You can start.
Yes.
You can see, right?
Yes, it is visible.
Yes.
Okay, fine. Thank you so much, and I'm extremely sorry for whatever the technical glitch which has just happened. And thank you so much, Bharti ma'am, Kashyap sir, and Jharkhand Ophthalmic Society for inviting me to give this keynote address. So I'm going to talk on basics of gene therapy. So far we had a very good discussion on the cataract, the how to, regarding the instrument maintenance, the blood sugar controls, and many things. So today I'm going to touch upon some topic which is not very often addressed in most of the meetings. And we have many patients for retinal dystrophies in India who always keep asking us what's next, what can be done, and all that. So through my presentation, I'll try to answer some of those queries which will help you to guide your patients. So this is my topic, basics of gene therapy. So, genetics is the study of heredity in general and of the genes in particular. It forms one of the central pillars of biology and overlaps with many other areas such as agriculture, medicine, and also in biotechnology. It's not only in the medical field, it's used in somewhere else also. So why, as an ophthalmologist, we need to understand genetics? Because it's evolving at a very high pace. And it's surprising to know that eye is the second only to the brain as an individual organ in its frequency of involvement in genetic disorders. And almost 50% of pediatric blindness will have some genetic etiology. And clinical pictures can be overlapping sometimes and may not be enough for the proper diagnosis. So let me begin with a case example. So this was a patient of a very early Stargardt. This is how she presented in 2017. She had a 6/9 vision with a very minimal changes of the fovea. We can just call early RP changes. So in 2019, the foveal atrophy became even prominent. By 2021, the fovea is completely atrophied. So these are our corresponding OCT image. You can see that 2017 OCT, there is a foveal thinning with outer retinal loss. By 2021, that's in 4 years, outer retina and even the RP and the superficial choriocapillaries are also atrophied. So this is happening because of a mutation in a gene called ABCA4. If you want to prevent this progression, what we need to do, we need to correct the causative factor, that is mutation in ABCA4. So how do we correct that? This is by gene therapy. So basically, gene therapy is a technique of correcting effects of a defective genes that are responsible for the disease development. It can be done in 5 different approaches, where a normal gene is inserted into the cell to compensate for a non-functional gene, or an abnormal gene is traded for a normal gene by recombination technology, or an abnormal gene is repaired through something called selective reverse mutation or gene editing. Sometimes we can also introduce partially correct copy of the gene, which is also called an exon skipping. And in one more way of correcting the gene is the change the regulatory genes. There are some genes which are adjacent to the main gene, which affects the function of the main gene. So which are called regulatory genes. Sometimes there could be defects in the regulatory genes which can cause diseases. So how do we do gene therapy? We use something called AAV vectors, that is adeno-associated vectors. These adeno-associated vectors are nothing but the viral vectors. We use adenoviral vectors because they have a very efficient delivery system and very high level of gene expression and absence of viral genes. Because we know, like, if we treat some gene therapy with some viruses, it should not cause some other infection and lead to some other complication. So it's better we should get rid of the viral genes and we should carry only the correct copy of the gene which we intend to inject. And also it has shown that there is no toxicity or excessive immune reaction when injecting the host. And when we prepare the products, it's very important that these products stay stable so that it can be transported from the site of manufacture to the site where we give treatment, that is site of injection. So in that aspect also, adeno-associated vectors have excellent stability. So these are the current gene therapy trials, these are all human trials, what I am going to tell. So there are many trials which are already underway, like extinct retinoschisis, even macular degeneration, retinitis pigmentosa, choroideremia, RP65, and many like that. So our area of focus in Narayan Netral, we are focusing on developing gene therapy for the following diseases, that is retinitis pigmentosa, some of the corneal abnormalities, Leber's congenital amaurosis, and also a Stargardt disease. There are several factors we ophthalmologists, we can be proud because eye is an ideal organ for gene replacement therapy. Why? Because possibility of using contralateral control, we can give gene therapy in one eye and we can use the other eye as the control. And there's, like eye is immunologically privileged because of the blood retinal barrier and small size. So that the amount which needs to be injected is small and it's easily accessible. We can use non-invasive way like OCTs, fluorescence, angiography, and autofluorescence, other things to monitor it. And ease of monitoring by using all these techniques and compartmentalization. So once we inject any viral vectors, either intravitreally or suprachoroidal or subretinal space, it gets compartmentalized to that section. It doesn't get, like easily get absorbed to systemic circulation. So where it can cause some untoward side effect, that probability is less. I can't tell there is no chance, but compared to any other organ like kidney or liver, in eye, it's the systemic toxicity is often less. So I'll just play a small video to show how exactly is the gene therapy done. So basically, it's done for a genetic disorders with single genes, where we use a vector called virus. This virus is mixed with the normal cells, which carries the correct copy of genes. The mixture is then injected back to the patient for the treatment. I'll just mute the thing. So remove the viral genes and give them the new instruction and inject them into the retina. Into the retina means the most preferred route is subretinal. So this is the routinely we do a vitrectomy before we do a gene therapy. This is not my video. This is from the Oxford University. After doing a vitrectomy, we select a particular site and we inject these genes in subretinally. So once we inject these vectors subretinally, so the virus will travel and it will start reaching its intended spot. It will get attached to the cytoplasm membrane, get internalized into the cell, and it will uncoat itself, and it will travel all the way up to the nucleus of the cell. Once it reaches the nucleus, it will pierce the nuclear membrane, and it will reach the host genetic material, that is the DNA, where it gets integrated, and it is expected to function normally, as it is shown in the graphics. This is the simple graphical representation of how gene therapy is being done. It's not that simple. So this was the Moorfields team and the Oxford team with whom I attended my initial few gene therapy surgical OTs. So, but there are some challenges when it comes to gene therapy, because the cargo capacity of AAV vectors is very small. It's only 5 kb. Because of it, some of the large genes, especially like ABCA4, which is the commonest cause for Stargardt disease, and USH2A gene, which is the cause for Usher syndrome, these genes cannot be loaded into these vectors. For which we have come up with a novel technology of dual vector strategy, where we split the gene into 2 parts. These are infected into the separate variants, and when they are co-infected into the host cell, once they reach the target cell, they'll join back together, and where they start producing the intended protein. So these are our chief scientists. This is a patented technology for our Grow Lab. And Professor Arka Subraghosh and Professor Somi Bhattacharya are the key scientists involved in developing this dual vector strategy. So why these clinical trials are needed in India? We know that there are a lot of trials which are going on in the West. India, we need to start our own trial. That is because there is an unmet need for the patients currently in India. Some diseases occur early in childhood, which is devastating not only for the affected member, but also for the families. And in addition, some of us know that the cost of the recently approved gene therapy product, that is Luxturna, it will cost around 6.5 crores per vial, which literally none of the Indian patients can afford. So to bring down these factors that limit the cost, what we need to do is we should start producing our own vectors in India itself. That will bring down the cost. So these are our initial trial where I tried injecting these viral vectors in the mouse, subretinal injection. So this is the mouse retina. This is the site of injection. We use fluorescent particle staining to trace the vectors we've injected subretinally. So, and this is how we have a dedicated gene therapy production platform with an expanded team of scientists. And I'm also happy to inform that we have built first in class 100 clean room facility. So basically this facility is we have built to produce the vector. So class 100 clean room facility basically means the sterility of this environment is 10 times more sterile than the normal OT what we use for cataract surgery. So this is the first in India. So before we enter this, we need to cross multiple barriers, like you need to take a normal shower, you need to take an air shower, then the proper donning has to be done with specific gown material, and then you finally reach the vector production area. So this is the first in India where we have built vector production facilities. And national guidelines for gene therapy trial are already out. If any of you are interested in following these trials, you can go to the ICMR websites and you can go download these instructions, because if you want to start any of these trials, you need to comply by these guidelines which are laid down by ICMR. So if you have any doubts, please get in touch. We are happy to help you. So, and thank you so much for the opportunity.
Good, Purna, good, very nice.
Very nice.
Thank you, sir.
I
Thank you, sir.
understand many of your points. Like, is this commercially available? Are you treating diseases with gene therapy, or it is in the just research level?
Ma'am, this is under the trial phase. So one good thing is, even for the trial, we are using our own vectors. The cost increases when we have to bring the vector from outside, like outside India. So we have used our own vectors in the animal models, which is showing a very good results. And we are doing not only the photograph of the animals, we are also doing ERG in animals to study the functional effect of these genes. So we are ready with our first phase 1 trials. Maybe in next year, if God willing, by next December, we are planning to start human trials.
So next year you will plan human trial, means
yes,
the 2 years your institute will make it commercially available.
No, ma'am. It will be a trial. Once it passes through an human trial, once we are convinced that it's working in humans, then we'll make it commercially available. During which the rate will be disproportionately less compared to what they're putting in the West. It is like, as I told you, 6.5 crores.
So now gene therapy is not available for eye diseases in India.
Yes, no, ma'am, it's not available. There are few who are trying. Yes, sir.
Can you tell me the difference between stem cell therapy and this gene therapy?
So stem cell therapy is something which is used to replace the entire cell. Okay, for example, in gene therapy, what we do, we correct only the defective genetic material inside the cell. We are not altering the cell. Our vectors just go through the cells and bind to the existing functional cell, and they will correct the defective copy of the gene. Whereas in stem cell therapy, will replace the whole tissue is the new things. But stem cell therapy has also been tried in retina, but it was not of a great success. It has started forming many teratomas, hamartomas, and all that. Compared to stem cell therapy, gene therapy has seen little bit more advancement.
Okay, so this gene therapy is only getting developed in your center, or it is getting developed in some other center of India also, like Assam, like Madhur Arvinda?
No, vector production facility only we have, ma'am. Only we have, not in
And
other medical.
Important.
Yes, other medical specialty also, it's not there. Across all medical specialty and non-medical specialty, we are the only one who have class 100 clean room facility for vector production as of now.
So once vector is there, which can carry many genes, so you will be able to treat to some part the Stargardt's, the retinitis pigmentosa.
Yes, and LC, Leber's congenital amaurosis.
And the other disease?
Leber's congenital amaurosis, LCA.
Leber's congenital amaurosis. So retinitis pigmentosa patients have some hope in future.
Yes, definitely. If you are seeing a patient of retinitis pigmentosa who is in his 20s and 30s, you can safely tell them in his lifetime there will be something, if not for curing, at least to arrest the disease, there will be some treatment.
Yeah, Dr. Poonawala, I have some query.
Yes,
can
sir.
we expand this trial to general ophthalmologists also, involving more ophthalmologists? That will more helpful.
No, they cannot, because it needs a very big infrastructure. They cannot do it.
No, sir. No, madam. What I wanted to say, suppose that government is willing that the government send us for various training. So something like that to be added in this curriculum also.
Definitely, sir. I understood your question. Like, once we reach the human trial, once it's commercially available, I do understand. First of all, sir, forget about general ophthalmology. Even among retina specialists also, the awareness about dystrophy is very less in India, because there is no money in this, no, sir, because there is no treatment and all. There are very few are interested in speaking to retinal dystrophy patients and all that.
Government should start funding and provide the facility that you are developing. Okay.
So do you get government grants?
Yes, sir. Yes, I am the first person in India to get a gene therapy grant from ICMR. I have not put it in the CV because I am going to get it next year. The ICMR has also given the grant. There are many other Western universities. They have also given us funds. From India, we have got the ICMR. This is the first gene therapy grant in India.
In crores, because it is a very costly project.
Yeah, I'm not sure about the exact amount, but the amount what NN invested, it's 90%, 10% we are getting from the government.
Oh.
Because the amount huge involved is huge because to build the vector production and all that.
But this
So
is
we
very
are,
heartening to know this. It is very hard.
yes,
So we have invited your head, Dr. Rohit Shetty, this time
yes, sir. Yes, ma'am.
in the annual conference, and he has agreed also.
And it's because of his wish and his future thinking, all these things are possible because it's a
Always.
very pros research. Yes, ma'am.
And it is very heartening to know that only one center is into that, and you are near achieving the target. So these are retinitis pigmentosa people, they are very common in practice, and they have some hope in near future.
Yes, ma'am. Definitely. Once we do it, hope other institute also get inspired and they also start maybe.
At least RP Center aims can start it. Thank you,
Yes,
Dr.
ma'am.
Your talks are always very lively. Even in our electrophysiology course in AIOS, which we conducted, your talk was so nice, and everybody appreciated your talk because you gave a lot of practical example. Thank you so much.
Thank you so much.
Carry forward the session, Dr. Tanisha Oja. So I'm calling Dr. Dr. Rajesh Sila.
Yeah, I'm here.
Okay, he's there.
It is an
something has happened.
We got two devices open from one.
Audio visual.
Pinky probably will have to close one device. That'd be good.
अरे सुनील को फोन करो, देखो क्या हो रहा है। नहीं ठीक है।
मैम दो जनों ने किसी ने ज्वाइन किया हुआ है एक साथ।
Bug is there.
दोनों ज्वाइन किया हुआ है।
हेलो।
You are shooting.
अभी चेक करिएगा मैम।
Yeah, it sounds good now.
ठीक है।
Okay, Tanisha, please start.
Okay, it is an honor to welcome renowned Professor Dr. Rajesh Sinha, Professor of Ophthalmology in Cornea, Lens and Refractive Surgery Services at prestigious RP Center, AIMS, New Delhi. He has done his MD in ophthalmology from AIMS and then went on to pursue DNB, FIA, CLE and FRCS, followed by a fellowship at University of Washington. He has several publications to his credit, along with 4 textbooks and 5 educational manuals. He has been a part of 3 multicentric FDA clinical trials and has received various accolades, notable among which are achievement awards of AAO, APAO, and SARC Academy of Ophthalmology, and has been appointed the professor of the Asia Pacific Academy of Professors in Ophthalmology, and is the recipient of many notable orations in the country. Currently, he is the treasurer of AIOS, treasurer of SARC Academy of Ophthalmology, general secretary of Indian Society of Cornea and Keratorefractive Surgeons, and treasurer of Eye Bank Association of India. We welcome you, sir. We are eager to hear from you, your keynote address on the latest updates on collagen cross-linking.
Thank you, Dr. Bharti and the whole team of Jhos for inviting me. I'm sorry for my voice. I'm having a bad throat and fever. That's why. Okay. So I'll be talking about updates on corneal cross-linking. Corneal cross-linking is something which is an established modality these days for halting the progression of keratoconus. And what it does, it uses UV rays with riboflavin to do cross-linking of the collagen fibrils of the cornea. And that's how it strengthens the cornea and makes it compact and strong. And it is mainly indicated for progressive keratoconus, and I'll be mainly dealing with indications in keratoconus only in my talk. So it is used mainly in progressive keratoconus to halt the progression. So there's so many factors that are there that will give us the idea that keratoconus is progressing. So which one to select? So there was a global consensus that was done in the year 2015, and wherein they finally made a statement that if there is change in at least two of the following parameters, then it will be a progressive keratoconus. That is progressive steepening of the anterior corneal surface, progressive steepening of posterior surface, and progressive thinning. And the standard method of corneal cross-linking is the usual resident protocol, wherein I think the video is not running. The standard protocol is that you debride the epithelium, central epithelium, and then use riboflavin every 2 minutes onto the cornea, and then focus UV rays. And all these is done first 30 minutes stage of putting the riboflavin, and then minutes phase of putting the UV rays along with riboflavin every 2 minutes. And it is now an established modality, and most of the studies have shown that cross-linking works in halting the progression of keratoconus, and that is detected by this presence of demarcation line that is usually seen in anterior two-third of the cornea. And that is why it is assumed that cross-linking works in anterior two-third of cornea, and that is why in post-LASIK ectasia, it is not as effective as in primary keratoconus, because in post-LASIK ectasia, flap forms a reasonable thickness, is something around 120, 130 microns. And flap, we all know that it does not contribute to the strength of the cornea. And if you do cross-linking, that will not have that much effect as in a primary keratoconus. Now, cross-linking has been combined with all these modalities like PRK, intracorneal ring segment, toric ICLs. There are various protocols, Athens and Cretan's protocol, wherein PRK is done to smoothen the surface, and then cross-linking is done to stiffen it, so that you reduce the irregularity. You don't correct the refractive error, you just reduce the irregularity. It's a topo-guided custom ablation, which reduces the irregularity of the cornea, and then you do cross-linking and stiffen it. Then I think there is something wrong with the system. Anyways, video is not running because I may have to restart, and that will take time.
Please restart. We want to see Rajesh.
Shall I restart?
Yes.
Okay. I'm sorry that I'll just restart, and then sometimes it happens that if nothing is working in computer, then you have to restart it. I'm sorry for.
Not at all, not at all.
I think you are so sick, still you have taken your time out and keeping the promise.
I think Rajesh sir has logged out, he's rejoining.
Dr. Rajnikant, can you see my picture, Dr. Rajnikant?
Yeah, I'm seeing you.
Yeah, but I cannot see my picture.
Why?
I cannot see my picture.
अच्छा है, इसमें कोई बुराई नहीं है। चेक कीजिए, अपने एक्सपर्ट को बोलिए चेक करेगा। रीस्टार्ट योर सिस्टम, आप लॉगिन फिर से कीजिए।
नहीं, it is Mr. X in Ranchi.
आप, मैं बोल रहा हूँ फिर से लॉग आउट कीजिए, फिर से लॉग इन कीजिए, हो जाएगा।
उधर स्क्रीन को शेयर करने के लिए मैं रेडी करके रखा हूँ। If something goes wrong, the problem will be there.
इसलिए बोल रहा ना, उसको फिर से लॉग इन कीजिए नया से।
हाँ,
लॉग आउट कीजिए और लॉग इन कीजिए, एक सेकंड तो लगेगा।
करिए लेते हैं।
Ma'am, sir is yet to join, I believe.
I'm really sorry for the technology glitches, and I'll just move on to the. Okay. So, I'm sorry, there's something or the other is happening. Okay, fine. So cross-linking has been combined with various things. As I said, that topographic assisted custom ablation can be done to remove the irregularity of the cornea. Similarly, intracorneal ring segment can be put to reduce the astigmatism, to reduce the irregularity in cases of keratoconus, and then you can do cross-linking. So so this is how femtosecond laser has been used to create the track for the intracorneal ring segment. You just open it first with the help of a mechanical separator on both sides, and then you use these PMMA rings to introduce into these tracks. And you can put 2 rings or you can put 1 ring. In case of keratoconus, most of the time, if you require 2 rings, then you will require asymmetric rings, that is asymmetric thickness rings, because keratoconus is a disease of irregularity, is a disease of astigmatism. Or if at all, if you require a single ring, then many times a single ring helps in order to, that's how you reduce the astigmatism. And once you have done it, then you can put a suture. These days I've stopped putting the suture. And then you debride the epithelium in the center and then put riboflavin and then cross-link the cornea. I'm sorry. Then, as I said, CXL has been used with good effect in cases of post-LASIK ectasia along with intacts. So CXL now is an established modality. There's no doubt about it, and it is now known thing about it that it is an established modality. However, there are certain issues because when you debride the epithelium, the patient does have pain. It's a long duration procedure. It's a 1-hour procedure. And if the cornea is thinner than 400 microns, then there's risk of damage to the endothelium. And that is why the updates keep coming in order to have a better outcome in case of cross-linking. So in order to reduce pain, transepithelial CXL has been attempted. Various methods. They've used drugs that increase epithelial permeability, but it doesn't work. Then people have done partial removal of epithelium. That has also not worked. They have done crisscrossing, as you can see here in this case, crisscrossing of epithelium debridement so that part of area is debrided and part is not. It has been noted that the area where you have not debrided the demarcation line has not been formed. And that is why today the punchline is that in order to get efficacy, we need to have epithelium debridement. The second issue is it's a long procedure. It's a 1-hour procedure. So people thought that if we increase the power, like normally what we use is 3 milliwatt per centimeter square for 30 minutes. So if we just reverse it, 30 milliwatt per centimeter square, you will require just 3 minutes. And that is what people started doing initial accelerated cross-linking. Because it was based on the Bunsen-Roscoe law of reciprocity, because you just multiply and see to it that you have to deliver this much of energy that is there, 5.4 joule per centimeter square. However, there are multiple studies that have compared all these protocols, 3 milliwatt per centimeter square, 9 milliwatt per centimeter square for 10 minutes, 18, 30, 45. And they found out that 9 milliwatt per centimeter square for 10 minutes is somewhat close to the conventional method. And it can be used as a replacement for the conventional protocol. Then the third issue was if the cornea has become very thin, as we see in keratoconus, then what to do? So initially for HAD-FAZ group, they started using hyposmolar riboflavin, which is still being used. So 0.1% riboflavin and 0.9% saline instead of dextran was used to swell the cornea. And then they found out that the endothelium is protected. However, the idea of doing cross-linking is not just to protect endothelium, but to cause strengthening of the cornea, cross-linking of the cornea. And when you swell the cornea by putting hyposmolar fluid so that the collagen lamellae, they separate, and then you want to cross-link. So these are paradoxical. So the effect is not as good as conventional cross-linking, because in conventional cross-linking, you want compactness. And here it is not the same. So that's why the result is not as good as the conventional cross-linking. Then people thought that we can do a conventional cross-linking. Let's separate the endothelium from a contact lens. Put a contact lens over the cornea so that the gap increases and the endothelium is protected. However, as we know that cross-linking works only in the anterior two-thirds of cornea, and part of it is occupied with a contact lens, which is thrown away. Second part is the pre-lens, post-lens tear film. There is tear film between the contact lens and the cornea. And that prevents passage of UV rays, and that was one issue. That's why the result is not as great. So people have used refractive stromal lenticule also. They have used the smile lenticule to put over the cornea so that it protects the endothelium, but the result is not as good as conventional cross-linking. We in RP Center, we thought that the idea is this, that if you put a stromal tissue on the cornea and then protect the endothelium, why not incorporate that stromal tissue into the cornea and then protect the endothelium and have an effect on that? And that is what we started doing here in RPC. This was a thesis, two theses we have done. Under my guidance, two students have done it. One with a 7 millimeter pocket, 7 millimeter of lenticule was used, and in another 8.5 millimeter was used. So this is how, with the help of a femtosecond laser, we create a pocket. And once the pocket is created, you dissect it. After dissecting, you infuse riboflavin into the pocket. So when you infuse riboflavin into the pocket, it disseminates very nicely, both superficially as well as interiorly. So in 2 minutes time, the whole of stroma gets the riboflavin infused. And then this is a donor lenticule, this is a 7 millimeter lenticule that has been created from donor tissue. And then it is introduced into the corneal stroma. So the idea is to increase the thickness of the cornea by introducing additive keratoplasty. This is a sort of an additive keratoplasty. You can just add some stromal tissue into the corneal stroma, and now you can do, this is a 7 millimeter donor lenticule. So you do riboflavin, use UV rays up to 7 millimeters. And that is how the idea is, to increase the thickness of the cornea and stiffen it by use of corneal cross-linking. So this is on day one, the stromal lenticule is quite thick, but at 6 months time, you can see the thickness reduces. And particularly in these cases, what I did was I ablated the central 4 millimeter of the cornea with excimer laser. So it became a negative meniscus lenticule, so that it can have some biological intact-like effect, peripheral thick and center thin, so that it supports. And I took 200 micron thickness of the cornea, which at 6 months time, after ablation of 70 microns, it was 125 on day one. And then at 6 months time, it reduced down to 98. This is the average thickness. So somebody who is having a 340, 350 microns cornea, if you add almost 100 microns, so it would be 440, 450, and you have stiffened it with corneal cross-linking, then it is a very useful tool to provide good visual rehabilitation. The patient can be rehabilitated with a mini-scale contact lens and may not require keratoplasty at all. The only issue is that you are putting a lenticule, so there can be two interfaces. And so you require long-term topical steroid so that the interface is not hazy and it is clear. So you can see here, these are some of the cases post-op of intrastomal lenticule with cross-linking. And initially we started with 7 millimeter microns, 7 millimeter lenticule. Now we have increased to 8.5 because the 7 millimeter lenticule does not give appropriate results. The 8.5 is giving good results, and you can see here nice bow tie pattern in a post-op case of keratoconus. Another thing that started coming up was customized cross-linking. The idea was to put more power of UV rays in the area which is thin and less in the peripheral part, which is not as thin. However, it is still under trial and not has not been so much in practice. Another update that has come up is use of oxygen, because it has been seen that when you do cross-linking, when you expose the cornea with UV rays, what happens is the oxygen saturation reduces down to 0 in a minute. So people thought that if we supplement oxygen from outside, that may help. And there are animal studies which showed good results. And they started doing human studies as well. And this is the oxygen mask that has been used. We created our own indigenous mask. This is a PPE kit, goggle of PPE kit, wherein created a hole over the top. From the side, oxygen was infused. So this is the area from where oxygen was infused. And this, through this cannula, we will measure the oxygen saturation in the periocular area. And this is the anesthesia machine with which it is connected. And the UV rays are focused through the opening in the goggle. And riboflavin is also instilled through the opening on the top. And the same goggle can be used for the left eye, for the right eye. You can just close one side and then you can use it. And the oxygen saturation mostly measured was 84%. And we use 5 liters per minute of rate of oxygen. And the cost of this goggle is just 300 rupees, while the cost of the commercially available oxygen goggle is 3,000 euros. So this is what this was published in the European Journal of Ophthalmology. This was published in the European Journal of Ophthalmology. But we found out that we had thought that with use of high oxygen, the effect will be very grossly high, will be much more than the controls. But we found out that the result was not as great as we had thought of. Perhaps there is something missing. So there are some queries raised with this study. That is oxygen concentration directly related to efficacy of CXL, or is there some other factor responsible? I guess there are some other factors also responsible, and that is what we have to keep working on, and we are working on to look for the factors as well. Another issue that has come up is the use of adaptive fluents, that you use if it's a very thin cornea, use UV rays for a very short period. And people, it has again come from Farhad FAZ group, and they have done it. This is sub 400 protocol, and they have done it in corneas as thin as 214 microns. So I don't know, and they have not evaluated the endothelial loss. They have just told that there was no endothelial decompensation. But in a young patient, large amount of endothelial loss will also not cause decompensation. So I feel that this study has raised furthermore queries, because sub 400 protocol flouts the concept of risk of endothelial damage in thin corneas, because earlier we used to feel that we should have 400 microns of cornea. And the study has not evaluated specular count and endothelial morphology. And if for 240 micron thick cornea, only 2 minutes with standard flux of 3 milliwatt per centimeter square is adequate, then how 30 milliwatt per centimeter square for 3 minutes was not as effective as conventional? So there's so many queries that have been raised by this study, and I guess this study needs a lot of further modifications, and we cannot rely on that. So in conclusion, corneal cross-linking, yes, is an established modality to arrest progression in keratoconus. And there are some issues, there are some queries that have been resolved, but there are some queries that are unresolved. In order to improve efficacy, safety, and convenience, modifications are being done. And some newer indications of CXL have also emerged, but are yet to be established. So with this, I would like to stop here and I thank you all for allowing me to speak, and also to bear with me during the technical glitches, and apologize for that. Thank you.
Thank you, Professor Rajesh. Wonderful. Thank you so much.
So it has benefited so many of us who are doing collagen cross-linking.
Thank you.
So you took time out despite your sickness. So we are double grateful to you.
No.
Now you can relax. Thank you so much, Dr. Rajesh.
Thank you. Thank you.
Get well soon. So now we are having local presentations. Hello. Am I audible?
Yeah, you're audible.
You're audible.
Yes, ma'am.
The first presentation is mine. The flap striae, it's not what happens, it's how you handle it. So I have made a video recently. I came across two cases. One was the early first post-op flap striae, and the second was the late post-op striae. And one post-op striae was associated with loose epithelium. So I have made a nice video of that, and I have borrowed the sweet voice of Dr. Nidhi. So I'm going to show that video, how I manage the post-op plastic flap striae. So I'm just sharing the video.
It's not what happens, it's how you handle it. Let's talk about flap striae. Flap striae are defined as wrinkles or folds in the cornea as a result of LASIK surgery. The most common classification of flap striae is based on the location, severity, and thickness. These have a variety of appearance and thus are classified morphologically as microstriae or macrostriae, and they can be located peripherally or in the visual axis. Microstriae are microscopic superficial wrinkles. They are asymptomatic and can be detected in the microscopic examination only. Macrostriae are larger full thickness folds and they cause noticeable visual impairment. The incidence of clinically significant striae requiring treatment is between 0.2 to 1.5%. The common causes of striae are a thinner flap or higher ablation depth, misalignment of flap after replacement, flap contraction and desiccation during ablation, flap wrinkling during stretching, movement of the flap on first post-op day, tenting of corneal flap over ablated stromal bed, nasal versus the superior hinge, and excessive manipulation during surgery. The visual symptoms linked to flap striae includes irregular astigmatism, optical abrasion, monoocular diplopia, degraded, uncorrected, and best corrected visual acuity. Now, microstriae can be treated with a bandage contact lens, punctal plugs, and preservative-free artificial tears. If persistent beyond 2 weeks, they can be treated as macrostriae. In macrostriae, even if the visual acuity is not much affected, it is better to intervene as epithelial ingrowth in the grooves happens very quickly. There are many treatment options available in the literature depending on the type of severity and time of detection of the striae and the choice of surgery. These methods include deepithelization with flap hydration, slit lamp stretching technique, flap suturing, hyperthermic flap treatment, or transepithelial phototherapeutic keratectomy. Deepithelization with flap hydration and flap stretching is the most common method for flattening the striae. Flap suturing is the technique used for regular striae that have been present for more than 1 month or longer. This technique requires expertise, and failure to apply equal tension results in an irregular astigmatism. The sutures can be removed after 1 to 2 weeks. Hyperthermic treatment of the flap is done for striae more than 1 month duration and when the conventional options are ineffective. It is based on collagen relaxation and denaturation at different heat levels. Transepithelial phototherapeutic keratectomy is an option for long-standing striae cases. The ablation of the peaks of the fold is done. Goal here is to achieve reduction but not elimination of all the striae. Now sharing few cases of flap striae. This is a case which presented with flap slippage and flap striae on the first postoperative day. Here, the superior stromal bed is exposed with epithelial ingrowth. 20% alcohol was applied to the exposed epithelium and it was removed thoroughly before lifting the flap to prevent epithelial ingrowth. The folds can be well addressed only by the removal of the epithelium of the surface. So here the epithelium has been removed from the flap surface as well. The epithelium is removed beyond the edges to prevent future epithelial ingrowth, which is common after flap relifting. The flap was refloated and the stromal bed and undersurface of the flap was irrigated well to remove any epithelial cell nests. Flap was hydrated well with hypotonic saline solution. The undersurface of the flap was stretched with a blunt instrument while anchoring the hinge with another blunt instrument. Flap was repositioned. We kept hydrating the flap and we noticed that most of the striae vanished by epithelial debridement and hydration itself. We can stretch the flap with a blunt rod and also with 2 Meroseal sponges, and then a bandage contact lens was applied. At 7 days post-op, slit lamp examination showed no flap striae. This can be seen beautifully on vitro illumination. Uncorrected vision was 6/6 and the post-op 7-day aberrometer and oculizer reports were within normal limits. This is another case of late post-op striae. The patient came back on the 7th post-op day with diminution of vision in the right eye. When we examined it on slit lamp, we found that the vision had dropped to 6/24. The patient was taken to the OR. 20% ethyl alcohol was applied to the flap and epithelium was removed from the flap surface and also beyond the edges of the flap to prevent future epithelial ingrowth, which is common after flap lifting. The flap was floated and stromal bed and undersurface of the flap were irrigated well to remove any epithelial cell nests. Flap was hydrated well with hypotonic saline solution. Undersurface of the flap was stretched with a blunt instrument while anchoring the hinge with another blunt instrument. Flap was repositioned and hydrated very well. And because of the flap hydration itself, most of the flap striae got flattened. We kept stretching the flap with 2 blunt rods, one used for anchoring and the other used for stretching, and a bandage contact lens was placed. Thus, with proper handling of the situation, one can have a very good outcome in a case of flap striae. Thank you.
So I showed you a case of.
You showed it, but we are going to review it. Excellent presentation. Thank you very much. It is something very excellent presentation you have given, and we have gained new insight in it. Thank you very much.
Actually, sometimes the patient squeezes the eye and they are not agree. They don't agree. They say that I have not done anything. But the next post-op day, we see the striae. Sometimes the patient goes home and then comes back with less vision and we found a striae. Sometimes I have a case in which the patient had undetected dystrophy, and it was a subtle Bowman's membrane dystrophy, and it got remained undetected. We did LASIK and we found post-op first day a subepithelial plaque, and we were very confused whether it is a subepithelial plaque or it is something at the interface. When we did OCT, we found that it was nothing to do with the interface, it was subepithelial. Then we diagnosed it at a loose epithelium and we took the patient to the OT, removed all the epithelium. And most of the time, this flap striae are cured by de-epithelialization, epithelial debridement, hydration, and stretching. Most of the striae goes by hydration only, and hardly we need any suturing unless and until flap is amputated. And PTK is needed. I have not done any PTK, but just by flap epithelial debridement, hydration and suturing, it's okay. So thank you.
if there is no central striae, it is not affecting the vision. Should we still go and correct it?
If it is not affecting the vision, that means it is a microstria. So microstria you can wait, but because if it is not affecting the vision, you should not touch it. But if it is affecting the vision, the patient is complaining, that means it is you have to intervene. And as early as you intervene, the result is better.
Okay.
Ma'am, can I ask a question?
Yes.
Sir, is Dr. Rajesh sir here?
नहीं वो तो चला गया.
I'm here. Yeah, it was a
Sir,
presentation and very good voiceover, Nidhi. It was very impressive.
thank you, sir. Sir, I wanted to ask.
We एक minute. I'm thankful to Rajesh also. So I have made one more video of the post of loose epithelium and flap striae. I have not shown that video here. So I have taken help of the consultancy from Rajesh. All advice.
We always learn from each other.
And we managed. The patient is 6x6, Rajesh, both the patients.
Yeah, that's fantastic.
So the other patient video, in which we had loose epithelium, we have kept that patient.
Yeah. That is reserved for some other meeting.
Yes, scarce.
Yeah, Nidhi.
Sir, I wanted to ask.
Very good.
So many a times when we are removing the epithelium, the flap is not that stable. So even in this video, when we were trying to debride the epithelium, the flap was moving too. So sometimes we do use the J stick, how we use it for debridement in PRK or maybe in C3R as well. So what is the best way to remove the epithelium? Is there any other instrument that you would prefer after using the alcohol to debride the epithelium in such cases? Because the flap was getting lifted when we were trying to scrape off the
Actually, we were supporting it through that blunt rod, because the flap was the Vikas flap was very thin, and both the flaps after debridement became very thin, and even when we were debriding, it was very fragile. So I was supporting it with the blunt. So otherwise, the epithelial debridement most of the people do by J stick.
Yeah, that is also one thing. The other thing
Yes.
is used alcohol for sufficient time, the epithelium becomes very loose.
वो जा नहीं रहा था actually.
Can use a simple dried Miracil sponge also, and that will just remove the epithelium completely.
Actually, epithelium, the loose epithelium case, even without alcohol, it was coming out, peeling out like a sheet. But the Dalgovin case, the other case, that case also we discussed with you. In that case, some of the epithelium was not coming even after applying alcohol twice. And the Vikas case.
Sometimes the concentration of alcohol or other things.
So, kitna alcohol? 30%, 20%, kitna 60%?
No, normally we should use 20% for 25 seconds. Kabhi
नहीं हो रहा था second case.
Then maybe you can use it for longer period, like for 30-35.
And ये blunt rod से support देना पड़ रहा था, because flap बहुत fragile था.
हाँ नहीं, अगर
वो चला आता हाथ में, hinge से चला आता.
In vast majority, you can do with simple Miracil sponge itself if you have used alcohol. But अगर नहीं निकल रहा है, तो you can support, as you said, you can support the hinge with one instrument and then use the J stick so that you can debride the epithelium. I very nicely pointed out one thing, that we should always debride the epithelium outside the edge of the flap, so that by the time that part starts healing up, the edge apposition is quite good, so that you don't have an epithelial ingrowth.
And I have one more question.
Highlighted in this video.
Yeah, I have one more question. Like, there are 5 methods, but usually flap debridement, epithelial debridement, hydration, and stretching is sufficient in at least in our cases. I have one question. Like, in one of our cases, you also know that Vishal Raj, the flap was amputated. So the flap was amputated, and it was so thin and fragile and flap striae that when we did suturing, we could not bury the suture. So has it happened with you any time that the flap is so thin and fragile that you are unable to bury it?
Actually, touch wood, this thing has not happened, but it can happen with anyone. But this thing has not happened with me. Sometimes what happens that if you have a double kind of, if you have an intact, all 360-degree intact flap, then you just reposition it. And if you have marked it properly, then you can align the flap properly along the mark, and then dry it for a prolonged period and put a bandage contact.
उसको alignment we did with the shape, and there was very small epithelial defect, very small. Could recognize that this is the epithelial side, this is the stromal side. Otherwise, the other method is just by fluorescent staining.
Yeah.
The fluorescent staining, the epithelial side does not take a stain, and the stromal side takes some diffuse staining. Am I right? तो वो उस समय में उसका एपिथेलियल डिफेक्ट छोटा सा था तो पता चल गया, लेकिन समटाइम्स व्हेन द एक बार मेरे साथ हुआ, बट वो विशाल राज का केस, बट द एपिथेलियम वाज so thin that sorry, the flap was so thin that the suturing was very difficult.
See, in a very thin flap, suturing will be difficult because
and वो बरी तो नहीं हो रहा है, बरी होने से वो चीज वायरिंग होता,
that will cheese wire. Yeah.
किया था, उसके ऊपर कॉन्टैक्ट लेस लगा दिया था.
The best thing is कि उसको आप align करके, instead of putting a suture, you just edges for a prolonged period and put fibrin glue at the edge.
अच्छा.
So that will be more useful.
अच्छा. ग्लू लगा करके नेक्स्ट टाइम गॉड फॉरबिड कभी नहीं हो, बस ग्लू कॉन्टैक्ट लेंस लगा देना है. So glue is better than this. At least it will prevent the complication of cheese wiring. ठीक है. So अब तो सारे के सारे लॉगिन करके चले गए, तो डॉक्टर कश्यप का वीडियो हम ही लोग देख लेते हैं. डॉक्टर कश्यप,
मैं डॉक्टर कश्यप का वीडियो देखने के लिए बैठा हुआ हूँ.
हाँ, गुड. डॉक्टर कश्यप का डेली कुछ ना कुछ अच्छा.
Hi, good evening, friends.
हम लोग भी हैं.
Sleeping friends.
अच्छा.
After lunch friends coming back from the tea. I'm going to talk about a case of injury. In injury, what my policy is, keep all the armamentum ready because you may have to tackle anything. So this is one such case of perforating injury. You can see the iris prolapse, the evil tissue prolapse, the scleral coil perforation, traumatic cataract. And now start my video. So first of all, I had to correct the evil tissue prolapse by properly doing the peritomy. I did it cast video and then I stitched the sclera. The moment I saw that the eye is tight, then I put a lifeline. You can see the irrigation line there. It is very, very helpful. You never know what time you have to increase the intraocular pressure or have to do a little bit of vitrectomy. So after doing this repair of iris tissue, there was a little bit of a hydrodialysis as well. So made the main incision. Side port, taking care that I do not injure the lens. And after injecting the air with the help of trypan blue, I put an iris hook there because the people who was coming into the field. With the help of the trypan blue, I completed the rhexis. fairly larger rhexis. And then I proceeded for lens management. The lens was quite soft, the catheter was quite soft. During this phacoemulsification, I had a little doubt with that there is some amount of subluxation and dehiscence of the capsule. So I put a capsular hook. So one iris hook was there. This is capsular hook. One more capsular hook to stabilize the capsule properly. And then irrigation aspiration is done. There was a little bit of iris prolapse through the main incision. That didn't matter much. And then I'll be putting the CTR. Before CTR, I removed the capsular hook so that the distal end of the CTR does not get entangled with the hook. There are many ways to put the CTR ring inside, not the distal but the proximal one. You can use the forceps, you can use the Sinskey hook, you can use both, or you can have a preloaded CTR. In this case, I have used the forceps. To put the CTR ring in the bag. Now there is aerodialysis there. So after putting the CTR, we have inserted the 3-piece IOL. You have to be very, very careful because the proximal end of the haptics might create problem and it may not open properly. And then I use a trocar cannula to repair the iris. This is a new method prescribed by Dr. Amar Agarwal and Dr. Rohitam Prakash. So this cannula is used to insert the needle and hook the iris and go up to the sclera. And at the scleral end is a groove. Now the other end of the same stitch is again inserted, entangle the iris and came out to the groove of the sclera and then tied the knot there. Now final irrigation aspiration is done. The lens is stable, air injected, and the conjunctiva peritomy is stitched. That's the end of the surgery. Thank you.
Nice, beautiful presentation, beautiful video.
Beautiful, sir. Beautiful. Thank you. Thank you.
ये पोस्ट ऑप रहना चाहिए था, पोस्ट ऑप भी लगा लीजिएगा.
The patient was taken up for the second surgery and we had done the SFT for people repair and the patient got 6/9 vision. Very, very satisfying.
Well done, sir. Well done.
Thank you, sir. Thank you.
Beautiful.
Wonderful.
Single case, so many actors, so many maneuver.
Yeah. You have to put the CTR, you have to put the caster hook, you have to put the iris hook, you have to repair the, you have to put the lifeline, that is irrigation aspiration trocar cannula, and normal cataract surgery, yes.
तो फिर उसके later on the patient went for second surgery, SFIO?
No, the second we have put the multiples IOL here, and then the second time we have just done the pupil repair by SFT. So the pupil is further constricted, and the vision is 6/9.
तो मेरे को लगता है कि दोनों सर्जरी को जोड़ देना चाहिए था.
नहीं जोड़ा इसलिए नहीं, because we had repaired the iris, and the moment you make the pupil small, they'll be stretched at the iris root area, and then it may redetach from the, it may do the dialysis again. So I did not do it in the same sitting.
No, I am saying that you should have दोनों वीडियो को ऐड करके एक वीडियो बना सकते हैं.
Yeah.
दिखा सकते हैं after doing the second procedure.
उसके बाद सेकंड सर्जरी बना दिया और अब ऐसा था.
Sometimes it's helpful if you do sequential rather than doing everything at a time. It becomes messy. So I think that was a good idea.
नहीं वो तो सही है, लेकिन वो सर्जरी में वो दिखा देते कि सेकंड सिटिंग में ये किया, एंड दिस इज द प्री ऑप एंड दिस इज द पोस्ट ऑप आफ्टर द सेकंड. क्योंकि वो तो बहुत अच्छा हो गया होगा. आफ्टर द विजन इज आल्सो 6/9.
Yeah, 6/9. The patient very happy. The only thing is
you want to combine two videos in a single presentation.
But he can show just 20 seconds. And 20 seconds, and then pre-operative the patient slit lamp photo, and then the final post-op after that second sitting. So it will make a very good impact.
Yeah, you are correct. Yeah.
Anyway, beautiful presentation.
ये वीडियो बहुत अच्छा है. It's very nice video.
So the main idea was to show you the new technique of trocar cannula, which is recently introduced by Dr. Amar Agrawal and Dr. Rohitam Prakash. So I thought to show it to you.
इसमें double-sided needle है.
Yeah, it has got two needles. So one needle is passed initially, and then this other end was passed. And why trocar cannula? Because the cannula length is, beyond the center of the eyeball. So the piercing of the iris it becomes very easy. Otherwise, if you take just the needle, so needle keeps on little, even if it bends a little bit, it will be difficult to aim at the place where you want to put the needle in the iris.
तो ये sclera में flap बनाया क्या?
Sclera में there was a groove.
अच्छा.
There is a very edited video. So I made the groove at the sclera wherever I want to come out.
Okay. Very nice, very nice. So now over to Dr. Utpala. She will show some magic steps for topical phaco.
Hi, Utpala. Good evening.
Hi. Screen share करो.
चलो screen share करो.
Slash. Okay. I'm good. Can you hear?
Yes.
Moving to topical phacoemulsification. My pointers for smooth transition. Advantages of topical phaco to the patient: quicker visual recovery and rehabilitation, better post-op cosmesis. You don't have ptosis and periorbital ecchymosis. Can avoid the pain of anesthesia or peribulbar block. Consecutive day clinic visits avoided. Advantages to the surgeon: can operate upon normally pressurized eye. Hypotomy due to over-massage or tight globe due to retrobulbar hemorrhage can be troublesome. Peer pressure to stay in the race. Some patients may request it. Starting the case. Patient should look straight into the microscope light. Since proparacaine will numb the corneal nerves, this will not elicit photophobia. Avoid topical phaco in small pupils. IFIS may require pupil dilating devices. Comorbidities like corneal opacities, post-uveitic eyes, subluxated lenses may require CTR, etc. Repeat surgeries. Counseling. Do not tell the patient that there will be no pain. Tell them, I will feel numb and touch sensations can be appreciated. They may experience a sense of pressure due to ciliary body stretch that may be slightly similar to moderate pressure with a finger on the eyeball at certain times during the procedure. Special precautions to be taken during the procedure. Eyeball fixation should be gentle yet firm. Patient can move and squeeze his eyes. Topical numbs pain. Patient can feel temperature and pressure. For cotton ball fixation, eyeball should be dry. For tooth forceps colibri, hold should be superficial and very gentle pressure only. How to keep the cornea moist? Do not put drops of BSS on the cornea to moisten it. Patient feels the drops and this will elicit a squeezing sensation. Gently apply viscoelastic over the surface of the cornea to moisten it. Do not overfill the anterior chamber. Two exceptions to this rule. Exception number 1, when you are performing a capsulorhexis, where you need a well-formed anterior chamber to flatten the anterior capsule. Exception number 2, while implanting the intraocular lens. Underfill the anterior chamber during entry with the phacoprobe or IA cannula. Patient will feel the sudden distension of the AC during entry due to ciliary stretch. Always enter with low bottle height and then increase to your regular settings. Inside the eye, once both the instruments are in the eye, you are good. Mobility is totally under your control. It is only during the initial stages of creating the incision, capsulorhexis, and hydrodissection that eyeball fixation is very important. Hydrodissection. This is crucial. Hydrodissection should be complete. Trying to rotate the nucleus with improper hydro will induce pain due to zonular tug on the ciliary body. Always ensure the nucleus rotates well before embarking on topical phacoemulsification. Nucleus disassembly. Techniques of nucleus disassembly is totally up to you. You can do stop and chop, direct chop. It does not actually matter. Supportive anesthesia. Intracameral lidocaine is optional. Proparacaine will pass transcorneally and transclerally to anesthetize the eyes. Precautions. Avoid engaging or touching the iris. Perform viscofluid exchange before coming out to prevent sudden shallowing of AC. This will cause the patient to experience certain amount of discomfort. Ending the case, finally, make sure that there is adequate water tightness of the clear corneal incision and side port incisions before you close up, because this patient will not have a protective patch. Finally, end the case with intracameral moxifloxacin. Thank you and good luck for topical phacoemulsification. Thank you.
Very nicely illustrated, Dr. Utpala.
Thank you, sir.
She does also.
There are two things. There are two things. Number one, that you are doing topical. The other point is patching or not patching.
Yeah.
So patching gives the patient quite a relief. It makes him comfortable. So you may patch it for an hour or 2 hours or so, but patching is better.
Okay.
Because the patient's eye anesthetized, and if you do not do the patching, take my words, the patient will have a dry eye after some time. For 5-6 hours, it will be a dry eye, and that is dangerous. So it is good to do the patching for some time. Do you agree, madam?
Yes, I'm just watching. सब चले गए.
Dr. Do you use midazolam? Because the patients under topical are quite apprehensive. And there is a discussion on midazolam on sometimes back. Do you use midazolam preoperatively?
No, I don't use anything preoperative.
So for the patient who are little apprehensive, what do you do?
My patients, I talk to them, I counsel them, and they're very happy with me. Like almost, I'm not for many years. 1 year I've been doing only topical. And I'm not, I do block only for when I'm teaching my DNB students to do the case, then, or very hard cataract when I'm switching to SICS. I'm not doing fake. When I'm not doing, I'm not giving up. And my
There was
patients
discussion in the morning that there was a claustrophobic patients. What do you do with the claustrophobic patient?
faced any claustrophobic. Otherwise, we are doing vocal anesthesia. We talk to them and they're very happy. And then they are good for topical. Seriously, you can ask. I'm not doing for the almost 1 year. I've not done any phaco with block, and I'm very happy.
You know what? When Dr. Utpala talks, सबका कान खड़ा करके उसी को सुनते रहता है, बाकी कुछ नहीं सुनता है. When they know that Dr. Utpala is
और वो
talking,
भी
they
तो बताओ
listen
कि
to her.
तुमने कितना दिया जालोकेन. तुमने कहा था ना, like people say 2-3 times, but ऐसा नहीं है कुछ. प्रिपेयर करती है, तुमने वो सब नहीं दिखाया. How the nurse prepares.
And all that. I was told, 4 times prior to surgery, and many times sister will have to take it in the cannula. They have to give it during surgery. But now I think they are good. My patients don't move their eyes, and whatever they move, I can manage. I can manage, and any kind of complications also.
You said that your sister starts preparing and she gives more than what they advise, but nothing happens.
No, I said before we start the case, they load it in the tropical plus and paraquat. And then almost around 4 times I think they are giving every 15 minutes, 4 times. And then during surgery also, if the patient is moving, then they are giving, otherwise they are not. Even last, like whatever recording was done on Friday, and the patients did not move at all. And we were very good.
Utpala, you are a temporal surgeon or 12 o'clock position surgeon?
I've said for a long time. I don't go at 12 o'clock. I'm all and all through temporal.
सुनो, अब फास्ट करो. ये कॉन्फ्रेंस वेब कॉन्फ्रेंस ऑर्गेनाइजर का फोन आ रहा है.
Yeah, we have got a very important topic also, Dr. Pooja.
Yeah. So Dr. Pooja, she is the gold medalist and the best awarded best junior resident in RP Center AIMS, and she has done her 3 years SRship senior residency in cornea from RP Center AIMS. And this topic basically we kept for the PGs, but hardly I can see any PG. So the topical anesthesia ways to achieve the goal. Slit lamp examination techniques, Dr. Pooja. And Dr. Utpala, please tell the PGs to join. Dr. Utpala bhag gayi.
Good evening, ma'am. Am I audible?
Yes.
Yeah, very much. Yes.
Okay, thank you so much, ma'am, for giving me the opportunity for presenting on this platform. So after hearing all the wonderful lectures, I'll take all of you back to basics on slit lamp examination techniques. So what is slit lamp biomicroscopy? This is basically a dynamic examination of the living eye and ocular adnexa. It is basically a misnomer since slit is only one of the various diaphragmatic opening which is present in the instrument. And this is an important examination tool for ophthalmologists to visualize eye in 3 dimensions. So why do we need a slit lamp? Because of the very small structure of the ocular structures, which can't be visualized by a torchlight examination. And to make out relative position of a lesion, it needs oblique illumination and need for magnification is required, and also gives binocularity. Little bit about history of slit lamp. It was first described by Purkinje, who applied microscopy to a living eye, and he basically studied the iris with adjustable microscope. Then later on, it was Louis de Wecker who invented uniocular slit lamp, which he combined with an eyepiece objective and a condensing lens within a tube, which was further modified by Zapsky, who added binocularity to the microscope. We all know that Alvar Gullstrand, who was a Swedish ophthalmologist, he got Nobel Prize in Physiology and Medicine in 1911 for dioptrics of the eye, and he gave the basic design of a slit lamp. Later on, it was Henker and Vogt who improved upon Gullstrand's device in 1911, and it was combined by Zapsky's microscope, and Gullstrand's slit lamp illumination was invented. Coming to parts of a slit lamp, so basically it has 3 systems: illumination system, observation system, and mechanical system. So illumination system, we have a light source, which is a low voltage incandescent lamp or a halogen lamp. So based on these illumination system, we have two type of microscope, which is a Hackstreet type of design and a Carl Zeiss type of design. So in Hackstreet, you can see the illumination arm is placed above, and in Carl Zeiss, the illumination is placed adjacent with the eyepiece. So this is a basic design of a Hackstreet microscope. So this is an illumination system. Then we have a headrest, then followed by chin rest, and mechanical system includes a joystick, and observation system includes the eyepiece. And below the table, we have a power unit with which you can switch on and off the microscope. Now I'll discuss each system one by one. So first, coming to observation system, which is used for basically magnification. So this one has a 5-step magnification, which has 6.3, 10, 16, 25, and 40x of magnification. Coming to observation arm, so here you can see this observation system has two lenses, and on these lenses, one mark has been given. So this has to be set at 0 for emetropia, but if you have any refractive error, you can adjust your refraction and you can visualize without glasses also. So these with these two eyepieces, you have to adjust your interpupillary distance for getting the best binocular vision. Coming to mechanical support, so this is the joystick. With this, you can move the slit lamp forwards, backwards, and sideways. Coming to positioning of the patient, this is very, very important. In this slit lamp, we have a canthal alignment mark, which is present over here, this black mark, which should be coinciding with the lateral canthus of the patient. So this basically gives the proper alignment of the headrest and chin rest. Now, there are certain special situations in which patient can be a bit uncooperative, especially in elderly patients and pediatric patients. So pediatric patient, we can use this kind of method. We can put a stool and the child can fold his legs and hold the slit lamp, and we can place him like this. For elderly who cannot walk, so we can directly place the wheelchair over against the microscope and we can support the patient. Coming to slit lamp width, the width of the light can also be managed with a knob, with a knob which is present at the end of the illumination system. So here you can increase and decrease the intensity of the light. Scale of slit diaphragm, on the below the illumination system, we have a reticule in which millimeters of scaling has been given, and here you can actually measure the lesions present over the cornea or any ocular structure, which will be very helpful in following up of the patient. So for us as a cornea surgeon, it is very, very helpful for measuring the corneal, the size of the ulcer and height of the hypopyon, along with the size of the epithelial defect, etc. Now, within the illumination system, this entire system, you can move forward to visualize the vitreous. So you can just tilt forward and you can get a better view of the vitreous, anterior vitreous phase, and you can also see vitreous cells also very easily. Coming to various filters, it has white filter, gray filter, red-green filter, diffuse, and cobalt blue filters. So below the reticule, there is one structure here. Various filters have been given. So this can be used according to the lesion, whatever we are visualizing. So before starting the procedure, first of all, you introduce yourself and explain the procedure to the patient. And you have to adjust the height of the slit lamp according to the patient height. Adjust the chin rest, make sure the patient is comfortable. He has sit comfortably, never stand and examine the patient. You have to always adjust the IPD and focus according to your refractive error. Start with first low illumination, and then only you increase the illumination gradually, which will be comfortable for the patient. And gradually you have to increase the magnification. And similarly, you have to do this procedure slowly. And at the end of the procedure, you always turn off the illumination, make it comfortable for the patient to get up, and decrease the height of the chair, make space by moving the table housing the slit lamp out of the way. Along with this, you can also attach the slit lamp with the slit lamp photography and videography also for better documentation purpose. Now coming to illumination techniques, basic illumination is divided into diffuse and focal illumination. So I'll discuss one by one. Coming to focal illumination, it's further divided into direct and indirect. And under direct, we have parallel pipette, optical section, conical beam, tangential, and specular reflection. Under indirect illumination, we have proximal, retro illumination, trans illumination, and sclerotic scatter. Coming to diffuse illumination, this is the most commonly used illumination while examining slit lamp. In this case, intensity of the light is kept maximum and angle is at the 30 degrees. So this is the observation system, this is the illumination system. So the angle between observation and illumination is around 30 degrees. Magnification is kept minimum, and filter, diffuser is used for examination. So I'll just show you. So this illumination is used for gross overview and lid and conjunctival lesion and overview of the cornea. So this is a diffuser which is present in the slit lamp. So here you can see, this is the diffuser which is present. So it basically diffuses the light and gives a diffuse image of the ocular structure. So here you can see this is a mass of OSSN which is seen on the diffuse illumination, and this is the case of corneal ulcer. We can examine the bleb also by diffuse illumination. Coming to direct illumination, first is parallel pipette. So what is parallel pipette? So here we are taking the width of the beam is around 2 to 4 mm. And intensity is kept at maximum, and angle between the observation and illumination arm is around 30 to 45 degrees, and magnification is kept moderate. So this is basically used to examine the size and depth of the lesion. So this was a case of corneal ulcer. So here you can see we have made a parallel pipette kind of beam, and here we can see the ulcer is quite deep in the cornea. So it's easy to visualize. So in this case, you can see prominent corneal nerves. Next is optical section. So optical section is same as parallel pipette, but the difference is that the beam width is very thin, that is around 1 to 2 millimeters. And rest of the parameters are same. The intensity is kept moderate. Angle is around 30 to 45 degrees between observation and illumination arm. And magnification is also kept moderate. So this is basically an optical section of the cornea. So here you can visualize all the layers of the cornea and detailed examination of the cornea, depth and size of the corneal lesions. You can examine corneal edema, any thinning, ectasia, anterior chamber depth, and you can also grade the cataract also. So here on this left side image, you can see the grading of anterior chamber has been done. So here you can see the first image, the anterior chamber is very, very shallow. And the third image, the anterior chamber is Van Herrick's around grade 4. In the next image, here you can see there is hyperreflectivity at the level of endothelium. So this was a case of viral endothelitis. And in this image here, you can see these are the folds of DM detachment. So it can be best visualized on optical sections. Similarly, grading of nucleus can also be done by using this illumination. The LOX grading can be done very easily. Coming to next, conical beam. So conical beam, this is in this method, the beam width is kept very minimum, that is 1 into 1 mm, and magnification is kept maximum, and angle between illumination and observation is around 45 degrees, and intensity is kept maximum. So this is basically used to measure, to examine anterior chamber cells and flare. So here you can see this is a thin beam of around 1 into 1 mm, and it is focused in the mid of the anterior chamber. So you can see a Brownian effect in the anterior chamber, which will denote the anterior chamber cells and flare. Now coming to tangential illumination, this is what is tangential illumination. Basically, you have to keep the angle more than 45 degrees. So in the previous illumination types we saw, it was mostly between 30 to 45 degrees. So if you keep more than 45 degrees and your beam width will be parallel pipette, so you can actually see the texture of the surface. So this is basically used for examination of pseudo exfoliation over the lens capsule. So here in this first image, you can see the pupillary rough and at the pupillary surface. And once you dilate the patient, you can actually visualize all the zones of the pseudo exfoliation. So this is best visualized by tangential illumination. Now coming to specular reflection, this is very, very important for all cornea specialists. So this has come from Latin letter specularis, which means mirror-like. So specular reflection is the reflected image of the light source itself. It is based on the principle Snell's law of optics, which states angle of reflection is equal to angle of incidence. So the brightness of the reflection depends on the reflectivity of the surface on which it is seen. So in this reflection, first thing you have to remember, your angle between observation and illumination arm is around 60 degrees. It means you have to make a right angle, and with the right angle, your observation and illumination will be 30 degrees each. Your beam width will be parallelepiped, magnification will be high, and intensity will be maximum. So this specular reflection is used to visualize the corneal endothelial layer. So here you can see the endothelium at the lower magnification, and here at the higher magnification. You can actually visualize the mosaic pattern of the corneal endothelium, and it's very easy to pick up various abnormal pathology of corneal endothelium, such as any pigment deposits or heterogeneous cells or guttae. Here you can see guttae. This is collagen excrescences, and beta and metal appearance can also be visualized on this specular reflection. Now coming to indirect illumination, just first is focal. In this, we have proximal illumination. So here, what we can do is, here one lesion is there which is adjacent to the cornea, somewhere around the conjunctiva. So if you want to visualize this lesion very clearly, then you have to use this proximal illumination. So what you can do, you have to keep the angle again at 30 to 45 degrees, intensity will be maximum and magnification will be moderate. So I'll be discussing, you have to keep the intensity of the light adjacent to the lesion, so the lesion will be, the lesion becomes more prominent. So here you can see this patient, he has a conjunctival nevus. So this is seen on a diffuse illumination, but if you keep the lesion, if you see the lesion on proximal illumination, you are shining the light adjacent to the lesion, so you can see the lesion has become more prominent, and actually you can see the conjunctival cyst within the conjunctival nevus. So this is very, very helpful in differentiating from a benign lesion with a malignant one. Now coming to retroillumination techniques, we have iris retroillumination and fundus retroillumination. So first, iris retroillumination. What is iris retroillumination? So here we are incidenting the light against the background of the iris, and with this, the light is reflected back, and whatever the structure is in front of the iris, that becomes prominent. So any corneal lesions which is present any corneal lesions, it becomes more prominent. So here also the angle is slightly decentered, and beam width is also parallelepiped, and maximum intensity we have to see. So any fine corneal structures such as vacuoles or epithelial edema or any vessels such as superficial or deep stromal vessels becomes more prominent. So here you can see with iris retroillumination, the vessels have become more prominent. And in this case, there are fine pigments which are present in the form of Krukenberg spindle, which is seen in the case of pigment dispersal syndrome, has become more prominent. Now coming to fundus retroillumination. So here also the beam is very short, and you have to incident the beam from the pupil, which gets reflected back from the retina, and magnification is kept moderate. So any pathology in the lens or any deposits, any lens pathology can be picked up very nicely with this fundus retroillumination. So this was a case of PCO, which has been seen very nicely. Now coming to iris trans-illumination. So what is trans-illumination? Basically, you have to... Yes,
please
sir.
sum up, Dr. Pooja.
Yes, sir. So in iris trans-illumination, this is basically seen in iris defects, pigment dispersion syndrome, and we have to check the PI patency also. So here you can see this is an ocular albinism, and along with this, iris defect can be seen very nicely. Coming to sclerotic scatter, so here we have to focus the light at the limbus, which causes total internal reflection along the outermost and innermost layer, and whatever lesion is present over the cornea becomes more prominent. So this is easy to differentiate from a scar to the infiltrate. So these are the examples. In the second image, we have applied sclerotic scatter. We have special filters like cobalt blue filters, which is used to examine the epithelial defect, and we can do the Stedel's test also to examine the with the help of this filter. This is a positive Steedle test, and we can also use special dyes also, such as rose Bengal stain and lissamine green stains. Additional uses is that it can be used for Goldman applanation tonometry, contact lens fitting, fundus evaluation, and anterior chamber assessment along with gonioscopy. It can also be used for corneal scraping, suture removals, AC reformation, bleb needling, toric marking, gonioscopy, and examination of the donor cornea. So this is a special thing. In this slit lamp, a special device has been attached in which the donor cornea has been kept in the media. So with this, we can actually grade the cornea and we can predict the outcome of the cornea. So we can grade it as an optical therapeutic, and if the cornea is not suitable for surgery, that can also be visualized very nicely. So these are various examples. So conclusion is, it is an indispensable method for the complete ocular examination. It has interplay between illumination and observation, and a skill that must be perfected. The more we use it, the better we become. So thorough knowledge and repeated practice is required, and it's a key for being a good clinician. Thank you so much.
Thank you very much, Dr. Pooja. I think we are moving towards the last speaker, Dr. Jayanti Kashyap.
Yes, thank you, sir. After a wonderful whole day presentation by Galaxy of Speakers, I would like to thank Jhos for giving me this opportunity. I hope I'm audible.
Absolutely, yes.
Very much.
Yes, sir, because it's raining heavily here. I don't know. Yeah. So I will be talking on neuroimaging in ophthalmology from a general ophthalmologist point of view. So according to the father of neuroophthalmology, neuroimaging is that subspecialty of ophthalmology where diagnosis is made upon the reinterpretation of alleged normal scans. And hence we should know at least the basics of neuroimaging. So from a general ophthalmologist point of view, neuroimaging in itself is a complex topic, but it has been revolutionized by the current advanced imaging modalities, and the yield is optimal only when the ophthalmologist and the radiologist collaborate in the workup. So the question arises, why to order, what to order, and when to order. So often in a busy OPD setup, either in government or in private with lots of common cases, we often tend to get confused what to write whenever such cases arises, CT or MRI. We have a tendency to straight away refer to the higher center without doing a proper workup. And sometimes patients may not get very convinced that whether it is urgent or not. So we should at least try to work up and guide the patient. And we also have a tendency to look at the reports instead of the film. So coming to the errors in neuroimaging, there are two types of errors, the prescriptive and the interpretive errors. So we can do prescriptive errors like failure to obtain correct study, omission of intravenous contrast or specialized sequence, which I will discuss later. And the interpretive errors like misleading clinical information and low sensitivity of images. So I will quickly rush to the common imaging modalities, the pitfall and the common clinical condition. We have this gamut of imaging techniques nowadays, ranging from CT, MRI, and the various advances like FLAIR, diffusion weighted imaging, and the CT and MR angiography. So starting with CT scan, this is basically a modification of the X-ray. Like in X-ray, we get 2D images, but in CT scan, we get 3D because in reality, we are not 2D, we are 3D. And this is done with the help of multiple array of detectors. And these detectors, they give images in form of black and white. And based on the different attenuation of different tissues based on their density, we get like these images of black and white. And these are scaled by Hounsfield scale. And where bone, it is the most denser, it is the most white, and it has given the Hounsfield unit of 1000. And air filled structures, these appears black, and water has isodense, means it's neither darker nor lighter. So disadvantage of CT scan includes radiation, contrast, allergy, and osseous artifacts. And advantage, of course, includes is less time, less expensive, and useful in cases like pacemakers, foreign bodies where MRI is contraindicated. So indications, mostly in cases of any trauma, when we have to look for pathology of extraocular muscles like thyroid disease, pseudotumor, to know the extent of tumors, calcification, or vital cellulitis, and of course intraocular foreign body. So briefly, I'll discuss the basic points. So whenever we request for a CT scan, slice thickness is something which we should all know, because the normal CT scan, they do 10 millimeter cuts, and the person who does this CT scan is a technician, he is not a radiologist. So unless we mention, and in ophtha routinely we need 2 millimeter cuts. So we have to specifically mention 2 millimeter cuts, otherwise a pathology of 6 to 7 millimeter may be missed. And in cases where we are so this, you can see a plain CT where we can see a tumor, and In cases of when we give the contrast, it has enhanced, so we can know the vascularity of the tumor and helps in proper planning. Imaging plane, so this is the Reed's line, any line passing through the inferior orbital rim to the external auditory meatus. This is the Reed's line. Any line parallel to this is the axial scan, and any line passing 70 degree to this is the coronal scan. So one thing we have to remember that in CT scan, we routinely get only axial scans. And so in specific cases, we have to ask the coronal and sagittal because they have to be reformatted. So coming to the tissue window, bony window is one such thing which we should remember. So this is the normal axial CT scan, and which we can see that along with the bone, the soft tissues, the lens, they all appear of the same density. So if we request for a bone window, the soft tissues, they are suppressed. And so we can only see the bone, and we can look whether there is any bony defect or so. Simultaneous brain CT in cases of any RTA cases or other cases, we know special brain CT, we can order for simultaneous brain CT along with orbit CT. And special techniques like we should be aware, like in orbital varices, if we simply write orbital CT scan in supine position, the orbital varices would not be aware. So we have to mention and talk to the radiologist that while performing Valsalva maneuver, we have to do the orbital CT. So normally we don't get a single image, we get a series of images like this. And so this is the axial CT scan, and the images, they are arranged from bottom to top. So the first film is the scout film, and for general purpose, we can identify lens as the section of the mid-orbital plane. We all know lens and the optic nerve, and we can see few sections above it and few sections below it to have a gross view of the. So these are the coronal scans, and we have to ask for them because they have to be reformatted from the software. So coming to the practical example, so all in cases of optic canal fractures we can see, and as I said before, we have to specifically ask for coronal cuts because in axial scan, these small subtle fractures will be missed. Also, we should specifically write CT brain and orbit non-contrast with thin cuts, as I mentioned earlier, because if the technician is not trained, then we may miss. So in cases of like we can see this teardrop signs, it is herniating into the maxillary sinus, and so these are the practical examples. We should also ask for volume rendering techniques. So these we have to time communicate with them. And so these are helpful if you are planning surgery, and we can easily see the 3D reconstruction of the images. So whenever patients come and presents with bilateral proptosis, we know the most common diagnosis is thyroid, but sometimes the thyroid levels are normal. So we have to order a CT scan, and which we can see the enlargement of the muscles, bellies with sparing of the tendon. These are just coronal images in which we can see the enlargement of all the muscles. So ask for coronal images. Just a word from differentiation for pseudotumor, in which we can see the whole muscle is inflamed along with the tendons, and in this there is sparing of the tendons. Also, in cases of orbital infection, CT is important because it can help us sometimes to differentiate between preseptal and orbital. In this, we can see there is opacification of the septum and some air spaces, but these are limited only anterior to the septum. But in the second image, we can see there is gross opacification and it has spread. So this is the case of orbital cellulitis. Also, in cases of, we can see this collection along the medial orbital wall, but all appear similar density. So we can ask for bony density to bone window to see if there is any bony destructions. As I said, in cases of metallic foreign body, the MRI is contraindicated. So we must primarily order a CT scan because sometimes the patient is not able to tell the nature of the foreign body. So in this, we can, in the left side, we can see this hyperdense lesions. Sorry, in CT scan, we have to deal with density, and MRI, we have to deal with intensity. And which we can, in this also, in left side, we can see an elongated air containing foreign body. And so briefly, I'll discuss the MRI. So MRI is basically, it is based on the principle of rearrangement of positively charged hydrogen nuclei. So when we give the energy, they get elevated to a higher state, and when we release the energy, it comes back to the resting state. And this is measured in two sequences, this process of exciting and then coming back. So there are two basic sequences, the T1 and the T2, and the rest all newer modifications are just the better versions of this. So for in general, we can remember that in T1, it is better for anatomical structures and T2 for pathology. And how to differentiate? In T1, the fluid is dark, and in T2, the fluid is bright. So we can see the vitreous and the CSF, they appears bright in T2. And this is the normal T1 images in which the vitreous is dark. So these are few of the modifications of MRI in like gadolinium contrast, which we do in cases of tumor and inflammation. And also fat suppression is sometimes the fat gives hyperenzyme lesion. So it is suppressed to see whether there are any other pathologies. So flare, this is very important in cases of MRI because frequently optic neuritic patients present to us. So in this, we can see that this is the T2 weighted images, and CSF, they appears very bright. So we may not see the demyelinating plaques, which are helpful in multiple sclerosis to prognosticate and for other purpose. So we should specifically tell them to give flare sequences, and in this the CSF signal is they are decreased, and so we can see the plaques. So diffusion weighted imaging, these are newer techniques useful in ischemic strokes, and we can see the bed-shaped infarct areas. And FISTA and CIS, they are for newer techniques for cranial nerve pathologies. So indications, CT is used for gross pathologies like pathologies limited to orbit, bony structures. MRI, soft tissues like optic nerve sheath, meningioma, when we are subjecting pituitary tumors, in that we have to order an MRI. So these are the coming to practical examples. MRI is useful in optic neuritis to confirm the diagnostic to prognosticate. So we should specifically ask for contrast MRI brain and orbit with flare sequences to see the demyelinating plaques. So this is also an example of 45-year-old presenting with diminution of vision. This is the fundus picture. And on the MRI, T1 weighted, because the vitreous is dark, we can see a hyper-enhancing lesions, and we can see the optic nerve traversing through the lesion, giving the typical tram track appearance suggestive of optic neuroma. So order a contrast MRI brain and orbit whenever you are suspecting optic nerve meningioma. Just a word about optic nerve glioma. And I have seen meningioma, we can see the optic nerve traversing through the lesion, but in cases of optic nerve glioma, we cannot see the we can see the tortuosity and thickened optic nerve, but we cannot differentiate from the rest of the lesions. So when patients such visual findings with bitemporal hemianopia, we have to straight away order MRI brain with and with, we should mention particularly cellular lesion, because we can see this lesion extending into the supracellular space suggestive of pituitary macroadenoma. Just a word about ophthalmic emergencies. Whenever such patients presents with sudden ptosis with pupillary involvement, we can order a contrast CT and so as to rule out the posterior communicating artery aneurysm, and we can refer the patient and to tell them the need and the urgency for, otherwise it will be life threatening. So to conclude, we have to look for the film along with the reports, try to work up cases before referring to neurologist, and correlate clinically and proper communication with the radiologist. Thank you for your kind attention, sir. And thank you, especially Bharti ma'am, for giving me this opportunity.
Extensive, Jayanti, fantastic, very nice.
Thank you, sir.
The PGs have listened. So the CCL PGs, 10 PGs are there. So they are logged in. I have checked. They are on YouTube. They watched the slit lamp examination and neuro-ophthalmology. So basically this session was for them, but there was no time allotment. So I placed my video and Dr. Kashyap's video also. So thanks. So now vote of thanks by Dr. Mitra, and I have Dr. Rajmohan sir को भी बोला है. He was saying कि वो दिन भर बैठे रहने से आदत छूट गई है. तो सर बोल रहे थे कि जब काम करते थे तो 9 बजे से लेकर रात के 9 बजे तक काम करते थे, लेकिन अभी
Dr. Rajmohan sir is here.
हाँ, हम फोन किए.
He was here only.
हाँ, बोले कि अब अभी आदत खत्म हो गया. सुरेंद्र सर हैं, सुरेंद्र सर भी हैं, रजनीकांत सर हैं, राजीव सर हैं, प्रोफेसर राजीव सर, सब लोग हैं.
I think the President sir will say 1 or 2 lines, then I will proceed for the vote of thanks.
बहुत सारा बच्चा लोग है, पीजी लोग, बहुत सारा पीजी लोग है, सब सुना है.
Thank you very much, all the participants who are here today with us, and they participated very actively in the all the deliberations that took place, and it was really a very excellent, excellently organized by the chairman. We must give 3 cheers for Bharti Kashyap.
Thank you.
Very
I'm happy.
meticulously, everything was organized, and I must say that she is now going to be also the organizers of all the conferences that are scheduled in the state. And we are thankful to the esteemed faculty members and the viewers who have been with us for this conference. And I think I'm sure it will be a very fruitful learning for all of us. Thank
And
you
sir,
very much.
Sir,
And,
have you
Dr.
noticed?
Mitra, huh?
Sir, have you noticed that this time all the chairpersons, they participated very well and very actively?
You have been after them. You have been after the president. मेरा भाषणवा पूरा ही दे दी बोलो तो.
चार बार तुम राजमोहन सर को फोन किए हैं, रजनीकांत सर को 4 बार.
अरे
सुरेंद्र सर,
कोई बात नहीं है. It was very sporting of you.
हाँ तो क्या हुआ, तो करना ही है ना.
चलो, अरे कोई हम लोग में अच्छा फैमिली रिलेशनशिप है.
हाँ सर, वो बच्चा बोलता है कि मैडम रोल कॉल हो रहा है, तो अब भाई तुम चेयरपर्सन बनोगे तो तुमको छोड़ेंगे.
Let us have Dr. Mitra to say the vote of thanks.
Yeah. And I'll proceed to the vote of thanks. On behalf of all Jhos members and on my personal behalf, it is my privilege to extend vote of thanks to all the guest speakers who, in spite of their busy schedule, attended the conference and they given most valuable contribution in the interest of science and Jhos today, though it was a Sunday. My heartfelt thanks to all the guest speakers. All 20 speakers were excellent in their presentations and excellent in the timings also, to the point. Heartfelt thanks to Dr. Srini, Dr. Umesh, Dr. Madhu, Dr. Somsila Murthy, Dr. Vanati, M. Vanati, Dr. Gopal Pillai, Dr. Kasturi Bhattacharji, Dr. Saiban Sethi, Dr. Anaga Hirar, Dr. Medha Prabhu Desai, Dr. Ajit Hazare, Dr. Veena Nangia sir, Twinkle Shah, Dr. Samresh, Dr. Rahul Parekh, Dr. Sikha Gupta, Dr. Tejas Shah, Dr. Upsam Goel, Dr. B. Purnan Chandra, Dr. Rajesh Sinha sir. So I also thank all our Jhos speakers, session coordinators and chairpersons for their neatly conducting the sessions. I also thank Entop Pharmaceuticals for providing us the platform for the virtual conference today. Last but not the least, the people who are behind the scene for smoothly running the show. I know the helping hands of our CSC Dr. Bharti Kashyap in Kashyap Memorial Eye Hospital. And finally, you, all the audience, without whom the conference would not have been a success. Thank you all. Long live Jhos. Thank you.
And non-formally, I am thankful to really all these chairpersons and the session coordinators. Dr. Pritish, Dr. Rashi, Dr. Tanisha, Dr. Vibhuti Bhushan, ये सब जो सेशन में बहुत लंबा टाइम तक इंट्रोडक्शन वगैरह किया है, डॉक्टर डॉली टंडन सब बनाया भी है अपना.
राजीव बोस तो एक भी शब्द कहे नहीं है. तो
राजीव सर कुछ बोल रही है, सुबह से है. विभूति भी मेहनत किया,
पता नहीं चला आपका आवाज.
थोड़ा आशीर्वाद वचन दे दीजिए.
केवल आशीर्वाद वचन के लिए आए थे और लगातार देख ही रहे थे. I am very happy that things have gone so well. I can appreciate the energy level of Bharti. You are really genius. And Dr. Kashyap supports all the activities without shouting much.
but he should take me out for at least for 1 hour car
1 week, at least one week. For 1 week holiday.
Yes, Vibhuti Bhushan is saying. And मित्रा जी बहुत सपोर्टिव है, इतना अच्छा बोलते हैं कि मेरा सब दुख खत्म हो जाता है. बहुत अच्छा बोलते हैं, बोली बहुत अच्छा है. और ये है कि विभूति हम लोग हैं ग्रुप में कि हम लोग एक अगले साल एक स्विट्जरलैंड का झॉस का ट्रिप प्लान कर रहे हैं. That will be in the month of last week of second or last week of May. इसमें काफी डॉक्टर्स का हमें आ गया है अप्रूवल. डॉक्टर राजमोहन सर, डॉक्टर आनंद ठाकुर सर, सबकी फैमिली से, आनंद ठाकुर सर के घर से 5 पीपल हैं. डॉक्टर मित्रा के घर में एवरीथिंग गोज वेल, तो वो भी चलेंगे, श्योर है. विभूति भूषण है, विवेक केडिया तो शायद यूके जा रहा है उस समय. राजीव सर आपको भी बता देते हैं, हम लोग सब स्विट्जरलैंड घूमने जा रहे हैं. 10 दिन का ट्रिप है. रजनीकांत सर को भी बताया है. प्रीतिश तुमको भी बता देते हैं, अगले साल मई महीना में.
इसलिए अपना पासपोर्ट सब रिन्यू करवा कर रखिए.
पासपोर्ट सब रिन्यू नहीं वो तो बोली है कि ये अक्टूबर महीना से लग जाएगी. एक ग्रुप बनेगा, बिहार वाला लोग भी बोला है. लकीली डॉक्टर सुनील इज द लीडर इन द बिहार ग्रुप, और उसको भी अभी स्विट्जरलैंड का मूड बन गया, क्योंकि दे ऑल्सो वांट टू एक्सप्लोर यूरोपियन कंट्रीज. एंड सनी मेहता को हमने कहा है इसको बनाने के लिए. और नेक्स्ट ईयर अगेन मई में हम लोग आइसलैंड जाएंगे. दैट विल बी ऑल्सो अ 10 days टूर, क्योंकि 4
और
दिन
आपका पासपोर्ट जो है वैलिड रहना चाहिए. जैसे कि मान लीजिए जनवरी महीने में कहीं जाना है, तो पहले से लेके 6 महीना बाद तक का वैलिड रहना बहुत जरूरी है.
नहीं, वो बोलती है कि स्विट्जरलैंड वैसे नहीं मिलता है. बोलती है स्विट्जरलैंड का सबसे पहले आपका टिकट आता है, और उसके बाद
आपका पासपोर्ट के बारे में बोले. पासपोर्ट शुड बी वैलिड फॉर एटलीस्ट फॉर मोर 6 more months.
अच्छा, वो तो बताएगी, ग्रुप बन जाएगा. राजीव सर, प्रीतीश, रजनीकांत सर भी बोले हैं कि वो चलेंगे. प्रीतीश तुम भी चलना, बंगाली लोग तो ऐसे भी बहुत घूमते हैं. एंड आई विश कि डॉक्टर मित्रा का तबीयत ठीक रहे बाय दैट टाइम, एंड वाइफ आल्सो रिकवर्स फास्ट. राजीव सर आप भी चलिएगा.
भारतीय बजट बता देना पहले.
अरे तो सर ज्यादा बजट नहीं है. 80, आप इम्पोर्टेंट रखिए, मान के 80,000 रुपया का टिकट है, और 1 लाख रुपया का 10 दिन का घूमना फिरना होगा. मान के चलिए तो 2 लाख तक में हो ही जाएगा. तो
Can I switch off the stream now?
हेलो
Ma'am, can I make it offline now?
Yeah.
just give us 2 minutes only.
2 lakh per head ना भारती.
हाँ